If I could have your attention, I think we're going to convene the session. If you have not already found a spot, please find one. So my name is Russ Pate, and it's a great honor for me to thank you so much for being here this morning. Before I forget, Barbara asked me to mention that we have about 450 people that are engaged with this event, about half of them here in person, and probably a little more than half that are joining us by live stream. So thank you very much for being here. We are here, of course, to celebrate the remarkable life and legacy of Dr. Steve Blair. Later in this introductory session, I'll have some housekeeping details, and I will have some personal comments on Steve and my relationship with him. But first, I'm honored to introduce Dr. Michael Amoritas. Dr. Amoritas has a long association with the University of South Carolina. He is a highly recognized chemical engineer who served as a faculty member and dean of USC's College of Engineering and Computing. He then served as the university's provost for several years. In 2015, he left USC to assume the position of chancellor at the University of Illinois, Chicago. 2 years ago, he returned to USC to become the university's 30th president. Please join me in welcoming Dr. Michael Amoritas.
Good morning. Good morning and welcome to a great academic event that is the perfect way to honor someone who committed his life to academia and to this university. The enthusiastic response to this symposium that we have, and you heard Professor Pate talking about the numbers, is evidence of the great impact that Steve Blair had on his academic field, on the University of South Carolina, and is also evidence of his ongoing legacy. You are going to be his legacy. All the people that they're going to present today, the students, the colleagues, continue to advance his legacy. The participation from everyone who will be present today, either in person, here, or virtually, pay tribute to Steve as a scientist and as an individual. Many of you had the privilege of working closely with him, and without doubt, you knew him better than I did. But what I learned quickly in my own interactions with Steve is that he was unfailingly passionate about his science, passionate about advancing the academic community in which he worked, and passionate about teaching and mentoring the next generation of teachers and scholars. It is likely that there are very few people in this room, or the ones who are watching online, who were not mentored in some way or another by Steve. And I was one of them. I was one of the people that he taught, not in my own field, but Steve, and actually Russ Pate as well, were the two people who taught me what I know about public health. So if I make any mistakes, it's their problem. Right? And in the discussions that we have, always concluded with the same phrase: I know it will cost you, but it's a great opportunity. I think they trained the dean along the same lines. I think they trained Tommy the same way. I admire the energy and the dedication that Steve maintained throughout his entire long career at USC, and we were very fortunate that he devoted the greatest part of his 60-year career to the Arnold School of Public Health and to USC. Worldwide, Steve was also admired as an incredible and prolific researcher, a great scientist and mentor, and an enthusiastic champion for his profession. He was recognized across the country. And I'll give you an example. It was interesting for me. In May of 2019, Bo Fernhal, who was the Dean of the Applied Health Sciences, where kinesiology actually is at the University of Illinois at Chicago, he called me around that time of the year, a couple of weeks before commencement, And he told me, you know, our commencement speaker is someone that is coming from the University of South Carolina. And I wonder if you know him. I said, who are you talking about? Who is going to be the commencement speaker? He said, Steve Blair. I said, not only I know him, everybody knows Steve. And that's what Bo said, actually, after that. And we know also, beyond the country, we know how much he was recognized internationally. And you couldn't miss his regalia during the commencements, that it was completely different than anybody else. And I will always remember them, because I was asking him, what is this that you have there? It looks like an animal that is on top of the regalia. But he immediately would jump in and tell me, this is the honorary degree that I got, and so on. A true academic, by the way. When you see them in commencement and when you see them proud of their regalia, you know that you have true academics that you're dealing with. I hope today will be a celebration of Steve's love of science, his contribution to the advancement of the field, and also a time for collegiate among those who shared his passion and will continue to advance his legacy. This is the celebration that I know he wanted and he would prefer more than anything else. So thank you for being here, and thank you for giving me the opportunity to speak in his memory.
Next, I'm very pleased to introduce Dr. Donna Arnett. Dr. Arnett is a widely recognized genetic epidemiologist who began her career at the School of Public Health at the University of Minnesota. From Minnesota, she transitioned to the University of Alabama, Birmingham, where she served as chair of the Department of Epidemiology. From there, she moved to the University of Kentucky, where she served as dean of the College of Public Health. In 2022, she assumed the position of executive vice president for academic affairs and provost here at USC. I will add that she is a past president of the American Heart Association, which is particularly notable for many in this audience who recognize the leading role that AHA has played in establishing physical activity as a priority in public health. Please welcome Dr. Arnett.
It is my honor to be invited to give a few words today about Dr. Steve Blair. First, I want to echo the tremendous things President Emeritus had to say about Dr. Blair. He was a consummate scholar, an amazing mentor, and as Dr. Emeritus said, mentored many of the people here in this room. But he also mentored people across the world. The first time I met Dr. Blair was when I was a department chair at the University of Alabama at Birmingham, and that was the first time I'd heard him speak. He was a passionate believer and real creator of this movement about exercise and long-lived lives. And he was also, as a past president of the American Heart Association, a great role model. And the reason he was so impactful in his work for the public health is that he always would laugh about himself being the fat little guy who loved to exercise. I don't know how many of you have heard that story, but when he was publicly speaking, he always brought that to life. And why does that matter? In public health, where we're really trying to get people to buy into the benefits of exercise, the images that we often see are these women or men with BMIs of 18, running quickly, and Steve wasn't that. And it made him relatable, and it made him a powerful proponent for exercise for life. And for those reasons, I'm really proud that he served his career here at USC, that he brought the College of Public Health here, the Arnold School, to national and international recognition. And his legacy will continue with all of those that he mentored in this room. You have a great program today, amazing speakers. I thankful again to be able to say a few words in honor of Dr. Stephen Blair. Thank you.
Well, now a few comments from me about Steve while I have the control of the mic. I met Steve and Jane Blair 50 years ago this month when I traveled to Columbia to interview for a faculty position that only existed because Steve had led the effort to include USC in a very large multi-center National Heart, Lung, and Blood Institute funded study called Mr. Fit, which is an acronym for Multiple Risk Factor Intervention Trial. Steve was going to be working primarily on Mr. Fit, and the department needed someone to assume his teaching load, and I was offered and accepted the position. And that initiated what became a very close and long-standing relationship. So I've done, over the last few months, a lot of thinking about my relationship with Steve, as I know many in the room have, and I've concluded that when you have an association with someone that lasts that long and is as close as ours was, there tend to be multiple elements to the relationship. I think that's probably true for the relationship that some of you had with Steve, certainly true for mine. So for me, Steve was certainly a great professional colleague. We sometimes published together. Our research groups were largely non-overlapping and had sort of different foci, but we did come together to do research from time to time. More frequently, we worked together on professional projects that I think generally were aimed at trying to better establish physical activity in the public health system in this country. Everybody's mentioned Steve as a mentor. God knows he was a mentor to me. When I accepted the position to come here, the alternative was postdoc. And I won't say it was a hard decision. I was pretty clear that I should take this job and come here, but I passed on a postdoc. I've said many times over the years, in lieu of that, Steve was my postdoc. I just learned enormously about how to do research, how to manage and conduct a very large trial by being around Steve and his Mr. Fit colleagues. Steve was a friend. That involves sort of the day-to-day mundane kinds of things like sit in one another's office and BS about the news of the day, to do more exciting things, traveling around the world to exotic, interesting places. We operated on that whole continuum. And, and I know many of you feel this way, Steve was a supporter. I cannot count the number of times Steve nominated me for something, encouraged me to pursue something, encouraged other people to invite me to do something. It was just part of his DNA to do that, and he did it for me. I know he did it for many of you. So Steve's passing, leaves a big gap. I have to say I miss him a lot, but I count myself very privileged to have had him as a great friend for so many years. So thank you for giving me a moment to express that. Thank you. Now the housekeeping items. The symposium program includes 6 sessions, most of them featuring 2 speakers. Each will speak for about 20 minutes, and we'll take questions or comments after each of the individual presentations. And then if there's time left in the hour, we'll take discussion for both of the presenters. If you have comments, please use the hand mics that are going to be available around the room. And we're recording and live streaming, so it'll help a lot if you use the mics. We have a 90-minute lunch break, and you're on your own. There are many restaurants. Just go out the front door of the center and keep walking, and you'll run into them. There are documents at the check-in table that will direct you to restaurants. Coffee and water station will be available all day. Restrooms are available to both the right and the left if you go out the door. And our program is being live streamed and will be recorded and made available after the symposium. So those are the housekeeping items I have. We still have about 10 minutes before we're scheduled to start the next session. So we will take a short stretch break here. Don't go too far, and we will reconvene right at 9 o'clock for our first presentation. Thank you all again very much for being here. Thank you. Okay, if you would return to your spot, we're going to start the first session here in a moment. So thanks again for being here. Our first speaker this morning is very well known to this audience. He is Dr. Claude Bouchard, who is the Boyd Professor Emeritus at the Pennington Biomedical Research Center, which is a campus of the Louisiana State University system. He is known across the globe for his research on the genetics of obesity and the genetic basis of the adaptation to increased exercise. Claude and his work have been recognized with awards from an amazing number of prestigious organizations. As an example, he has received honorary doctoral degrees from 7 universities, and I'm proud to say one of those is the University of South Carolina. So this morning we welcome back to USC Dr. Claude Bouchard, who will speak on the life and momentous legacy of Stephen M. Blair. Please welcome Dr. Claude Bouchard. Claude? Oh, no, as long as you want to go.
Good morning. When Russ contacted me about this event, he mentioned to me that I would have about 20 minutes, maybe 30. And the more I worked on this, the more I thought about it, the more time I needed, and I just realized that I could have had 10 more minutes. This turns out to be a larger event that you had anticipated, and that's certainly an extraordinary indication of the immense popularity and respect that Steve had developed around him over the years. His departure leaves an immense void. The death of a loved one leaves us with feelings of emptiness, grief, and sadness. We experience these emotional states upon learning of the death of our dear friend, Professor Stephen Blair. How could this have happened to a person who did so much to prevent chronic diseases and premature death? Why him? Why then? We have no illuminating answers to such existential issues, but nonetheless they remain front and center to the human condition. We are assembled today to celebrate the life and legacy of our dear friend, Stephen Blair. And I will offer some thoughts on his life, his family, his scientific contribution, his appreciation for the physical wonders of our planet, and the worldly pleasures of life. First, a word about his family. In the course of my frequent visit to Dallas, I had the pleasure of meeting daughter Anne Blair and son, now deceased, Max Blair. I had over the years multiple interactions with Max and enjoyed discussing with him all kinds of esoteric topics. Even though I had less interactions with Anne, I know that Steve was extremely proud of her career and what she had accomplished. She was always a great joy to Steve and to Jane as well. Jane was the love of Steve's life. As many of us can testify, he was very proud of the accomplishment of Dr. Jane Blair. She created all kinds of excitement in their life through a variety of social, civic, and outdoor pursuits. Jane was an engaged and wonderful travel companion with whom Steve enjoyed exploring the world, and they did. So Steve's journey began in Kansas. He grew up on a farm, northwest Kansas, the son of Wilma and Bernard Blair. His interest in sports and athletics led him to undergraduate training in physical education and biology at Kansas Wesleyan University, where he obtained a bachelor's degree in physical education in 1962. He developed an interest in the application of science in coaching and physical education. His football coach at Wesleyan University encouraged him to enroll in the graduate program and recommended Indiana University, mainly because Dr. James Conselman was there, and he was one of the early practitioners using science to modify training and try to improve performance. But his time in Bloomington and Palo Alto were really determinant for his career. So Steve moved to Bloomington, Indiana, and completed a master's degree in 1965. He went on to pursue doctoral studies also at Indiana University, and was awarded a physical education doctorate in 1968. And then he joined, for the first time, the faculty at the University of South Carolina as an instructor. Here at USC, he founded and directed the Human Performance Laboratory from 68 to 78. He climbed the professorial ranks and was professor in the School of Public Health by the time he went to Stanford University to pursue postdoctoral work in epidemiology and preventive cardiology with Ralph Paffenbarger and Jeremy Morris as an advisor, distant advisor, and William Bill Haskell and others for 2 years, 78 to 1980. These years were really critical for the career that Steve embraced and pursued with so much energy in the field of epidemiology of physical activity. A word about his impactful years at the Dallas Cooper Institute. In 1980, Steve took a big step. While remaining on the faculty here at USC, he took a part-time position as the Director of Epidemiology and Clinical Applications at the Cooper Institute for Aerobic Research in Dallas. Soon thereafter, he was appointed Director of Research and became a full-time scientist there. He was also given the responsibility of leading the Aerobic Center Longitudinal Study, or ACLS, as it was known. In 2002, he was appointed as the President and CEO of the Cooper Institute. And he left in 2006 and returned to the School of Public Health here on this campus. At the invitation of Steve, some of us served on a board of external advisors over a 15-year period. Frequent trips to Dallas brought us closer to Steve and Jane. And Steve made it a productive and pleasant experience to serve on his board, which included luminaries such as Lester Breslau, Bill Haskell, Norm Kaplan, Aimin Lee, Qiang Liu, and a few others. The highly visible publications coming out of the Institute were responsible for the stellar reputation that it enjoyed when Steve was its leader. The Cooper Institute became, under his leadership, a physical activity epidemiology powerhouse. Interestingly, this was not appreciated as much as it should have been by the leadership of the Cooper Center. A word now about his global reach from his professional home here at USC. In 2006, Steve returned to his academic roots when he rejoined the School of Public Health at the University of South Carolina. He enjoyed being back in his beloved academic home and was proud of the School of Public Health accomplishments over the years. He continued to publish extensively and mentor junior faculty and students. There are many scientists in the School of Public Health with stellar national and international reputations. However, Steve was one of a kind, and I'm confident that Dean Chandler agrees with my assessment. His name recognition in the world of exercise and physical activity is unsurpassed around the world, and he brought a lot of attention to the university. Now a word about his legacy. Steve was not only a productive scholar, but also a very influential one. The hallmark of a scientist is that his or her science changes the current, ongoing, accepted research paradigm of a field. And this shift is widely accepted by peers. Well, Steve has made contributions of this caliber over the last 40 years or so. Let me briefly introduce two of them, which have changed, in my judgment, how we think and formulate hypotheses about physical activity, fitness, and health. First, he demonstrated that a moderate level of cardiorespiratory fitness, CRF, was associated with a lower risk of dying from all causes, or from cardiovascular disease or cancer. His JAMA 1989 paper with collaborators Cole, Paffenbarger, Clark, Cooper, and Gibbons, was a game changer. They showed that a moderate level of CRF reduced all-cause mortality by more than 50% in men. 50%. The pattern was less clear in women at that time, but it turns out that it was largely due to the smaller sample size, as was shown in later studies, both from the same cohort and others around the world. Interestingly, and that is for people who know Steve well, you will recognize that. Interestingly, for more than a decade, Steve explained this relationship as resulting from the fact that CRF was a better indicator of the level of physical activity compared to subjectively reported physical activity level. But later, after a lot of discussions and heated discussions, he recognized that CRF per se was a powerful indicator of health and a major predictor of life expectancy. This powerful relation between CRF and death rates was confirmed in diabetics, but also in other cohorts affected by morbidities or conditions such as hypercholesterolemia, elevated blood pressure, or overweight and obesity. But in diabetes, in this landmark paper published by Tim Church, Steve, and other colleagues in 2005 in the Archives of Internal Medicine, he showed that the relationship between CRF and death rates remained as clear as it was in non-infected people, in diabetics. Steve made several other lasting contributions, but I will highlight only another one. He reported in a paper published in JAMA in 1995 that changing one's level of CRF over the preceding 5 years had a significant impact on survival. Those who went from an unfit to a fit category reduced their mortality rate by more than 40% compared to those who were unfit and remained unfit through the follow-up period. So these two contributions of Steve's and his colleagues have had a lasting impact on physical activity epidemiology and on the global health research agenda. They are part of his scientific legacy and are still influencing our thinking years later. A highly cited scientist typically enjoys high name recognition and is highly influential in his or her field of expertise. In this regard, Steve's numbers are impressive. In the broad field of medicine, as of late March, he has more than 172,000 citations, with an H index of 178. He is ranked 139 in the United States and 209 worldwide among about 69,000 scientists in biomedical research. That's a powerful and enviable science legacy. Moreover, when data across all disciplines and all scientific areas are combined, that means a pool of more than 1 million scientists, of which about 250,000 have published at least 10 papers. Steve ranks 439 in the world for citation performance, from engineering to the humanities to physiopathology. This metric alone is worth 1,000 words regarding his legacy. In addition to his scientific pursuits, Steve had a strong interest in the promotion of physical activity in various settings. His contributions were recognized also here in a variety of ways. He has been appointed a fellow of 7 scientific societies. He received the U.S. Surgeon General's Medallion for his many contributions to the field, including being the senior editor on the report of the Surgeon General on Physical Activity and Health. The number of recognitions he received from states and national organizations is long and rich. His many contributions were also recognized by agencies and academic institutions from around the world, a testament to his profound international impact. Steve was also the recipient of 4 doctorates honoris causa. Now a word about Steve, the Epicurean. A less visible dimension of his personality revealed itself when you engaged him in literature, music, painting, and history in general. This side of Steve was particularly evident when you had the chance of traveling abroad with him. He was curious not only about the people he met, but also about historical background, life circumstances, and cultural record. Visiting museum, concert hall, symphony performance was high on his itinerary. Steve was also a devoted Epicurean, with a taste for fine foods and fine drinks. I don't think that he learned that from Epicurus, the Greek philosopher. Rather, I believe that this was his natural inclination to pursue the pleasures of gastronomy and high-quality libations. And here, refined wines and Scotch whiskies had his preference. I have had the pleasure of experiencing this side of Steve and of Jane when traveling to speak at conferences or simply when we took vacations together. The great evenings we shared and the fine restaurants we visited around the world are lasting souvenirs. One of these trips, a truly memorable one, involved Steve, Jim Skinner, and I in 1997. It was a mix of business and pleasure as we drove in the southwest region of Germany and in France, from Frankfurt to the Black Forest and Freiburg and Breisgau, with a stop in Strasbourg along the way. Over a period of about a week, Steve explored every day, the regional nuances of foie gras, with well-paired beverages. He was, and we were, having a grand time. Another trip, another example, involved Steve and Jane with my wife Monique and I. We took advantage of being both invited to speak at the pre-Olympic scientific meeting in London in 2012, organized by the British Physiological Society, to add a side trip to Scotland. We targeted several historical sites and a few distilleries, including the Hydradur distillery, the smallest one in the business, established in 1825. For about 1 week, we indulged in excellent food and tasted some pretty unique beverages. Steve was at his best in this environment. What a superb experience it was. Finally, a word about how great a human being he was. Steve led a full life. He was more active physically, more engaged intellectually, and more connected socially than most people of his generation. At the same time, he was fully devoted to his family. He explored the world a lot more than most. Just ask Marjorie at Rudy Steele Travel in Dallas, or check his frequent flyer programs at American Airlines or Delta Airlines. Steve was a caring and devoted mentor to students and young faculty alike. Through his research, he changed the way we think about physical activity, fitness, and health. He was the most influential scientist in the world in the field of physical activity epidemiology, and he has left us with an impressive legacy. He has left a strong imprint on public health. His life mission was to be a devoted servant of the common good. He's gone, but his momentous legacy remains with us all. As they say in German, war ein Mensch. He was truly a fine and very special human being. He is greatly missed, but will not be forgotten. Thank you.
I think we have time for a few comments or questions. If you would, please use the floor mic if you can find one. I think we've got folks that are prepared to move around the room and bring you a mic. So we do have a few minutes here for comments or questions. Yes, Jim?
As has been mentioned quite a few times, Steve was good at mentoring people. And one thing that a lot of people don't know about Steve, he and I used to meet together at the program committee meeting of the American College of Sports Medicine, and we would always go the night before and have dinner, in which he would say, you know, Jim, can you imagine that this boy from rural Kansas and you from a little town in Mississippi have the things we've seen, the things we've done, and how much so many people have helped us. And he said, what we have to do is return that. So every time I met Steve for dinner, I had to have at least one name of someone we had to help. And that's who Steve was. And he always had one, two, at least. But I had to have at least one. And we would sit and talk about how can we promote that person to be a member of the college or go for fellowship or whatever it was. We figured someone could use our help, and we were in a position to do it, and that's who he was. So I just wanted you to know that.
On behalf of the family, I would like to say thank you. It was Steve's dream to have a symposium, a scientific symposium, and for Claude to give a talk. And Claude is so wonderful, and Russ organizing this, and Barbara helping him, and May, and all the people at the university that supported this. I know he is appreciative, and I and the whole family are appreciative. Thank you all so much. And thank you, everyone who has come. I hope you learn some things and are inspired to go on and move the science forward. Thank you.
Somewhere in the back. You got someone in the back?
Hello, my name is Pat McBride. I first met Steve Blair. I was a physician up at what is now Primus, I don't know what it is, but it was Richland Memorial Hospital when I was there. And Steve, and I want to give some credit to Russ Pate because they were joined at the hip when I was there. And I was a struggling resident up at the hospital up there, and one day Russ Pate and Steve Blair showed up at the hospital and convinced me that I should come down to the University of South Carolina and get my master's in public health. And Steve Blair and Russ Pate changed my life, and so did Jane and Ann, so I want to thank you very much. So I went down and I was in this class with this guy, Steve Blair, who I didn't know anything about. So I looked him up and I found out he was the world's expert on exercise, which I was pretty interested in, but I didn't know that meant that you had to go running every day and do 8 miles. I was running, but I wasn't running 8 miles, and I didn't know that Russ Pate was one of the best runners in the world. So. And I didn't know this little short guy could keep up with him, so that was a challenge. And then I asked a question in Steve Blair's class because I was interested, and then he said, would you like to do some research with me? And then he stuck me in the library and he said, let's look up something about cholesterol, and that became the basis of the rest of my career. And he had me start doing research on exercise and cholesterol, which nobody in the world was really looking at HDL and cholesterol. And that was his brain. He would constantly ask questions. And then he took a guy that was 1 year out of medical school, and he'd say, come with me to meet with Johnson & Johnson. We're going to do a health promotion project for this entire company. How would you like to work with me on that? I mean, who does that? You know, who does that? And you know, then I started doing this with other companies with him. And, you know, I was 25 years old or something like that. So I know that he did that for people all over this room and all over the world, because I met people from all over the world. He'd introduce me to these people. And I was just not even capable to do that, but he elevated my career, and I became the dean of a medical school. And that's all because of that guy right up there. So I just want to say thank you to him, and for everything he did for all of us, and especially for me. So thank you to him and Russ. Thank you so much.
Good morning. I'm Susan Jurgen. I said this at Southeast ACSM, so if you were there, it's a little repetitive, but I was Steve's office neighbor the last 6 years. He was always checking on me, and I have to admit, at first I misunderstood and thought that he thought I wasn't coming in enough. But then I did come to realize that he just really cared about how I was doing, and he would stop by and ask how work was going, asking how my children were. But I really connected with what Claude talked about in terms of the science and the culture. So he would bring me his first research on hydration, which is my area, in terms of connecting with me, and that meant a lot. But then he would also bring me all of the Koger Center flyers and ask me to make sure that I knew about a new Broadway show that was coming into town, or he wanted me to know that there was some other kind of cultural event and wanted to make sure I knew about it. So I really did feel cared about in terms of being a well-rounded person, not just about the science. And then lastly, Steve asked me to write a commentary having to do with children's unexplained death. But it really started to bring me from my world of sports medicine into public health, and really like bringing what I do into that realm and making me not feel so like in my little sports medicine world, but really understanding how we were a part of the bigger picture of public health. And so I really just am very grateful for the time that I had of being his office neighbor for 6 years. Thank you.
Hi, everyone. I'm Mark Sarzinski. I'm an associate professor here. I also told this story at Southeast ACSM, so I apologize, but I am an aspiring stand-up comedian when I retire, so this is the biggest audience I'll get. And I think since the mood has been, I'm sorry, Claude. I mean, I'll continue your legacy, don't worry. I am a mentee of Claude, so I've had the wonderful opportunity to interact with Steve way early in my career. But the story I want to tell is when I was being recruited here, you might take an unofficial second visit. My wife wanted to come with me, make sure to check out Columbia. And Steve and Larry Durstein helped set up, like a whole series of meetings for us. I was going to meet people, and we were going to end the day with dinner with Steve and Jane. And so we show up at 8 or 9 in the morning. I'm dressed like this. My wife is dressed like she is now, a very nice dress. Steve had made a reservation for us at Saluta's, a white tablecloth, nice place. Steve's kind of quirky. He looked at my wife and said, nope, we can't go to Saluta's. We're going to Mr. Bunky's. And if you don't know about Mr. Bunky's, it's like 20 miles north. It is a combination gas station, meat market, antique shop, everything, and has all-you-can-eat fried gizzards. So we enjoyed a wonderful dinner of all-you-can-eat fried gizzards with Steve and Jane, and then we drove back to their house for a nightcap where Steve busted out a bottle of Johnny Walker Blue for us. That's one of the most expensive scotches out there. It was amazing. He busted out the horse collar for us to put on. And like I said, again, I am 100% confident we are the only 4 people in the history of the world that went to Mr. Bunky's and had Johnny Walker Blue Scotch in the same night. And it was amazing. Thanks for everything. Enjoy the day.
Well, if there are no more, please join me in thanking Claude for a wonderful presentation. And we're going to try to stay on schedule, so we have a little break here before 10 o'clock when our next session will start. Thank you. You can have a short break.
Okay, we're going to get started here in 2 minutes. So if people could make their way to their seat now, that would be great. I don't think they're listening to you, John. Yeah. Okay, I think we can go ahead and get started. It is such a privilege to be here moderating this session in honor of Dr. Blair and his tremendous legacy and impact. I met Steve and Jane in Dallas. They warmly invited me to their home, and Steve then, when he came back to South Carolina, I was so excited and so happy that he arrived. I do have a question for Jane, though, and Anne, and that is, did he ever sleep? Because I hear about how much he's impacted and touched people's lives, and how well-rounded he was in his travels, and it's truly amazing. So I'm going to go ahead and, as Russ kind of outlined, we will have 2 speakers in this session, and I'll introduce each of them. They'll have about 20 minutes, and then we'll open it up for questions. So first, Dr. John Jakisik is a research professor at the University of Kansas Medical Center in the Department of Internal Medicine. His interdisciplinary research program examines lifestyle approaches to the prevention and treatment of chronic health conditions, with a particular focus on the role of physical activity and sedentary behavior. Central to this research has been a focus on interventions for weight loss and weight maintenance. He's served on numerous national committees focused on obesity, physical activity, and other chronic conditions, which included his appointment to the 2018 Physical Activity Guidelines Scientific Advisory Committee. Dr. Jakisik has been influential in elevating physical activity as a lifestyle factor for prevention and treatment of obesity. So please join me in welcoming Dr. Jakisik to the podium.
Oh, I can only tell you how much of an honor it is to be here on this day. This is just amazing. And I thought this is going to be easy, but just a baseball analogy. Normally the leadoff batter gets a single. The second person that gets to talk has to just bunt them over, and then the cleanup hitter, the number 3 hitter, will knock them home. And unfortunately, Dr. Bouchard hit a home run, so now I actually have to bat, I guess. But it's a real honor to be here. And I put this disclosure up not because it matters, but this, I think it's been talked about this morning. I'm an advisor for Wonder Health, and one of Steve's colleagues, Tim Church, is heavily involved and very influential at Wonder Health. And it was because of the relationship that Steve helped to build between myself and Dr. Church over the years that I've actually been given this opportunity. And those are the kind of relationships that go far beyond getting a name on a paper and things like that. Has been pointed out so many times. Steve was a relationship builder in so many ways for so many of us that when you look back, you're like, wow, I would have never have had that opportunity. I'm extremely honored to be here today because in 2018, I was awarded this award through the American Heart Association in Steve's name. And I was honored and humbled when I was notified that I was getting that award. And so I cherish this moment today, and I cherish this award because it meant so much to me. But just a funny story related to Steve. In 2019, I was awarded the Citation Award by the American College of Sports Medicine, and that's kind of a big thing. And it was in Orlando, Florida, and I remember Steve going up an escalator, actually walking up the escalator, of course. He wouldn't have us standing on that escalator, so I sprinted and got behind him just to say hello. And he said, hey, congratulations on your award. We've actually knocked off all the really good people that deserve this, so now we're in the second tier, so I'm glad you've made it. But that was Steve's, sense of humor at the same time, and I know he didn't really, well, I hope he didn't really mean that. But Steve was that kind of guy. He always was quick-witted, but it was also always just so engaging. So I have a few things around just, some work that we're doing and some things that Steve has thought has influenced for me in the work that we're doing, have been doing, and currently doing. But, a lot of the work that I do is in this area of obesity. And, I know in the introduction I talked a lot about weight loss and weight loss maintenance, but I've really changed my thinking around this over the last so many years. Because, weight loss is something that changes. Obesity is a chronic health condition that's complex, and weight is only one component of that chronic condition. And so it's really got me thinking and changing my mentality around the work that I do and the work that I think needs to be done, in this space. And, I look back at the early part of my career and I say, we've had these lifestyle interventions. That was, really important to me. We were working on eating behavior change and dietary change. And, I was fortunate enough to jump in and get the physical activity things going and had some influence in that space. And, that's going to change body weight. That's going to change adiposity. It's going to change body composition. And it was kind of a simple way of thinking about it. Calories in, calories out. It's easy. And then what we realized is that it's not so easy. And this is not, by any means, comprehensive. But these things go in multiple directions. They're bi-directional. You change one thing, something else changes. You didn't even expect it to change. You got to throw the physiology on top of it. You got to throw the biology on top of it, the genetics, the environment. All these things are influencing this. And then you start to realize how variable the responses are and aren't. And so you really realize that this is very, very influential. And as I look at what this is, physical activity is a component, but a critically important component that influences so many of these other factors. And I think that that's kind of where I think we're moving with the field. And Steve was very influential in helping me to move into this way of thinking like it's not just about the weight. It's well beyond the weight, and there's so many factors that kind of influence that. But as we think about some thoughts around obesity treatment and things, we talk a lot about the use of the BMI and the use of the waist circumference, right, Bob? We talk about this. And, the reality is that these are just simple clinical indicators. Not everybody that has a higher BMI, not everybody that has a higher waist circumference is going to have, certain chronic conditions. There's variability in what we see. There's variability in this response. There's variability, and we're learning more and more about, the cut point, saying anybody above or below this number, that it's a continuum. It's not a dichotomous variable in so many ways. And we really need to think about the overall health impact in so many ways. And I think as Steve talked about that, we really had to think more broadly than it just being a number of BMI and waist circumference. And so, Steve and others have done work. I just pulled out, one study. I had to highlight Larry Durstein in some positive way, so his name's on this. So, right, Dr. Durstein, I know I saw you out there. There he is. But this showed, that if you compare people with a higher BMI or a lower BMI, that there's a difference in outcomes and all-cause mortality, and you could overlay other chronic conditions, obviously, on top of this. But as we all know, the thing that influenced so many of us, and I think that it influenced our space as well, is even in the context or even in the presence of an elevated body weight, an elevated adiposity, an elevated waist circumference, that when you take someone and you have that and they become more physically active or they become more physically fit, that there's a lower risk of all-cause mortality and many, many other factors. And Steve termed that, and we've all kind of bought into this idea that it's the fitness-fatness phenomenon. And that has, when he first started talking about that, we're like, oh, what's he talking about? And that thing has resonated and has stayed with us for decades at this point in terms of us thinking about this. And this has been so just influential about it's more than just one thing. It's more than just about the weight. And so I think the one thing that, we're at a transition point now with the treatment of obesity and how we think about it. And there's so many now medically effective treatments for obesity. We have bariatric metabolic surgery. We now have medications that are coming out that are more and more and more effective. But I put this up here because at the heart of it all, we still have lifestyle. Lifestyle is still a key component of this. And if you think about in that lifestyle, physical activity is just one of three, what I'll call three pillars, that interact with the other two pillars of lifestyle. But I think that it's also critically important that we kind of keep staying in the game. The one thing that I was at the ACSM Health and Fitness Summit in February, and I gave a talk on how physical activity fits with anti-obesity medications, and I thought I was going to get attacked for a moment because it's like, what are you doing promoting this? Well, we have medications for hypertension. We have medications for hyperlipidemia. We have medications for all these other things. We can have medications to help with the treatment of obesity, not weight loss, but the treatment of obesity. And how do we as a profession who are passionate about physical activity fit into that medical treatment model? And I think that that's our opportunity as a profession to take us to the next level. But at the heart of this all, and this is important, is when you pull out the insert of the packaging of these new pharmacotherapy agents, it doesn't say lifestyle is an adjunct to pharmacotherapy. It says this should be used as an adjunct to lifestyle that includes healthy diet, healthy eating, and physical activity. And we have to remember that's where we need to, that's our space. That's what we need to be promoting. And I think we have great opportunity here if we embrace it. But the other thing that's become very, very important in my way of thinking about this is this young man set the world record for the marathon in October of 2023 in Chicago. And he ran the marathon in 2 hours and 35 seconds. And unfortunately, he was killed in a tragic auto accident in January, February of this year in his home country of Kenya. And you look at that and you say, wow, that's a fast run. And we have some pretty active people in this room. And I just want you to think, this guy trained a lot, had the best nutrition people around him, the best trainers around him, the environment, all the things lined up. And I ask all of you in this room, how many of you think that if you could train like this young man, if you had the nutrition support, the environmental support, all those kind of pieces around you, could run a 2 hour and 35 second marathon? And we all know why, right? We all know there's a training component. We all know that there's this environmental component. But the thing that separates who's going to run the 2 hour and 35 second marathon and those who aren't, even with the same training, is the biology, the physiology, the genetics, those other factors that come into play. And I think that if we can put it, and that's a sports performance issue, and we know that. But let's think about that also in the same light of how we think about the causes of obesity. It's not just about lifestyle. It's not just about the environment. You overlay those things on top of a genetic, physiological, and biological underpinning, and you realize how it's more difficult for some and less difficult for others. Some respond and some don't, right? And I think we learn this, and this is very helpful in our way of thinking, my way of thinking about it. So these new treatment medications that are out there are going after things like the biology and physiology, and that's going to help to influence this behavior. And in many ways, this is, I think this is important for us to think about, because what it's basically doing is taking back that analogy of that young man who held the record in the marathon, the world record in the marathon. It's leveling the playing field so that when we put the behavior on top, when we put the activity on top, when we put the eating behavior on top, we put that environment on top of that, or at the foundation of that, we level the playing field for people whose biology and physiology is working against them in some ways. And I think that's really important for us to understand. And we see that just with standard physical activity and exercise trials, right, Greg? We've seen this variability. You give two people the exact same treatment and you get variability. Dr. Bouchard did classic work in this space. And so we should understand that as we overlay these treatments and prevention strategies, we're going to get variability, and how can we help to level the playing field in some ways? And I think this is where we are with this space right now. And these things are becoming more and more effective. But it's not about more weight loss. It's about better obesity treatment. And you start to look at this, and the first thing that I hear is, well, if people are losing this much weight with these new medications, why do we need to worry about lifestyle? Why do we need to worry about exercise? It's important that we worry about those things. In fact, it's even more important now that we worry about those things. Because as people come off of these medications, which I don't think they should, but access is a problem right now. It's a problem to get people to stay on them. Some people self-select off. They're becoming expensive. These people what do they do when they come off? If the medication's controlling it all, but there's no foundation from a lifestyle perspective to fall back on, we know what's going to happen when they come off these medications. The same thing that would happen if you start an exercise program and stop, right? So we have an opportunity here. And so I like to think about where we are with our space and why physical activity is important, even this dynamic, what I call contemporary era of obesity treatment. And so we have these treatments now that are mostly affecting energy intake. And we know that when that happens, it can affect body composition, body weight, visceral adiposity. You start to name it. It's affecting that part of the balance equation. And we know that when that happens and we can reduce those things, that we're going to reduce adiposity-related chronic conditions, things that are related. And when we do that, we have an improvement in health and well-being. And this, and so we can think about it from this small lens. But we also know that when we do this, that there's some changes in lean body mass. And some of those, people get worried about that, and we should get worried about that a little bit. But a person that weighs 150 pounds versus a person that weighs 250 pounds have different amounts of lean body mass and muscle mass on their bodies, right? Some of this is compensatory, and some of it is maybe problematic. But we need to be worried about that. But what about lifestyle? Where does that fit in? Where does exercise, physical activity fit in? And I only named 2 different types of activity. I have a comment about that before I end, about multiple modes of activity. But when you think about it, we know that that will affect these things. We also know that there's a better chance that it's either going to preserve or minimize the loss of lean tissue while a person is losing weight and changing their diet. And that those are going to have different effects on health outcomes than what's probably happening with adiposity. And more importantly, I think we've spent so much time worried about the volume of tissue, particularly when it comes to lean tissue and muscle, that I think we've lost sight that there's this quality issue that goes into it. There's a quality issue that's critically important. 2 people with the same amount of muscle, one has better muscle quality than the other, that's going to have a different outcome. And activity helps with muscle quality across the age span, across the health status. And that's going to also help us to reduce what I'll call sarcopenic-related conditions. And more importantly, and as Steve and others, and Steve was at the forefront of this, remind us all the time, when you take weight and body composition out of the equation, activity and exercise still have independent effects outside of that. So if we're really thinking about the holistic health of a patient, we need all of this. Not one of these components, but all of these components. And I think that this is important for us to remember and think about. And I just came back from giving a talk yesterday and talking to some clinicians, and it seemed like for the first time, some of this is the first time they've heard this, and they realize how important this is. So what are some important implications? we can think about all these things. Should we try to do interventions to maximize weight loss? Should we focus on clinically meaningful and sustainable weight loss? Or should we think about interventions that are going to help us with body weight management and obesity that also cause physiological adaptations that are going to improve health in a different way? And I think that that's what we need to be focusing on. And at the heart of that, the one behavior we know that can improve the physiology of the body is physical activity and exercise. This can modify so many biological processes. This is the pill. This is the magic pill that can change physiology in ways others can't. And I think this is where our angle is to make sure that activity remains relevant. So just a couple of final comments in the minute or two I have left. The one thing that's a little bit concerning to me in our profession is that I constantly am hearing the debate over which mode of activity is best. What mode of activity is best? And I think that this is detrimental to the profession. Because I look at all of these different, and this isn't all of them, by no means is this all of them. But every one of these things are important. Every one of them. And they're all important for very different reasons. If I want to improve cardiorespiratory fitness, I'm going to focus on aerobic cardiovascular exercise. If I want to improve muscular strength, I need to focus on strengthening exercises. If I want to improve balance, I want to do balance training exercises. All of these are critically important. And I think it's a detriment to the profession for us to be debating which one is, quote unquote, the best. The answer to that is very simple. The best one is depending on what outcome you want. But don't we want all the outcomes? Don't we want a person to have better cardiorespiratory fitness, strength, balance, function, mental health benefits? Don't we want all of that? Which means that instead of saying everybody should do 5 days of cardio a week, maybe they need to do a little cardio, little resistance training, a little balance training, a little bit of all these things. Because that's going to give us more parameters that are improving, but not all of them have to improve to a maximum. And when we think about holistic health, I think that's where we need to be. So I think, Leanna, you heard me give this little spiel. I don't know if any of you are a Kenny Chesney fan, but a little bit here and there. But he has the song Get Along. And this song is basically, this is kind of part of that song where he talks about, all these different things. We all have to get along. We have a long, long way to go. We're scared to live. We're scared to die. We ain't perfect, but we try. Get along while we can. Always give love the upper hand. Paint a wall, learn to dance, call your mom, buy a boat, drink a beer, sing a song, make a friend. Can't we all just get along? And I think in the exercise physical activity profession, we can debate with one another, but I think we have to get along and understand that all these things are critically important. We're stronger collectively than we are separately in terms of what we need to be doing. And so I've changed the lyrics a little bit. I don't know if Kenny likes this or not, but I haven't asked him. So the first part, I just leave the same. And I say, this should be our mantra. Take a walk, do a squat, stand a while, get some sleep, breathe a bit, do a dance, make a friend, call your mom. Can't we all just get along? I think we all would agree that all of those things are important for health and well-being and holistic health of patients. And as I point this out as I come to an end, a couple things I want to point out. Always give love the upper hand. We can agree to disagree, but we can also agree that activity is good no matter what kind you do. Never forget to call your mom, right? Never forget that. And when you don't have your mom anymore, you realize. So call your mom and call your dad. And let's all just get along. And in honor of Steve, I don't want to not say this, but let's all have a beer at the same time. And I think Steve would appreciate let's all have a beer. So with that, I'll end and just say, in the space of obesity, let's recommend exercise, but not focus on weight loss. Let's focus on health and well-being of patients. And to do that, we need this collective, holistic treatment approach for patients. And we have to remember that one of the foundational behaviors is physical activity, and hopefully we can help to promote that and in the spirit of what we've all are so passionate about. So with that, I would just like to end and thank the family and thank Ross and thank everybody for inviting me. It's a great honor to be here today. Thank you so much.
We have a little bit of time for questions, so I'll open it up. And just a reminder, if you can go put up your hand for a microphone so that those viewing online can hear you. So we have a couple questions, lots of questions.
Dr. Skinner has a question.
Just a comment to you, John.
Thanks.
That's another home run.
Thank you. I appreciate that.
Thank you very much. Wonderful talk. I have a question about set point and the effect, because we know that set point also affects your ability or your desire to exercise. And my sense of it is it's whatever exercise you're willing to do that may help, but do we know if any of those exercises that may have the possibility of helping us keep set point down?
I don't think that we have that level of evidence. Others may suggest differently, but we do know that at least in some modes of activity and some intensities of activity, that it might have an effect on better or worsening of hunger and satiety responses and things. But I think the one thing that, Lee Kaplan, a colleague of ours who's a physician out of Dartmouth and Harvard, he gives an interesting analogy around the set point. And that is, when it comes to body weight regulation and folks who are a bit compromised when it comes to biology, physiology, genetics, if you take a life preserver, we all know what a life preserver looks like, and you are in a pool and you just try to take it and push it down in the water. You know how hard that is. And it always wants to push it back up. And if you let go, it just pops right back up. And that's an analogy I like to think about when it comes to how the biology works against us sometimes. That if we're trying to push something down that is resisting from the other side. And so we need to find a way to kind of level that field a little bit to help the physiology along a little bit and kind of even, that's why I call it evening the playing field a little bit. So I think that we can do this, but I think the one thing about these current, particularly pharmacotherapy opportunities that we have, it's giving us a new opportunity. So from a food perspective, what you hear patients saying is, it's reducing the food noise. I don't think about food all the time. So instead of focusing on reducing calories, the medications are helping with that. I can now focus on diet quality. And if I'm not worried about energy expenditure, maximizing energy expenditure from an exercise perspective to reduce weight because the medications are helping to lower the weight, I can now focus on variety of activity, other kinds of activity that are not always the highest energy burning, but have other health benefits beyond the energy burn. So I think we have opportunities here that are different, and I think we should embrace those new opportunities. So.
Thank you. And just one little plug for that piece in there where you were showing that all the different, all the lifestyle, all the stuff that needs to be done in order to be successful. About the only thing covered in insurance is or the surgery things. There's a bill in Congress right now. We're almost to a place of getting it onto the floor. It's called TROA, the Treat and Reduce Obesity Act. Contact your legislators and let them know that they should vote for that.
I agree. Thank you. Dr. Skinner. Oh, got to turn it on.
You mentioned that what the best exercise would be is depending on what you want. When people ask me what's the best exercise program, I say it's what you enjoy and what you will do.
Yep.
Because you're trying to change a lifestyle, and I've had people say, don't tell me to run, don't tell me to do this, but if I get on a tennis court and I can beat that other guy, that's what I'll do. And so I said, you got to find what you like and do it.
Yeah, I agree. It's about what you'll do, what fits into your lifestyle, what you're able to do, and take those opportunities where you find them. And if it's about performance training, that's a whole other story. But this isn't about performance. This is about health and well-being, and we have to separate that. And I think that we need our practitioner colleagues in the exercise space to realize that while they enjoy X, Y, or Z exercise, that's not what everybody else enjoys, and that's not what everybody else is going to do. So I appreciate your comment because it's right on point.
Let's go here, and then we'll go to Dr.
Okay.
Hi, this is excellent work. Thank you so much.
Thanks.
I was wondering if you happen to know if there's any data on variability in exercise regimen and adherence to an exercise regimen. Is there maybe, because we talk about like at our med school, like a fit prescription, and I'm wondering if maybe there's any evidence on like variability in that fit prescription, like maybe one day yoga, one day, and whether or not that impacts adherence?
I don't know if there's a specific thing. I think the challenge in our space right now is that you have studies that are supervised exercise, and we're kind of forcing people into a model. So that's going to affect the variability. And then you have so then we kind of do the public health look at it, and so it's a little bit harder. But I think what you're talking about is kind of what I'm a little bit advocating for, particularly as individuals get older. It might be helpful to say, okay, the guidelines say 5 days a week or whatever, and 2 days in this and so on. But maybe we need a day or two a week and making sure you go for a brisk walk, a day or two of muscle strengthening activity, every day do a little balance. So a little bit of all of that might be really helpful. So I think we need new models like you're talking about that could really inform that. So
Thank you so much.
Thanks.
And I'll make this real quick. 3 comments. One is, it's always nice for someone to say nice things about you. Thank you, John. I appreciate it. The second thing is, you talked about, years ago I worked with Paul Thompson, and we talked about how exercise and drug therapy went well together. And you said that same thing today, conjunctive exercise programming with lipid disorders. The third thing is you bring back the idea that somehow got lost, comprehensive rehabilitation programs. And we talked about that 45 years ago in cardiac rehab programs. I don't hear much about that anymore. Thank you so very much for bringing that back.
Yeah, you're welcome. I appreciate that, Larry, and I think that's where we're at. It's not one, it's all of this stuff is important. So it's about us repositioning physical activity in a meaningful way. So thank you all. Thank you all so much. This is wonderful.
Great, thank you, John. Next, I'm pleased to introduce Dr. Robert Ross. He's currently a professor in the School of Kinesiology and Health Studies and the Department of Medicine at Queen's University. He is the director of the Lifestyle Cardiometabolic Research Unit at Queen's, where his research focuses on the development of strategies to manage lifestyle-based disease. He's a fellow in the American College of Sports Medicine, the American Heart Association, and he's a recipient of the Citation Award from ACSM. So please join me in welcoming Dr. Ross.
Well, good morning, everyone. First, thank you to Russ, Jane, and the organizing committee for including me as part of this symposium. It's a real honor for me to share the podium with so many illustrious speakers. In fact, it's intimidating. I have a difficult topic to share with you over the next 20 minutes or so, and I'd like to say that it's the organizing committee that gave me the topic. But it's not. We were given a choice to take anything we wanted, and have you ever been in that situation where you're starting to develop your talk and say, what was I thinking that I could do that in 15 minutes? But I will do my very best. A few years ago, the American Heart Association approached me and asked me if I would put together a team of people to put together a statement on the importance of cardiorespiratory fitness. So, of course, comes as no surprise to you. The first person I spoke to was Steve, and Steve agreed. And I was very fortunate, again, to work with Steve. We put together the speakers, and we put together this statement that I think made it about as clear as can be, that cardiorespiratory fitness should be a vital sign across all healthcare settings. The evidence is rich, and it's undisputable. So that's an established observation. The second established observation is known to everybody in this room, that if you do physical activity according to the guidelines, you are going to receive benefit across a wide range of health outcomes. And let there be no mistake that one of those outcomes is cardiorespiratory fitness. So shown here, if you do the minimal guideline, or at least the target, we seek to go 150 minutes of moderate vigorous physical activity that Russ Payton colleagues dictated in their seminal paper back in 1995. You're going to improve cardiorespiratory fitness. And if you do a little more, shown here, at about the same intensity, but a few more minutes per week, you will improve that more. These are established observations. There's no dispute on this, and I'm certainly not here to dispute that. But over the last maybe decade, maybe 12 years or so, there's been great interest in the variability about that response. And certainly that's not new. I always give credit to Dr. Bouchard. It was the first observation that I saw that variability in response to a standardized dose of exercise could be substantial. And I think Claude did that in I don't know, the 70s or 80s. But very recently, it's taken on a new dimension. And it's taken on a new dimension because because the standard deviation is there, it comes as no surprise to you that in response to standardized exercise, so what I mean by that is everybody did the same relative workload for the same period of time they attended. We measured every heartbeat, and they were doing exactly the same relative workload for, in this case, 24 weeks. And you look at the results here, and you see this now reported almost monthly in a scientific journal, that some are responding very, very well, it seems, and that some are not. So if you look here, it puzzles you somewhat. How am I going to interpret that on an individual basis? Some do very, very well. So most exercise scientists, and I teach kinesiologists, they like the very good responses, and the very poor responses, they say, well, something happened, right? That wasn't done correctly. Well, why does that matter at all? Well, as you know, in the last 10 years, ACSM, along with many institutions, have taken on the notion that exercise now should be considered medicine. And if it's medicine, then you're going to make a diagnosis. And on that diagnosis, you're going to prescribe a treatment. And you're going to measure that trait after treatment to determine efficacy. And that's not going to be based on a guideline prescription. It's going to be based on an individual response. And this is the point I'm trying to make here. The guidelines, quite correctly, are based on the mean response of an average population. That's the way we should do it. That's the way we develop guidelines worldwide, right? But individual response to that treatment is what we do with individuals. That's how we determine treatment efficacy, right? So if you go back to this observation, right, how do you interpret the observation to someone who's done 24 weeks of exercise under supervision, and the response for this very important trait has gone in the wrong direction or hasn't increased very much at all? Right? So we ask ourselves a couple of questions when we do that. The first question is that observed variability truly a response due to exercise alone? And then if that's true, if you accept that, is the individual response to that treatment permanent, or can it be changed, right? And these are questions that are now surrounding our group, and questions that we take quite seriously. So let me explain that second observation maybe in a way that makes it even more confusing. So these are observations taken from our group, Exercise Under Supervision, as shown to you here. And most of you would draw a line here and say that, well, something very good happened to 72% of the population, and 28% of this population, you'd say, well, that's something not so good happened there, right? So you can look at this. The common interpretation would be, as I just said, 72% of the participants or patients, right, respond 100% of the time, and 28% of the participants 0% of the time. Or you can have an alternative interpretation. You can say the treatment works in 100% of the participants 72% of the time. Now, that you might have to work your head around that a little bit, but essentially the point that I'm trying to make is, in the first case, the response to exercise is a permanent feature of that individual. So anyone in the 72%, that's their response, and it will not change. And those to the left, you say, well, it also won't change. In the second case, you say they're indistinguishable. You can't. In other words, someone over here, I'll use this screen, this person here might be over here the next time, and this person here, right? To what extent is either of those observations true? And in the very short time I have with you today, I'll try to confuse you even more because this can get a little complicated. So let's go back to this observation and perhaps look at the first. Is the observed response truly a reflection of exercise alone? So one of the common ways of looking at what aspect of the exercise response is not due to exercise is to simply look at what we call the technical error, right? So if you measured fitness on a Monday and you measured fitness on a Wednesday, would it be exactly the same? Well, of course it won't. You know that. There's nobody here that would say it would be, right? So you will, in your research area, you will measure some people over time on each consecutive Monday, and you will determine the variability, your ability to measure that trait of interest. And today I'm talking to you primarily about fitness. And if you do that, then you represent the data looking like this. Never mind the acronyms. These are just 3 different exercise conditions. And that TE, or that measurement error, our ability to measure it on Monday and Tuesday on the same people, and you will shade that. That's done by many groups now. So here I'll just show you on one, the shaded area there, you would call those individuals, you would interpret that response as uncertain, or what many in the field have now come to say, that's a non-response. For whatever reason, you have not responded to the exercise dose prescribed beyond our ability to measure, in this particular case, fitness. And that's the way I did it for quite a while, and many others did it. But then you can ask another question. You can say, not just what is the difference from Monday to Wednesday, but what would be the difference in a control group if we measured them at the beginning of week 24 and at the end of week 24? That would include 2 sources of error now, right? Your ability to measure it, and then just the day-to-day variability. I don't know what causes that. Over 24 weeks, what's the variability in your control group? That would be a second question that you can't answer with the data that you just did on Monday and Wednesday. And this was an observation that was I first became aware of this observation in 2017, where these UK colleagues put together a very important observation. They were kind of grumpy when they did it and threw a lot of shade our way, that's for sure. But they made 2 very, very important points, and I'll take a second here to make sure we understand that. What they basically said is, well, you can't just take your technical error on Monday and Tuesday and do that. You have to have a time-matched control group, and you have to use the data, the variability in the time-matched control group. You have to account for that if you're going to look for the variability in the exercise group. Hopefully that makes some sense. And the way you would simply do that here, that's what I'm trying to show you here, is you take the standard deviation of the intervention and you control for the standard deviation within the control group. The variability that would remain from that is variability you can now attribute to exercise. Make sense? Okay, you can shake your heads up and down like this and give me great confidence, because I know that this gets a little bit squirrely. All right, then the second thing you simply do is this, and I think I mentioned it. Do I do that here? Yeah. If, having done that, the remaining variability is what you consider clinically significant. If that's clinically significant, only then can you now look at the moderators or mediators of that variability to look at what the variability is that you can now attribute to exercise. So what that might look like now, showing you that here, and there's a little math behind this, but what I'm trying to show you here is this is our same data. There's the control group, and you can see there's variability in that control group. You can't argue that, right? So the notion that I have to account for that variability in the control group when I consider what variability in the treatment group is really due to variation in exercise response, right? And when you do that there, in this particular case, the residual standard deviation is only about 70 mils. And you'd say, boy, that's not really clinically significant, right? There might be a response in exercise that's beyond control, but I don't think that that's variability that's clinically significant. On the other hand, I'm just showing you here, again, data unpublished, right? All I'm showing you here, oh, I'm sorry, go back like that. Yeah, all I'm showing you here is that when you do the same process, now we've changed the dose a little bit, you start to get a residual, you start to get a variability of 200 mil. You say, well, that's clinically significant. Let's now do the analysis to see what is it about in that population that's explaining that variability that now we can attribute to exercise. So we have, as I said, made this an important question that we've looked at with our group over the last year or two, and I selfishly plug this observation recently published because I think within it, it makes a couple of points that I'd like to share with you here right now. So here in this study, we put together data, all supervised exercise, aerobic type exercise, all supervised, all standardized, et cetera, et cetera. And you can see the sample size here gets a little bit bigger. And essentially what I'm showing to you here, without getting into the math of it, is the green bars, that's a variability. It's beyond 2 standard deviations of the variability in the control group. I know that's a bit of a mouthful, but in short, you like to see more green. That's what you want to see. That's really variability that you can now confidently attribute to exercise. Now, you might say that, well, geez, look at that variability in the control group. That's a lot of variability. We have to account for that. But the reason I wanted to bring this up is to look at a few other traits. So these are just 3. We report on a lot more in the paper, but as you can see here, it doesn't take much insight to see that the variability in the control group, you can almost superimpose that on the variability within the treatment groups, right? So apart from whether or not there's statistical significance, what you see here, right, and that makes a whole lot of sense to me, is that the variability that you can attribute to exercise, again, that's beyond 2 standard deviations here, is very, very small. Small by comparison to fitness, right? So the variability we're seeing within the control group for fitness is for cardiometabolic risk factors very small, right? And it's almost encouraging. But I also wanted to share with you other observations in the paper here. So what I'm showing to you here is data from our group. We use whole body MRI to look at our various outcomes. Jane, if that was anybody else but you, I come here as your friend. Do you want to answer? Should I proceed? Okay. All right. Okay. I understand. I'm humbled. We'll stop. So seriously, what I'm showing here is very, very different, and I think there's 2 really take-home points that you make here. So MRI, you can very clearly see, I'm sorry again, MRI, you can see a difference, that the variability in the control group with respect to the response variability in the treatment group is ginormous. You don't have to be a biostatistician to see that there's a difference there. And if those responses in green is good, you can see here that the observation within your treatment groups is substantial. This is substantial variability, and now we can go in and really do some nice statistical analyses to see what might be explaining that variability. So I think, and we say in the paper, that the 2 major take-home points from this are twofold. One, the importance of accounting for control group variability. It makes sense to me. I didn't do that at the very beginning, and some of our early publications are wanting in that regard, right? We do so more so now. And the second is a point that is almost more important, and that's the precision of measurement, right? If we are going to determine treatment benefit for any trait for a given individual, and that's what we do, we run an outreach program, we work with individuals, then it behooves on us to make sure that we do our very best to measure that trait as well as we can. So those of you in clinical medicine are saying, well, tell me something that's not true. We're not going to make a diagnosis on one measure of a blood going at 2 miles an hour in the thing, but often in research, that's exactly what we do. Did the treatment work? We get one blood. We measure fitness once we do that and determine whether there is a benefit. So by way of summary, please don't leave here and say that this moron from Canada came down here to tell us that if you do physical activity, that cardiorespiratory fitness on average won't improve. No, he didn't say that, right? It will. And maybe for many of you, that's good enough. You say, I'm going to prescribe consensus, and I'll just assume that everybody benefit from that. However, if you're an individual, if you're someone who works with an individual, this gentleman here, if he's interpreting the results of a program, 24 weeks of physical activity on cardiorespiratory fitness, and that has gone in the wrong direction, that's a very unhappy participant, and you're going to struggle to interpret that. And that's very, very important, and I think it's something that we move towards. So right now, exercise as medicine is, by design, really one treatment fits all. We have a condition in medicine. We call it low cardiorespiratory fitness, right? It's there. We're going to prescribe consensus guideline for exercise. You are going to see this result. Some are going to improve, some are not, and some might even go backwards. Whether that's an adverse response, I'll leave that very difficult consideration to Dr. Bouchard, but you are going to see this, right? So if we know that, if we accept that, then exercise as medicine in the future, right, what we're going to do is we're going to either alter amount or intensity or frequency for a given individual so that we can maximize the benefit, saying that one size doesn't fit all, but as the cliche goes, there's a size for everyone, right? So if we're going to do that, what it says, and this is my message, is we've got to, I'm going to get this right, we've got to make sure that we measure the trait properly so that we can alter the dose to maximize the benefit. And that's something that I'm not, the more I'm in the field of cardiorespiratory fitness, I'm not so sure how well we do that. So the first question is the variability in CRF response. I'm saying that I think we have to measure fitness, and we have to be very, very cautious and considered and deliberate on how we do that, right? So if a time-matched control would be ideal to have, but many individually will not have that. Do you measure fitness twice, pre and post? If you can't measure fitness twice, do you do perhaps a verification test to determine whether that fitness level was actually achieved? Many of my colleagues measure, as we do, fitness at several time points over the intervention. So if the person is increasing at every time point, you're fairly certain that that's a true response to exercise. Or as many of my colleagues are considering now, estimate fitness using peak work rate. And I remind very few of you in here that when you look at the seminal observations of Dr. Blair that were so nicely characterized by Claude this morning, all those observations are not based on indirect calorimetry. They're based on fitness that was estimated by peak work rate. So that's the evidence that we have. So if someone increases the treadmill on the cycle, the work that they can do in the second test, is it fair to say there's an increase in aerobic capacity? Most exercise scientists would say that's a fair assumption. Some would say, well, maybe they just got better at the second test, and maybe they're more familiar with it, and they just did better. That could be true as well, but that's also true for indirect calorimetry, right? And maybe someone just didn't get as familiar with it on the second test. And I'm not the first one to be questioning or to be raising some issues that really should be interpreted positively. Cardiorespiratory fitness is a trait that predicts morbidity and mortality. It's beyond question, it's beyond dispute. But if we're going to deal with individuals, then we have to measure that trait, like all traits that we measure, as well as we can. And there are questions, and we need to give that careful consideration as we move forward. I haven't spent too much time discussing the second question, and that is whether the response to exercise is permanent. If you accept that the variability that I'm showing you, if you accept that that is a true response to exercise, well, it doesn't negate answering the second question. Well, can I change that? Is it possible that I will change the medication, in this case, to lower blood pressure because the person didn't respond to the first medication? Well, our medication is first-line therapy, 150 minutes of moderate intensity, vigorous. What if we change it? Well, we have very little evidence on this right now. As I said before, this is a question that very much interests our group. This is a randomized trial. We're halfway through this trial right now. We've randomized about 160 or so participants. In the first 16 weeks, they'll do guideline exercise, and we will evaluate that response using a waitlist control group. Then after that 16 weeks, we'll measure a bunch of things, and then we'll re-randomize them to 3 other conditions to see, well, is it really possible to change someone, or is it permanent? We have very little evidence, really good evidence to do that. These are painful studies, 32 weeks of supervised exercise in a gym, every heart rate measured, physical activity outside of that prescribed is measured weekly by accelerometry. These are hard to do, but if we're going to answer the question, this is the type of study I think that we have to do. So maybe in a little bit, I'll come back and share the results to that. I'm happy to share my slides. Much of what I've talked about today may be a little hard to figure. We and others have published in this area. If you send me an email, I'm happy to send you these references. I want to, with my last minute or so, just as so many have, is to recognize the importance that Steve had in my life. I first met Steve, over 20 years ago, when Steve was still in Dallas. And just like all of you here, I was struck by 2 things. The academic skill and acumen of Steve was a bridge way too far for a simpleton like me. But like most of you, I was struck by his persona, his humility, his loyalty, and his acceptance of even those who weren't as friendly to some of his observations as others. And I've often thought that I was special in Steve's life, but I wasn't. I really wasn't. I can tell from everybody who's spoken here, you were far more special in his life than I was. Because the unique ability that Steve had is when you spoke with him, it was about you. It was about what you were doing and how you were doing it, and that's why I felt special. Because someone like Steve thought enough to talk to me or think with me or work with me or do the kinds of things we did over the years. And my very picture that I have in my office here is one that I cherish for a couple of reasons. One, because of course it's Steve with, as you all know, the love of his life, Jane. But it also shows my graduate student at the time who came down to work with Steve, Louise and myself, and there we were doing what we had most fun with. This was our morning walk. We were going to get out there. We took this picture quickly because Jane wouldn't walk with us. We were far too slow, so she goes off at a very quick space, and I work with Steve. But I will continue in my career to aspire not to achieve what Steve did academically. That's a bridge too far. I'll fail at that miserably. But his humility, his loyalty to his friends, and his acceptance of all who either agreed or disagreed with him, are traits that I admire and I will strive to achieve for the rest of my career. So I thank Steve and I thank you, Jane, for hosting us so many times at your home. It's a memory that I treasure for the rest of my career. So thank you, Steve, thank you, Jane, and thank you all for listening.
Okay, we probably have time for a quick question. And while someone is raising their hand, I'll just say I think we are all going to leave maybe feeling a little less special, but also very grateful for the role that Steve played in all of our lives. We have one over here, and then if you have other questions for Dr. Ross, just catch him.
Dr. Ross, great presentation, very concise and thorough at the same time. So my name is George Grieve. So with all the results that you presented, I think that some people might have the inclination to say, like, well, why should I do exercise if I might be in the lower group, a non-responder, so to speak. But so I think in certain cases, well, one example would be military basic training, right? Everyone's run time gets faster while they're there. Now, as to whether or not their aerobic fitness increases, you know, that's unknown because we don't measure it. But that's a really controlled environment where there is the same sleep, same eating, same physical activity, that we may not get that outside same level of consistency, even with supervised exercise visits. So with that being said, still doing exercise, we're likely to see performance benefits, which will likely increase habitual physical activity. So I think that could just be a message that we could say, in addition to the additional work that you're doing, that, you know, hey, there's additional benefits to exercise for total health, you know, independent of cardiorespiratory fitness, right? So, which we all know that, but I think that it might just be something that could be important to emphasize so these results aren't misconstrued, if that makes sense.
Yeah, I think I caught a question there. I'll do my best to respond. I think that we're in the very early days, and I don't feel comfortable at all saying someone is a good responder or a poor responder yet for fitness. And of course, as I said in my second slide, there's benefits to engaging in exercise across a wide range. I'm picking on one trait to make the points that I made today, but we're never saying, even if the fitness response is poor, that maybe reductions in adiposity or cholesterol or triglycerides or lipid or whatever weren't outstanding. You can't judge all traits by the response of one. But I think what is true, and it comes as no surprise to me, that not all of us will respond the same way to a given dose of exercise. And in clinical medicine, they've known that for years. Not everyone responds the same. You accept that. I think the point that we're making is that you want to make sure you're measuring that response very, very well. And then in time, we can alter the dose of exercise to find the dose that is optimal for you. I think people, rather than see that as a negative, see that as a positive. Say that, well, the chances are I will respond well to guideline activity. But if I don't, right, then we'll find the dose of activity that's right for me. I think that's a win-win.
Thank you.
Great. Thank you so much to our speakers. Let's give them one more round of applause.
While there are still a lot of people taking bio breaks, in the interest of time, we're going to get started. My name is Nicole Keith, and I am the Executive Associate Dean for the School of Public Health, Bloomington at Indiana University. And I am here to be the moderator of this session, but I'm also here sending greetings to Jane from our dean. That he asked me to read to you. And this is from Indiana University School of Public Health, Bloomington, the Office of the Dean. Dear Jane, friends, and colleagues, Steve Blair was an extraordinary man, an extraordinary scholar, and an extraordinary friend. He will remain in our hearts and live there forever. I regret that I cannot be there with you today, yet please know that my spirit is. I held Steve in the highest regard. He supported me for years and was a role model to me. He was someone I admired and looked up to, not only because of his success, his intelligence, his exceptional speaking ability, and his research savvy, but above all because of his kindness and humanity. I admired that Steve took care of others and that he could be selfless. And I am grateful for all that he did for me. I'm a better person and have had a richer life for the privilege of having Steve Blair in it as a friend, mentor, and colleague. I know that I am not alone in these feelings. Jane, that you and Steve met right here at the Indiana University School of Public Health, Bloomington, which is actually called Health, Physical Education, and Recreation, but we won't talk about that because he likes to call it the new name. Where I now have the privilege of serving as dean means so much to me. Of course, I was not in this role at the time, but I can imagine your first meeting, having heard so much about it from Steve, and my heart is warmed by it. I am proud that my school has not only helped to produce great scholars, but also a great couple, a great marriage, and great human beings. Please know that my heart is there with you, and I will always be here for you if there's ever anything you need I can do to help. Let us celebrate Steve, his good work, and his goodwill today. With friendship, gratitude, and the admiration to both you and Steve, David B. Allison, PhD. He has also engraved this on a plaque that I will give to you after the session is over. So thank you. Now, to get started, I have the privilege of the last session between you and eating, which is always fun. This is session 3. And the speakers for this session are I. Minley and Jennifer Trilk. In your brochures, you have their bios. And I decided not to read them because I have the privilege of knowing I.M. and Jennifer, or I-Min and Jennifer personally. And so I'll start with I-Min. She is the nicest person. If you don't know her, she comes from very humble beginnings. And when I heard about her life story at what is now known as the Rathbone Drinkwater Breakfast at the annual meeting at the American College of Sports Medicine, I said, wow, she had no resources. And when I finished listening to her talk, I said, wow, she had all of the resources. She is brilliant. She is creative. She is loving. She cares for people. She wants to make this world a better place, and she is successful in doing so. I have such an honor to know her. And I remember I was walking down the street in Indianapolis one morning where I live. It was at the end of the annual meeting. And she said, "Good morning, Nicole." And she gave me the biggest, best hug. And I didn't even know she knew my name. She is a wonderful person, and she makes you feel special no matter who you are. And it is my privilege to introduce Dr. I-Min Lee.
Good morning, everyone. I'm so very honored to be speaking at this symposium honoring the memory of Steve Blair. And I'd like to thank the family, Jane and Anne, Russ, the university, for inviting me to participate in this. Like many of you, Steve helped me at the beginning. And many of you here will also know how he took care to promote those who were, I guess in my time, it's like people whom he felt would need an extra hand. And that would include women, junior women. The photograph that Claude showed earlier of us being on the scientific advisory board of the Cooper Institute, at that time I was truly, truly green. I had just finished school, maybe done my postdoc, and Steve very, very kindly invited me to serve on the board. And it's people like Steve, my mentor, Ralph Paffenbarger, Jerry Morris, who helped me along the way, as Nicole said. So I wish for every one of you, Steve, someone else like Steve, someone else mentored by Steve, to help all of us along the way. And as I was thinking of the various memories that I had with Steve, one memory came to mind that has nothing to do with human physical activity. And Jane may recall this. We were at a dinner or probably lunch. At that time, every one of us carried a laser pointer because you'd use that for the slides. We didn't have things like this. And Steve turned around to me and said, "You know what this thing is? It's a very good cat toy." And he knew that we had cats, and I knew he loved cats. Jane loved cats. Joe Almeida, who's with him, helped look after the cats. So I had never heard this, and I couldn't wait to go home and try that. And when I did that, whoa, it was a really big hit. So Steve, thank you for everything you've taught me about physical activity, but also thank you for teaching me about this laser pointer. So what I'd like to talk about this morning is the result of, as you all know, in the recent few years, we've seen a proliferation of data coming from epidemiologic studies that rely not on self-reports of physical activity, but use devices to measure physical activity instead. And so this new data, this rich data that is coming out, should it influence guidelines that we have on how much, or as most people probably want to know, how little physical activity we can get away and still be healthy? I am not seeing. Yeah, good for cats, but not for. Are we up? Okay, back one. So this is a viewpoint that Sarah Keetle and Chuck Matthews and I wrote for JAMA, maybe it was last fall, describing the rich sources of data that we can have from wearables and talking about how this clinically might be useful. And of course, one of the new metrics we talk about is steps. Steps, as you all know, is something that Steve diligently tracked. This is a lovely tribute written by Ben Boudreau, his daughter Ann Kennedy, and Russ Pate. And in this article, it talked about how Steve has been recording his step count since at least 2010. And over this period of time, he averaged 13,700 steps a day. So is this a good number? Is this a bad number? Should we be aiming more? Should we be aiming less? So this is one of the things that I'll talk about today. And to give you the context for this, we of course know that there's a large body of epidemiologic data clearly showing that physical activity is good for our health. And prior to, I would say, 2019 or so, the bulk of this literature came from epidemiologic studies where individuals self-reported their physical activity. And in self-reports, of course, you cannot have steps. And so our current guidelines are based largely on these self-report studies, and they recommend a level of physical activity that is based on time. But now with this proliferation of data that has steps, perhaps we should be including steps into these guidelines. And when I say steps, I'm cognizant of many individuals that are not able to walk. So when I say steps, I also mean step equivalents, and we'll talk about step equivalents in a little bit. So with all this new data that is coming, should we be including steps in our new guidelines? And if so, how many steps are we talking about? So I don't need to remind this audience how physical activity benefits our health, our well-being, and our function. This slide comes from the evidence base that was put together by the expert committee that reviewed the evidence for our current or 2018 guidelines. We know that people who are physically active live longer, in part because they have lower risk of many chronic diseases such as heart disease, cancer, type 2 diabetes. We know they have better cardiometabolic risk factors. We know they function better physically, mentally, they have better cognitive health. They also have better quality of life, sleep better, less anxiety. Physically active individuals have better bone health, they manage their weight better. Older individuals are less likely to fall and have fractures from the falls that they have. So there's a large body of evidence showing that physical activity is good for our health. I'm not going to show you all the studies. I'm just going to show you this classic study that is based on self-reported physical activity. So I'm going to use my pointer on the left slide. This is a meta-analysis that we at that NCI cohort consortium did. It was published in 2015, so largely based on self-reported data. It's a combination of data from 6 prospective cohort studies that included 661,000 participants, and it was led by Hannah Aram, who was a postdoc at NCI at that point. And so you can see that individuals are classified according to their physical activity levels. So no leisure time physical activity meets guidelines 1 to 2 times, 3 to 5 times, and so forth. And what you see is this curvy linear relationship. Looks like it ticks up at the end, but there are very few data at this point. Less than 1% of the population reach that level. And you can see what we all know, that guideline levels are great. The more you do, the better off you are. It tapers off at a certain point. But also, before you meet guidelines, you actually see a significant reduction in mortality rates. And if you look at this slide, you can see the risk reductions are on the order of perhaps 20 to 30%. Now, Professor Bouchard, when he talked earlier, he talked about how there's this argument with Steve and that, fitness results in larger benefits. And I think in part this is because fitness is better measured than self-reported physical activity levels. So nowadays, when you have data from wearables, we don't have to rely on self-reports. You can use objective data from wearables. So this is a slide that shows 2 panels. At the top, it's a woman who's playing pickleball, and she reports playing pickleball for 2 hours. And if you were to observe her, she's telling the truth. She was on the pickleball court for 2 hours. But you can see the enthusiasm flags after the first hour. So very good pickleball playing here. But then at this last hour, she's probably talking about how the University of South Carolina women's basketball team is doing. And if you look at this bottom panel, this is someone who reported walking for 40 minutes, and this is much more regular, but there's still breaks here. So the breaks could be, the dog is peeing, pooping, you're waiting to cross the street, but it collects very well what you're doing. So when you have this better precision of measurement, what we see are far larger magnitudes of association. So this is an editorial that a cardiologist, Megan Wasfi, and I wrote maybe about a year ago, and you see the Aram meta-analysis, and we haven't pulled this to 10 times because the comparable studies did not have enough of a population to reach that level. In particular, this blue line, which I'll talk about in a second. So this is the Aram study, and the Aram study comprised participants from North America and Europe. Do people from other parts of the world show the same sort of association? And these data are from Wen et al., and Wen et al. Used data from a Taiwanese health insurance database, and you can see that in these Taiwanese individuals, pretty much the same sort of association reductions that are 20 to 30% risk reductions. So these are accelerometer data, and this was a meta-analysis that was led by Ulf Ekelund. We pulled together data from 8 studies at that time. The UK Biobank wasn't in it. So these 8 studies had relatively few participants, less than 40,000 participants, which is why we couldn't pull this out to, which is why we couldn't pull this out to the 10 times. And you can see that in this Ekelund meta-analysis, the magnitudes of risk reduction are far larger than what you see with the self-report studies. So on the order of 50 to 60% risk reductions, which is what you would see in the fitness studies where fitness is better measured than self-reported physical activity. So we'll turn now and talk about these data that you get from wearables. Wearables give you step count data. Should there be a place for step targets in our next physical activity guidelines? Now, why steps? Steps are a very egalitarian measure. Everybody has steps or step equivalents. We are talking about people who do not walk. It's a marker of physical activity. The more steps you have, the more physical activity that you're doing. And steps, in a way, is very encouraging for people who are not very active, because I haven't been doing much here, but I bet if I were to look at my pedometer, it probably record maybe 10 steps, 15 steps. So for people who are at the low end of physical activity, using a step counter can be very encouraging to them because it captures all these little movements that they make. It's also a very easy to understand metric. Most people in the public, if you're making public health guidelines, would understand what steps are. And wearables, your smartwatches, your smartphones are increasingly being used more and more. People have access to it, and whether you like it or not, whether you consciously monitor it or not, these data are being captured. So this is a map that Tim Althoff and colleagues published in 2017, and these were data that they had obtained anonymized. Apple had given them permission to collect step data from a platform that Apple puts on their smartphones. And you can see that around the world, people have different levels of step counts, but they are really not very high. And particularly if we look at where we live, North America, people on average take maybe 5,000 steps a day. So if we're thinking about using step counts for our future guidelines, how many step counts should we be asking people to do? So we know that Siri has all the answers. So if you say, hey, Siri, how many steps should I be taking? And let's not be elitist. So if you're using an Android phone, we'll say, hey, Bixby, how many steps should I be taking? So I tried that. Siri and Bixby will tell you to go to your health app. You go to your health app and ask you to open the app that records your steps. And if you do that, you'll find that if you haven't made any changes, your default will be 10,000 steps. So why 10,000 steps, and what's the basis for this 10,000 steps? Very interestingly, the origin of the 10,000 steps was really not based on scientific evidence. The pedometer has been around for a long time, but the first commercial pedometer was actually made by a Japanese company called Yamasa Clock and Instrument Company, and they sell in the US under the brand Yemex. So at that time, they had made a pedometer, and you remember that in 1964, there was the Tokyo Olympic Games. So they were trying to capture the popularity that had come with being physically active. And the Japanese at that time were concerned because at that time, the Japanese population was starting to put on weight. And I took this from their website, and I can't remember whether I Google translated it or whether I had copied it. It's not written in native English, but you basically get the point. They basically said that, it's a good number. We don't really have evidence, scientific evidence that directly addresses the issue, but we think that this will be a good target if we want people to walk a certain amount, and it was to help control their weight. Now, at that time, they sold a meter, which they call the manpoke, because man in Japanese means 10,000. We have a word for 1,000. We don't have a word for 10,000, but the Japanese do, and they call it man. And the device that they had looked like this, and if you went one round around it, it was 10,000 steps. So this is what they sold, and they wanted people to get to the 10,000 steps. Now, Yoshiro Hatano was an investigator at Kyushu University, had done some research using pedometers, and I once heard him speak, and I think it might even have been at ACSM, and he said, the Japanese character for 10,000 man looks very much like a man walking. So this is a very good way for people to remember. It looks like a man walking. 10,000 is a nice round number. So is this truly the number that we want to reach at? Steve actually had some data that looked at, if you follow guidelines, what number do you actually get at? So some of you may remember his Drew study, and in the Drew study, for the group that was supposed to exercise at 100% guidelines. He brought them in, they walked on treadmills, and he had them wear a pedometer. And during the time that they walked on treadmills, they recorded the step counts on the pedometer. And these women recorded a total of something like 16,400 steps while they were walking on the pedometer. Now, they did not come in every day because obviously that's not practical. But if you take that weekly count and you divide it by 7, that will come to an extra maybe 2,300, 2,400 steps a day. Remember the tip LTOF maps, you saw that the average American was taking only about 5,000 steps a day. So you take 5,000 steps a day, you follow guidelines, you add the 2,000, say 2,300 on top of that, you can actually reach guidelines, not at 10,000, but somewhere around the level of 7,000 steps a day. So while we have had studies looking at step counts showing that more step counts was better for health, nobody had actually asked that question, do you need to get at 10,000? And we published this study in 2019. And the genesis for this was, my workplace had a physical activity promotion program. So I do physical activity research. My administrator came to me and said, you form a team, here are the Fitbits. And the people in my team were people like me, older individuals, people were not particularly, some of them were not particularly active. And they said, we're never going to get 10,000 steps. And so I thought, do you really need 10,000 steps? So I had a cohort of older women at that point, and they had worn an accelerometer, and so we were able to look at their step counts and their mortality rate during follow-up. And what we saw was, as you saw from the Aram curves, the Venn curves, Ekelund curves, this nice curvy linear relationship that shows that some stepping is better, more is better than less, but tapers off at a certain point. And interestingly, the point at which it tapers off is not 10,000, but in these older women, it's something like 7,500 steps a day. So in the past 5 years, you've seen a large body of literature looking at stepping rates, and different health outcomes. And here's an example from Neil Stens and colleagues from the Netherlands. It's a meta-analysis of 12 studies looking at all-cause mortality, looking at cardiovascular disease, and we see the curvy linear relationship that you see with many of the studies that have looked at physical activity and health. And this is a meta-analysis that Amanda Paluch conducted, pulling together the Women's Health Study as well as other data, and it's a combination of 8 different cohort studies. It's a combination of 15 different cohort studies. OAF had 8 studies. This was 15 different studies, and at this point, the number of participants was about 47,000 because the UK Biobank had not been included. And what was interesting was that she showed that the curvy linear relationship existed, but probably differs between those who are older and younger. Among those who are older, and by older I mean 60 years and older, and I know we typically say 65, but the way the data were presented in the different studies, we had to cut the age range at 60 and older and younger than 60. Among those who are 60 and older, it looked like it would taper at between 6,000 and 8,000 steps. Among those who are younger, it tapered off closer to 8,000 to 10,000 steps. So now I think we have a lot of data showing us that if you follow guidelines meeting time-based, you have health benefits. If you use your step counter, you will also see health benefits at more steps, and probably closer to 6,000 to 8,000 for those older, 8,000 to 10,000 for those younger. So what I was interested in is, are these comparable? So what do I mean by comparable? So you know that, of course, you can use glucose to monitor, fasting glucose to monitor someone's diabetic status, or you can use HbA1c. So they are sort of equivalent measures. They're not exactly identical. So what I was interested in is, do these two metrics, because not everybody is going to monitor their steps. Some people just don't care. You give them a device and they're going to put it in their drawer. Some people obsessively monitor their metrics, and other people would prefer to look at time. So do these perform comparably? So a postdoc of mine, Rick Hamaya, and I conducted this analysis, and we wanted a clever title. We said, should we rely on a clock or a step counter for health in women? And we thought this was great. And it's been accepted for publication. I was going to present on this, but it's actually not going to publish till next month. So it'll be in the JAMA Internal Medicine, and we just got the galleys last week, and we were crushed to find that they didn't like our catchy title, and they changed it to the boring time-based versus step-based metrics and health. So what we did was we had these accelerometer in this cohort of women, 16,000 healthy women, and what we did was we divided them according to quartiles based on their time in moderate to vigorous intensity physical activity, and this wasn't reported. This was based on a device measure. Or we divided them in quartiles according to their step counts. And what we wanted to do was to formally compare the performance of these two measures with regard to hazard ratios, with regard to prediction of all-cause mortality and cardiovascular disease, and with regard to their survival time. And essentially, I'm just going to give you the highlight of this, is that they perform pretty comparably. So on this slide, I'm showing you hazard ratios for women divided by quartiles for all-cause mortality on the left, cardiovascular disease on the right, and the blue and the red dots indicate whether they've been classified according to time metric or according to the step metric. And you can see that neither one of these metrics is clearly superior to the other. So in my opinion, I think that future guidelines can include both sets of metrics, and it's back to, I think Jim Skinner made the point, what should be recommended is what you like. So this gives people the option of whether they prefer the time metric or whether they prefer the step-based metrics. Now, as I said, not everybody walks. We know that in the US, about half the population has chronic conditions, and the CDC tells us that 12% of adults have a mobility disorder, and many of those with mobility disorders use wheelchairs. So how might steps be relevant to these individuals? Now, many of you know Professor Barbara Ainsworth's seminal work. Oh, this is probably like 3 decades ago, when she gave us the first compendium of physical activities that we could use to calculate energy expenditure of people who self-reported their physical activity level. She's continued her admirable work in this area over these many decades, and this came out earlier this year. If you haven't had a chance to look at it, it's a really nice series looking at the history of the compendium and updating the information as they come. This particular article was looking at wheelchair activities, 124 different wheelchair activities. It was led by Dr. Scott Conger. And so we can use the energy expenditure of these different activities and equate them to a step equivalent, so that if the guidelines were to include steps, not just walking activities, but non-walking activities might be able to use the step metrics to look at it. So I'm going to end at this point and say that, of course, we know that physical activity has many benefits. It improves our health, physical and mental, improves our well-being, improves our function. And with the device measures that we have more recently, the magnitude of benefit may be larger than what we had previously thought. Our current guidelines for aerobic physical activity use a time-based metric because step-based metrics are not available at that time. Accumulating data from device-based measures, I think, compel us to look and consider whether step-based metrics might be included at our next set of federal guidelines, which we anticipate to be in 2028. And I don't want to forget the fact that, of course, our physical activity guidelines ask us to engage in strength training, exercises 2 days a week, and Professor D.C. Lee will talk more about strength training activities and our health this afternoon. So thank you for your attention, and I'll stop at this point.
We are right at time, but Dr. Lee is, out of respect for her, if there are questions, I think it's really important that she has an opportunity to answer them. My pregnant pause that all professors do. Okay, so if you do not have questions for her at this moment, I encourage you to find her at lunch and ask her questions at that time. So I was looking around the room, and I have a story, and that is that this is a family. and it's a really cool family. So I look at, for example, John Jakisik and I were on the student advisory board together a long time ago for the American College of Sports Medicine. And Leanna Ross is like, you're not talking to the microphone. And speaking of Leanna, many of you know I'm having some health issues and I was actually advised not to come to this trip because there was a fear that I would be traveling alone. And I said, I won't be alone. There'll be like 100 people here who love me and help me, and I'll never be alone. And Linda Durstein lent me her husband last night to take me to CVS so that I would have what I needed overnight. And Leanna made sure I had my phone number in case something happened in the middle of the night. And then both Leanna and Jennifer carried my stuff up to my room because they didn't want me to carry anything heavy. And so when I start dropping things, that's why I'm having a little bit of trouble. And so there are 100 people in this room. And my best story about Steve is I was in the first trimester of my youngest son. It's 20 years ago. And we were in we're in the mountains, and he was like, let's go for a walk. And I was like, oh yeah, I'm not in the very best condition, but I'm in pretty good condition otherwise. And it's Steve. Like, how fast can he actually walk? I'll keep up with him. And after 15 minutes, I was like, I'll see you when you get back. He was such a fast walker, and I could barely breathe. And that's about, and he didn't make me feel bad about it. It was more, I understand you're pregnant. I also understand I'm in great shape and you're in okay shape. So I'll see you back at the lodge. And it was just a really funny story. But again, a way of grace that people appreciate you. So when I first met Jennifer, it was kind of funny because we were on a panel together at AMSSM, at the American Medical Society of Sports Medicine. And they don't tell you who you're going to speak with. They just say, will you be on this panel? And I said, sure. So then I got the panel list, and Jennifer was on it. And I was like, oh, great. This is going to be horrible. Like, she's amazing. She's smart. She knows everything. There's not a thing that she doesn't know. What can I possibly talk about? And I was like, well, I agreed to do it, so I did it. And Jennifer was so nice, and she made me feel so comfortable, and she made me feel so smart and knowledgeable. And we were a pretty good pair. And we taught those sports medicine physicians, no offense, Liz Joy, but we taught those sports medicine physicians some things that we think they didn't know during that conference. And Jennifer and I have been really good friends. She's fun, like she's a normal person, although she's a brilliant scientist, and she is discovering things about exercise that nobody knows. She's also a really good dancer, and she's a lot of fun. And it is my pleasure to introduce Dr. Jennifer Trog.
Okay. So I'm going to try. I want to thank Russ and Ann Blair and Jane for the honor to be able to speak about who was a most amazing man to me. I'm going to try to not look at Ann Blair for the duration of the talk. Okay, great, that's even better. Look at Blair. Blair. I spoke with my mom last night, Dr. Jakisik. I called Mom. And Mom goes, what are you doing? And I said, I am having a family reunion that will be a combination of incredible science, wonderful laughter, and tears. And to me, to be honored to be able to speak at the Blair Scientific Symposium and to honor what he has done for not just me, but for every medical student that I have encountered over the last 12 years of our institution. So the title of my slide is the rationale for lifestyle, or the talk is the rationale for lifestyle medicine training and medical education. However, the secret session title would be his legacy at our medical school. I do have objectives because I was I was taught correctly. So we're going to provide the rationale of why we teach physical activity and lifestyle in medical education. We're going to provide some of the examples that we teach in our medical school and why students are being taught this. And then we're also going to educate you on what you could do as an educator to promote physical activity and lifestyle medicine in medical schools if you're associated with one or if you teach in one. So this is really important for us to understand. So let's look at the rationale. Some of this data, many of us in this room already know, but medical students don't really get taught this right from the beginning. So Dr. Chozid, Dr. Chozid here, she is the Module Director of Foundations and our Vice Chair. Thank you, Dr. Chozid. Thank you, Dr. Cannell, who's the chair of our department, who traveled down here today. And I'm hoping that you're seeing in the room the love around lifestyle medicine and physical activity and where this came from for our medical school. So when we look at the chronic disease, and the CDC reports that over 90% of the nation's $4.1 trillion in annual healthcare expenditures is around preventable chronic conditions, preventable chronic and mental health conditions, and that the primary drivers of those preventable conditions are physical inactivity, a poor diet, making sure alcohol, substance use disorder, and tobacco. So we know this. We also know from a healthcare cost, and breaking that down a little bit more, that chronic disease from a heart disease perspective, cancer perspective, type 2 diabetes, obesity, and Alzheimer's and smoking is a significant cost to our country. And when we think about all of this that could potentially be preventable, and yet medical students and our future doctors are taught from a traditional standpoint of disease management and disease treatment, and not necessarily the prevention of chronic diseases through the root causes of physical inactivity, sedentary behavior, poor diet, smoking, etc. It's really, really important to bring this into medical education. So in 2017, the American Medical Association and the American College of Preventive Medicine put forth a resolution, resolved, that our American Medical Association supports policies and mechanisms that incentivize and provide funding for the inclusion of lifestyle medicine and social determinants of health in undergraduate, graduate, and continuing medical education. So this was in 2017. We opened our doors in 2012, USC School of Medicine, Greenville. When we think about, and when I'm talking with you about what is lifestyle medicine is a clinical discipline, and it incorporates 6 pillars around lifestyle, as Dr. Jakizik had mentioned before, when we're looking at lifestyle. So we've got healthy relationships. So we understand, and we saw this in COVID with social isolation, how important having that social connectedness and reducing that social isolation is in order to improve chronic disease risk. Looking at quality of sleep, not just the quantity of sleep, but what is your sleep hygiene? Looking at avoiding the risky substances, and then also managing stress. So we're learning more and more in the literature how stress and increase in cortisol levels really impacts chronic disease risk. Healthy eating, of course, so when we think about a whole food plant-based diet, reducing our sugars, reducing our cholesterols, reducing our saturated fats, and most importantly, reducing our processed foods. So if you think about it, what is a processed food? A processed food has more than 7 ingredients. So if you look at eating out of a box, so there are 7 ingredients or more in that food, that's a very highly processed food. And more data are coming out demonstrating a very strong link between that and chronic disease. And then of course, physical activity, which is why we're here. Looking at making sure that we have a very physically active lifestyle and that we teach our patients how important it is to have a physically active lifestyle. In 2018, I published a white paper with colleagues looking at the lack of training in medical education. and also demonstrating that physicians, residents, medical students, this is many times why they actually come to medical school. This is they want to learn to heal. But yet in 2018, with this white paper, we did physician survey reports and resident survey reports that physicians felt that they don't have the exercise and nutrition knowledge and skills to treat patients with chronic conditions. And there's a very real lack of time and compensation codes to be able to counsel their patients on physical activity and be able to bill for it. Residents who are graduates from medical school and now in their residency training, this was very interesting, the surveys that we found, that only 14% who had graduated from our schools across the country and are in residency training felt that they had the knowledge and the skills to provide nutrition counseling. The majority of them didn't quite understand the obesity guidelines or diagnostics of obesity. And this was quite interesting. The 76% felt that it was confident for physical fitness was a priority, and 88% understood physical activity benefits. There were less than 50% of those residents in practice and in training that had the knowledge or felt like they could implement exercise programs, not just with their patients, but in their own lives. So when we think about where this is going and where now we're seeing a recent movement on Capitol Hill, so think about the 2017 resolution, the 2018 white paper. In May of 2022, Jim McGovern, who's a congressman, he passed a resolution on it through the House that nutrition should be taught in medical education. And this was May of 2022. So he's stating how incredibly important this is to be taught across the country so that we can look at the impact of diet-related diseases and how we can improve nutrition and education in medical schools so that doctors can speak with their patients about nutrition and most definitely refer them to the appropriate resources, such as a registered dietitian, to really dig in and start talking about that behavior change. So right on the heels of that, in September of 2022, the White House convened its first conference in 50 years. So that was since Nixon, on the hunger, nutrition, and health. So for the first time in 50 years, the White House, from a federal perspective, started looking at the importance of diet-related diseases and food insecurity in our country. There were 4 pillars. I'm going to highlight 2 of them. The second pillar was to integrate nutrition and health and to prioritize nutrition and food security, so making sure that individuals have access, not just to food, but to healthy, nutritious food, including prevention and management and ensuring that our healthcare systems address the nutrition needs of all people. So very, very important. And then thanks to our colleagues, they added in a pillar 4. So although it was titled the Conference on Hunger, Nutrition, and Health, I know that many of the colleagues in this room and those who are online really advocated for adding a 4th pillar on supporting physical activity for all. So making it easier for people to be more physically active and having safe places to be active, to increase the awareness and the benefits of physical activity, and to conduct research and measurement on physical activity. So from a White House perspective, you've seen, through the years how this is now coming to the forefront from a federal perspective. However, apologies. So in March of 2023, the ACGME and the Association for American Medical Colleges convened a summit themselves and said, let's go ahead and start implementing what the White House is demonstrating. And then in January 2024, I was a part of the Department for Health and Human Services Food is Medicine Summit with Javier Becerra on continuing to drive this forward. My point of all of this, again, that hidden curriculum, this started way before the start of our medical school and much way before the time that the federal government started saying, hey, this is the way that we should be teaching our students, our future doctors. So looking at what Dr. Blair put out in 1997, encouraging patients to become more physically active, the physician's role in advocating physical activity. 1997. I was, how old was I? That's probably not public knowledge, but I would have been, like 24 years old. 24 years old at the time. So he was thinking about this long before this was mainstream. And then looking at, again, 2011, responsibility of sport and exercise medicine in preventing and managing chronic disease, applying the knowledge that is, that is very, very overdue. So that's in 2011. And then furthermore, thanks to Dr. Pate and the colleagues that he brought together, Dr. Liz Joy, who's here today, who was the chair of the healthcare sector of the National Physical Activity Plan, implementing in the fourth strategy that universities, postgraduate training programs, professional societies should include basic physical activity education in the training of all healthcare professionals. And since this was launched in 2010, and I was extremely privileged to be a postdoc with Dr. Pate and Dr. Russ, I remember looking at this and going, oh, okay, kind of a little wet behind the ears, and thinking, well, if that's what we're supposed to do, then that's what we're going to do in our new medical school. As that foundation was built, and as we were building our school when we opened it in 2012, Dr. Blair continued with his colleagues. Chip Levy is here as well. So physical activity counseling and sports medicine, a call to action, physical activity promotion in healthcare, and physical activity training in medical schools and preparing our future doctors. So if you see throughout this thread, throughout what we've done at our medical school, this really was a foundation of Dr. Stephen Blair. So thankfully, I remember when I was in my postdoc with Dr. Blair and Dr. Pate, I was saying, why are you going to Greenville now again? Because I was down here in Columbia, and I remember Dr. Pate going, we're going up because we've been asked to consult for a new medical school that they may open in Greenville. I'm not quite sure if they're going to do it. And I remember saying, is there an interest, do you think, of promoting physical activity and lifestyle as a prevention for chronic disease in this training? Because this has never been done before, and I've learned this since then. And Dr. McBride, raise your hand. Where are you? Yeah, so I remember, Dr. McBride, you heard from him earlier. And I remember being in a parking lot on the phone with him because Dr. Blair said, call Dr. McBride, because of what he had done in Madison, Wisconsin, with the Nutrition Academic Award. Said, how do I even start this? And that man gave me step-by-step guideline on how to really bring in the idea of lifestyle medicine in our medical school. So fast forward to 2024, we just received the Platinum Plus certification for being a medical school, only one of two, Loma Linda's the other in the country, that incorporates over 100 hours of lifestyle medicine training in our medical school. We have a classroom clinic community model to where the students learn it in the classroom. They implement it within the clinic, and we utilize our community resources such as the YMCA for our Exercises Medicine Greenville program I'll talk about in a moment, and our culinary medicine. So our students will don a chef's coat, and I will say to them, it's your other white coat, because you're going to teach your patients how important nutrition is. And as they're going through their training of becoming a lifestyle medicine physician, again, they receive the education, we're supported within the community, they get networking with the American College of Sports Medicine, American College of Lifestyle Medicine, Greenville Tech, all these different areas in which they learn to utilize their community resources. And then they're also set up for residency certification as a board-certified lifestyle medicine practitioner. We have it integrated all throughout our school. We have an organic garden. Again, we've got the culinary medicine. We have a Walk with the Doc chapter. We do quite a bit of physical activity and exercise. We do research in physical activity, and we do fellowship. So again, that's social connectivity. Again, that call of action, the one thing I wanted to point out was that as the students learn their culinary medicine, their capstone project is to identify a patient within family medicine or internal medicine, bring that patient into the kitchen, and teach that patient how to cook, and teach that patient how to prepare healthier meals. The research that we do is very hands-on in lifestyle medicine for these medical students. You can see that we have had papers published in exercise counseling in pregnancy. We've had near-infrared spectroscopy in looking at how chemotherapy affects muscle mitochondrial function. We've looked at children, we've examined children after school physical activity programs, and we just added this great PR that went around our tandem cycling effects and looked at how tandem cycling with patients who have Parkinson's and their care partners really improves functional gait analysis, quality of life for both the partner and the patient. So I would not be able to stand up here today and talk about our Exercises Medicine Greenville program that we launched in 2016. But before we launched it in 2016, we started it in 2014. And we've all heard about how Dr. Blair is extremely smart and how he connects individuals, one to another. Here's AHA, I need you to meet this person. I'll never forget when he called me and he goes, I really need you to meet my daughter, Ann Blair. And I'd love for Ann Blair to come up and see what you're doing and really get a take on what it is to be in medical education. So he sent Ann Blair up. Ann Blair did an internship with me, immediately transitioned after her graduation into a postdoc. And if it wasn't for Ann Blair's intellect and insight and understanding on health behavior promotion, right, that we would not have, Dr. Ross, a flexible and adaptive program of a 12-week exercise physiology with all patients coming through. So our Exercises Medicine Greenville program, thanks to Ann Blair, putting together recommended building blocks and core building blocks on each one of those patients who are referred into the program, get a very highly qualified exercises medicine professional who works with them individually, tracks them through their 12 weeks, and sees how their performance or how their health is improving, and will titrate that based on what's going on with the patient. So this was a picture, which I absolutely adore, of our launch of Exercises Medicine Greenville. You can see Dr. Blair, Dr. Pate has been with us every step of the way. We know that when we launched that in 2016, we launched it with 4 practices, 2 in family medicine, 2 in internal medicine. We are now scaled over 39 practices across 2 counties. We cover 400 square miles in terms of clinics and over 350 square miles across 7 physical activity facilities in Greenville and Oconee County. We've had quite a bit of dissemination on this data. And as of February 2024, we have also received from Prisma Health a pilot for them to bring in 200 team members, so 200 employees, to see how it works for not just the patients, but the employees. We've received Duke Endowment NIH Award. And again, this is all because of the idea that Dr. Blair had of, hey, I want you to meet my daughter. So I'm going to go in just a teeny bit, and I know we're a little bit short on time, and I have a video I'd like to show you of what our medical students see in our medical school. So we have over 100 hours. I can give you 4 examples in the time that I have. We talk about obesity and body composition, and we look at the difference between subcutaneous adipose tissue, visceral adiposity, and looking at BMI and how it is only a screener and it is not a good measure necessarily of health. We talk about that chronic disease inflammation linked to obesity and how accumulation of that body fat has been demonstrated to lead to all of our chronic conditions through cellular inflammation and pathogenesis. And then we'll get into type 2 diabetes, and we talk about the lifestyle factors, which is that standard American diet with high salt, high fat, high sodium, and physical inactivity, and all throughout the intercellular mechanistic pathways, how that can promote inflammation in the pancreas, destruction of beta cells, and type 2 diabetes. We also talk about how do we look at, from an exercise standpoint, a way to help our patients bring down their A1Cs, and how do we promote that And we go in from an intercellular mechanistic pathway so that so that the students understand when they're taking their exams what those biomechanisms are. We even go into above the neck, brain health. So we look at brain health, mental health, we look at neurogenesis, we look at neuronal repair, and how physical activity is very promotive in increasing brain-derived neurotrophic factor and other very good solid factors that help with brain health. We talk about dementia, we talk about Alzheimer's, and we talk about what is the way to prevent that. And again, what is the hypothalamus skeletal muscle crosstalk that occurs with physical activity? The last example I'll give you is lifestyle and cancer, because we want to look at one of the ways that we can utilize exercise to decrease the risk of getting cancer, and also looking at how you can utilize exercise to decrease the risk of progression of some other cancers. So we'll go through the multi-stage carcinogenesis and looking at the processes and prevention strategies of exercise and how exercise will reduce long-term oxidative stress and make sure that we've got anti-initiation strategies of exercise and anti-promotion progression strategies of reducing that cancer risk. So in summary, the students get over 100 hours of physical activity and lifestyle promotion within their training, and this is in the biomedical sciences. It's in their integrated practice of medicine, so it's within their clinical skills. And this is assessed in both their clinical skills, their OSCEs, and their biomedical sciences. What we've seen, this is data from 2020 and 2021 for students who graduated from our program. And when the question is asked, do the students like the program? You know, that's going to be a bell-shaped curve. Some of them absolutely adore the program. Some of them think they want more surgical content, pharmacology content. You know, so we really work as a team to make sure that everything is covered. But we see this data on the students who have graduated. And that first one, I've professionally implemented lifestyle medicine principles in the way that I care for my patient. We've got 65 to 70% of graduates who agree to strongly agree. What I love so much is what they've learned in the classroom, that second graph. I personally implement lifestyle medicine principles in my daily life as a result of the curriculum and experiences. During their medical school, that's up to 70% of those that are implementing it. Remember that pilot or that white paper? Implementing it in their own lives and understanding the benefit of physical activity and lifestyle. So before the video, I'm going to close and ask you, as a plea, as a call, if you're involved in any way in medical education, there are ways in which you can promote this at your own school so that it's not just at USC School of Medicine Greenville, that it is across the country, because the nation is now listening. We've been reached by CNN, US News and World Report, Wall Street Journal, Chicago Tribune. We've been reached and saying, what are you guys doing at our school that is different than other schools? And I always say, this is, you know, we may be the first, but we don't want to be the only. We want to help those who really want to integrate this into their medical school, how to overcome barriers of implementation in their medical school, and how to work with your clinical faculty and biomedical science faculty to champion this in your medical school so that it can grow. And through doing that, you know, thanks to our school, we've open sourced our lifestyle medicine curriculum, so it's free for any medical school, any medical student, any instructor, any faculty who wants to utilize it, with a vision that all clinical students will receive education in lifestyle medicine to prevent and treat chronic disease. And we've got, again, that open access. So everything of those 100 hours is on a downloadable website. We've reached, I've learned actually as of yesterday, we've reached 99 countries throughout the globe who've downloaded this content. And it's been quite successful. In this coming year, we just received a grant to reach out to those schools, develop a relationship, see how we can work with them to also get certified. I'm gonna go here just for a second. To also get certified with their school through curriculum certification. So with curriculum certification, their students could also be highlighted as students who were taught lifestyle medicine. So the final thing that I'll mention is that we were very proud to be able to offer at the White House Conference for Hunger, Nutrition, and Health an in-kind donation, or be able to state that we will help implement this open source through the White House Conference Initiative, and that we also would provide an open source to our Exercises Medicine Greenville toolkit, and so that others can implement this program as well. Okay, and I think. LMED stands for Lifestyle Medicine Education. Lifestyle medicine incorporates nutrition, exercise, sleep hygiene, social connectivity, resilience, and a reduction of risky substance use into the teaching of medical students who are going to be our future physicians and our future clinicians to treat and prevent chronic disease. I'm Dr. Jennifer Trilk. I'm an associate professor here at the University of South Carolina School of Medicine, Greenville, and I'm one of the founding faculty of the medical school. I also developed the lifestyle medicine curriculum here, the core curriculum that spans all across the 4 years of the undergraduate medical school curriculum, and also was director of the distinction track, and I direct the culinary medicine program.
The lifestyle medicine education is just a very unique opportunity to learn about a super important part of healthcare that is not taught nationally in medical schools.
It empowers students that besides pharmacotherapy, there are some lifestyle interventions which are actually much more effective as well as cost effective for our patients as well as physicians. It is such a cost saving for our healthcare system.
Our goal in lifestyle medicine, this curriculum, was to implement recipes that lowered sodium, lowered sugar, lowered I won't say all the bad things, fats, inappropriate fats, unhealthy fats.
To innovate curriculum to bring in the effects and the power of exercise, the power of nutrition, the power of good sleep hygiene, and create a lifestyle medicine curriculum here at the school to train the future doctors for prevention of disease and treatment and reversal of chronic disease.
We've known for a long time that a lot of what we're dealing with in healthcare right now is preventable things. Things like type 2 diabetes, certain cancers, complications of obesity, #1 killer, coronary artery disease. So the fact that we're finally really addressing it is overdue, and the fact that Greenville is spearheading this is really an honor.
I have heard many testimonials from our patients as well as from medical students in regards to the lifestyle medicine curriculum. And I have to say that for many of them, it has been life-changing.
I had a problem with my hip, and I was sent to a neurologist to make some evaluations, and he made further referrals to a surgeon, to other doctors to find out if it's the problem my hip or is it someplace else. He ended up referring me to Dr. Revilla.
I spent time talking with medical students and the doctors about what's good information, what should we stay away from, and just things that are going to help with our quality of life. So it's been really wonderful.
It's such an engaging curriculum to be a part of, learning how multifaceted health is and how it can be affected by so many different parts of your life.
It's a fantastic part of our curriculum here at the School of Medicine Greenville. And it's something that makes our school so unique, and I just love seeing the other students get involved with it and get interested in it. And it is part of every student that comes through here goes through the curriculum.
Our doctors are trained to look at the root cause of the disease through poor nutrition, high saturated fat, high cholesterol, high sodium, to look at physical inactivity, because sedentary behavior is the 4th leading cause of mortality in the United States, independent of other chronic diseases. So to take a look at that and to train our doctors how to implement those modalities as medicine, as prevention-oriented medicine, and treatment as an adjunct or as a first line of defense for chronic disease, that is something that is powerful and will help us for the community and hopefully be able to turn the tide of the chronic disease that we see here in the United States. So I want to finish by saying I've stood up on a podium many, many years now when people will say, how did you start this program? And how did you get it so successful? And what gave you the ideas? And how did you really do this? And let me see if I can do this without crying. You can see in the room, all I did was translate what I learned from Dr. Blair, from Dr. Pate, from Dr. Jakizik, from Dr. Ross, from Dr. Joy, from Dr. McBride. All I did was translate everything that I was raised on in physical activity and lifestyle and brought that over to our medical school. So I gave this slide at Southeast, but I'm going to say it again. In deep honor of the most amazing man, scientist, spearheader, fearless leader, mentor, legend, Olympic torchbearer, people promoter, student and young faculty supporter, and work father to so many of us. There would be no exercises medicine Greenville at the University of South Carolina School of Medicine, Greenville, without this man's mentorship. Actually, since he and Russ Pate helped build the original curriculum, there may be no medical school. Let that sink in for those of us who know our school. Dr. Steve Blair left a legacy few people reach. The earth is dimmer now. However, the heavens are incredibly bright with his light. So thank you, Jane. Thank you, Ann. Thank you, Dr. Blair. Thank you for everything, because every student that comes through our curriculum and comes through our school are benefiting because of Dr. Blair. Thank you.
Jennifer has given me directions and I'm not following. Do you have questions for Jennifer? You can ask her at lunch or you can ask her now. One thing I want to say before we break for lunch is a question that I have is how many lives of physicians you've saved. We know physicians are under incredible stress and aren't taking care of themselves. And so for this to be a part of their curriculum, to take care of themselves, I just have to wonder as I listen how many clinician lives you've saved.
Thank you, Dr. Keith. I will say that in our very first year of the student curriculum, the students are learned right from the beginning that they are their first patient. So we do go through self-assessments and reflections with the students of what is your current lifestyle behavior? What are you doing with your lifestyle behavior? How are you going to maintain your lifestyle behavior in a rigorous curriculum over the next 4 years and probably the next 24 years of a service leadership role as a physician? What are you going to do as a person to maintain your health? We also ask them to do a SMART goal in lifestyle and choose one of the 6 pillars, and we meet with them one-on-one to see how they're doing. So we hope that we are able to also serve our patients through serving our physicians, through serving our students.
You're changing the world. Thank you. All right. I am going to ask the Blair family to come up, take a picture with the plaque, and everyone else is free to go to lunch.
Stay on schedule, so we're going to start the afternoon program here shortly. So please find a spot.
Good afternoon. Good afternoon. There we go, there we go. I hope you all had a great lunch. I certainly did. And I'm most excited to be here. And I want to thank Russ and Jane, you and your family, for asking me to just kind of chair this session. I truly appreciate that. And what makes this session so special is the two speakers. And even though Dr. Hand is sitting in my seat, but that's okay, he does that before. What makes it so special for me is I've watched these guys grow up. They are USC graduates in one way or another, and I've watched them grow up. So I've talked with both of them, and I'm not going to read these completely. I'm going to give you a shortened version. But before I do that, I have a short story about Steve Blair. And that story was, I'm going to really keep it short. It's not really very long. I met Steve in 1974. I was working at Cooper's Clinic in Dallas, Texas, in the Institute. Mike Pollock was my supervisor, my mentor, and turns out later in life, one of my really good friends. And Mike said one day, he said, hey, in a couple of weeks, we're going to go to Southern District. It's going to be in San Jose, or not San Jose, excuse me, near Austin, one of those little towns, and on the river. And he said, I'd like you to go with me. And we went together, and Steve Blair was giving his presentation, and Mike looked at me and he said, Larry, I want you to come up and meet Steve Blair. I met Steve, and he was very gracious, as you all have described, but 8 years later, I was interviewing it to South Carolina, and who was sitting out in the audience? Of all those 6 people who attended my presentation. And Steve Blair goes, in the question period, he said, Larry, just tell us, who do you think the leading people are in lipoprotein metabolism in the United States? He gave me the loaded question, and I must have done good because they hired me before I even left campus. And then the last story is, you know that Steve is the farmer. I, too, am a farmer. I've been up at 5 o'clock every morning for 80% of my life. And you know, it's nothing for me to go into work early. And guess whose office I would always pass? Steve. And he'd look over his shoulder at me. Well, one morning I didn't get there till about 6:10. And it wasn't 5:45 when I got there, it was about 6:10. And he looked over at me like this, and he goes, you think you're ready for this afternoon? I am. And let me just introduce Mike Lamont. He's a professor of epidemiology, co-investigator of the Women's Health Initiative Regional Center at the University of Buffalo. And it says, stop here, Larry. Michael said, don't say any more. But I am going to say one other thing. I've watched Mike, and I really met Mike through Barbara Ainsworth over here. Barbara invited him to be a postdoc, and she came to me a few weeks afterwards and said, you know, this Mike Lamont's asking about you. Why don't you join with me, and let's work and develop Mike Lamont. And look what we produced.
Well, good afternoon, everybody. Thank you, Larry. I have to tell you, it's very humbling to stand in the shadow of greatness. And I have to tell Russ my sincerest thanks for your gracious invitation for me to join the program. Thank you, Jane and Ann, and all of you for coming together to celebrate a great and a very generous man, and of course, an eminent scholar. I fondly recall working on the data for this slide with Beth Wright, Beth Barlow, her pen name. I don't know if she's here. I don't see that she's come back for lunch. There she is in the back. For this slide that Steve would show often in his presentations. And Steve was very clever on how he would describe the slide. So the obvious is there. There's an inverse association between fitness and mortality in each of the 3 age groups shown. But then Steve would engage the audience. And he would say, but if you look carefully, you will notice that the mortality rate in the oldest men who are in the high fitness group is lower than that in their youngest peers with low fitness. And he would make the point that that suggests a 20-year mortality benefit through fitness. And we would talk about this slide, and Beth would make it better over time. And then, of course, May Sui, my dear friend, published these data in the Journal of the American Geriatrics Association with Steve, of course. And Steve would always say, you know, Mike, one day we'll have enough data, we can add the 90-year-old age group. And he said, I'm confident that the pattern will be the same. So I've spent the past several years working on the Women's Health Initiative, which in the early 90s enrolled 162,000 postmenopausal U.S. women ages 50 to 79 into one of 3 large randomized controlled primary prevention trials and a large epidemiological cohort study. And when the main study ended in 2005, we've continued to study the women as a prospective cohort using 5-year extension study increments. And as of the current extension, which began in 2020, there's still 63,000 women active and alive and participating. 2,800 of them are between the ages of 90 and 107. And they remain active, and they are an example of generosity that Steve Blair exuded throughout his career. In 2008, of course, you know, we had physical activity guidelines for Americans, and as part of the advisory committee report, this research gap was identified. We needed to understand more about the potential, I say potential because there wasn't a lot of data at the time to support this, the potential health benefits of lighter intensity movement, and to take advantage of what had become more readily available and cost-effective for large-scale epidemiological studies, device measures, which I mean so elegantly overviewed this morning. So in 2012, we developed and got NHLBI funding for the OPATCH study. I'm in as one of the senior principal investigators on that study. And we were doing home examinations, in-home health exams in the WHI at the time. So we coupled our recruitment and enrollment into OPATCH with women who had completed an in-home exam. So we got a lot of extra data, blood collection, physical performance measures, and so on. And we deployed hip-worn accelerometers. And at the end of the day, we were pleased to receive over 7,000 of them back with usable data that represented a cohort of older women between the ages of 63 and 99. Now, we had a challenge at the time. And that challenge was, and remember, this is back in 2008, 2012-ish. We really didn't have a lot of guidance on how to process accelerometer output so that it reflected the target population, which was older ambulatory women living in the community setting. So we did a calibration study, a laboratory-based calibration study that was superbly led by my Tar Heel buddy and friend, Kelly Evenson. And we used indirect calorimetry measures of oxygen uptake and simulated activities of daily living and the such in the laboratory setting. And we came up with a way to process the output that we felt better, maybe not perfectly, but better reflected the intensities and patterns of movement of women the age that we were going to study in OPATCH as compared to what was available at that time. Now, you might ask, why would you want to study, or at least focus a study, on cardiovascular disease in late life? Well, let's be clear. Cardiovascular disease kills more women in the U.S. than anything else. Total number of cardiovascular deaths, as Dr. Levy would attest to, in women exceed those in men. It's not just a man's disease, we've known that, but we have to remind ourselves of that from time to time. And as you can see, some of our latest public health surveillance data, the prevalence of having cardiovascular disease in some form increases sharply across the adult age range in women, such that by the time you get to the 80 plus, almost 50% are affected. This is a major public health issue. Why? Because that's the fastest growing age group in the population. Older women, 80 and older, by 2050, they'll outnumber men of the same age 2 to 1. And they're going to carry a big burden of cardiovascular disease into later life. So we do need to look at cardiovascular disease and its prevention in later life women. So one of the first studies we published in OPATCH kind of focused on that research gap from the 2008 Physical Activity Guidelines Advisory Committee, where we focused on light intensity physical activity measured by an accelerometer, calibrated to our cut points from the laboratory study. And we were really, really surprised by the results. First of all, I want to say one of the other unique things of our study is all of the clinical outcome events are adjudicated. Not a random sample, not just a few. So these are high-quality endpoint data. And you can see in this study, if you look at, I'm going to try and do this over here. If you look at the incident rates, there is a sharp inverse gradient across quartiles of light intensity activity, such that the incidence rate per 1,000 person years is 37 in the lowest activity group, and it drops down to 19 in the highest activity group. And you can see, using multivariable adjusted regression, we see a very strong and significant inverse association. And that basically is maintained even after we put things in the model that one would argue are pathway variables and probably eliminating some of the association that we actually want to highlight. Kind of picking up a little bit from where Ayman left off this morning, if I can do this. We've also looked at steps from the accelerometer as another way of characterizing physical activity in older life. And I've learned so much from my dear friend and colleague Amanda about thinking how steps can be used, how do we talk about it, how do we analyze it. Thank you, Amanda, another Gamecock. And what I want to point out here, look at that distribution. These are women 63 to 99. You can see that the greatest density, oops, I knew I would do that. The greatest density of steps is somewhere between 1,500 and 4,500. That's the greatest exposure density for this metric in our cohort. And you can see it tails off dramatically, just like Ayman was showing in her data. Now keep this picture in mind as I show you the next few slides. This is a cubic spline regression of cardiovascular disease incidence on steps per day. And what I want to highlight, aside from the fact that overall this is a significant, gosh, sorry, Larry, you said that wasn't going to happen, man. This is a significant inverse association, but you can see it's nearly perfectly linear over the density of steps that is the greatest. Where we have the most exposure and the most case counts, we get really good precision. Notice the confidence intervals are very tight there. And as we go rightward on the x-axis, we're losing exposure distribution and we're also losing cases, and therefore this becomes far less precise, more unstable. But clearly, over the range of steps the majority of the women were doing, there is a strong inverse association between steps per day and incident cardiovascular disease. On average, for each 1,000 step per day increment, there was a 20% lower risk of having a major cardiovascular event in women 63 to 99. We also found that the intensity of stepping, at least as the way we looked at it, really didn't make much of a difference. When we looked at light versus moderate to vigorous steps, the pattern and the estimates of association were comparable to one another. And remember, the women in this study, for the most part, oh, darn it, sorry, this is where they spend their day. They move around at lighter intensities, habitual physical activity. That's what those steps are picking up. Right. Heart failure. Listen carefully. This is a big deal. Dr. Levy. Heart failure has been referred to by some of the giants in cardiovascular medicine as the cardiovascular disease epidemic of the 21st century. Okay? It's a disease that selectively targets older adults. 80% of heart failure cases in the U.S. are in people 65 and older. It costs a huge amount of money in healthcare costs and services to treat somebody that has heart failure. The lifetime residual risk of getting heart failure from age 50 and on, if you haven't already got it, is almost 50%. Okay? There's a subtype of heart failure, referred to as heart failure with preserved ejection fraction, that is particularly concerning to us because at present, there is no well-established treatment, making its primary prevention even more important. And hey, that form of heart failure is more frequent in older women and in race and ethnic minorities. So we've looked at heart failure recently. This is a paper that we published about a week ago from OPATCH. This is our first look at heart failure, and I'm focusing specifically here on HFpEF. This is, again, light intensity physical activity from the accelerometer. And I'll again point your attention to my inability to use a clicker. Look at the gradient in absolute risk. 10.3 in the least active, all the way down, cut in half in the most active. And again, statistically significant, strong inverse associations across incremental quartiles, so that if you look over in the column where we treated the steps per day continuously, for every 60 minutes of light intensity, not steps per day, physical activity, for every 60 minutes per day increment in light intensity physical activity, there was a 20% lower risk of developing HFpEF. And this is after controlling for a lot of things. One of the things we knew with this analysis, heart failure has a very strong likelihood of reverse causation. It probably starts long before your heart tells you it starts, long before you even feel it. So we wanted to try and control as best as we could for sources that might introduce reverse causation bias. And so we were able to control for physical functioning, use of a walking aid, morbidity. We did a lot of other analyses to try and ensure that that's at least not the only explanation for why we're seeing this inverse association. This is the spline regression of HFpEF on steps per day. And I think you're seeing what I just showed you previously for cardiovascular disease. Over the stepping density, where we have the greatest exposure, it's almost a perfect inverse linear relationship with the incidence of HFpEF in an old population that has susceptibility for multiple reasons. For every 2,500 steps per day on average across the distribution of our exposure, there was a 30% lower risk of incident HFpEF. I mentioned to you earlier that this particular disease afflicts race and ethnic minorities considerably. When we stratified our analyses of steps per day on HFpEF, we saw inverse associations in each of the 3 race and ethnic subgroups that are represented in OPATCH, and based on a statistical test, we found that there was no statistically significant difference in those point estimates. To try and put it into a public health context, we calculated something called the population attributable risk, something that Dr. Powell, who's with us here today, and Steve have a beautiful paper on a while back, and how we could and should be using this in the field of physical activity epidemiology. And what this tells us, if we assume that these factors are causally related to HFpEF, this would be the percentage of cases that would be avoided if the exposure wasn't present in the population. And what I want to draw your attention to is insufficient steps carries a similar population attributable risk as hypertension, and hypertension is the most well-recognized risk factor for HFpEF in older adults. Think about that. Steve would often say, I believe in population attributable risk. He would use it in his analyses and his presentations, but he was very, very ardent in saying, but we have to confirm that with experimental evidence. And I think we will have experimental evidence to soon offer on this topic as we anticipate the results from the Women's Health Initiative Strong and Healthy randomized trial, which concludes at the end of this year, and we hope to have our first primary outcomes publication around summer, fall 2025. WISH was a large, pragmatic, community-based physical activity intervention that was centrally delivered from Stanford University across the United States, and that used the National Institute of Aging's Go for Life for Elders package as the physical activity intervention. We randomized almost 50,000 women into the intervention arm as compared to a comparison arm, and as I said, the active intervention ends this year. Primary outcomes are primary clinical cardiovascular events. So let me say, best as I know, and there's far smarter people in this room than I, please correct me if I'm wrong, but I do believe, Dr. Skinner, I'll look to you especially for confirmation. This is the very first randomized controlled trial in the US where exercise is the sole modality for primary CVD prevention. I believe that's true. I'm going to end by sharing that cardiovascular disease is a very important outcome. We've been interested in it in OPATCH Women's Health, but we do work on other outcomes. As an example, Ayman Lee, I don't see you, but I know you're here. I hope you're here. Did she leave? She had to leave? So Ayman and Kelly Evenson have been spearheading a large investigation funded by NIA to look at all of the cancer endpoints, combining the women's health study Ayman led with accelerometry and the OPATCH study that Kelly transported into now a synthetic cohort. We've also started looking at brain health. These are remarkable numbers and sobering as well, as you might see. Dementia and Alzheimer's related dementias are going to double in prevalence. By 2050, there'll be 10 million cases in the population, and we really don't have good treatment for it. The lifetime risk of developing dementia is twice as high in a woman as it is in a man. The Lancet report and the National Academies both identified physical activity as one of the most promising interventions for ADRD. We need more data on this, of course. We've started to look at this in OPATCH, and this is an initial publication from last year. Again, showing you our findings for steps per day. These are women who had, as part of the Women's Health Initiative MIND study, serial clinical cognitive assessments. So they had really objective measures of their cognitive function repeated over time. The outcome here is mild cognitive impairment or clinical dementia. All of these cases were adjudicated. And as you can see, again, we see this over the distribution of steps per day in our study. We see a very strong inverse association with developing either mild cognitive impairment or clinical dementia. And what I want to point out here, and I find this to be fascinating, and I'm not exactly sure I can explain it, but these findings hold even when we control for the ApoE4 genotype. And that genotype increases susceptibility to early onset dementia and Alzheimer's disease tremendously. And we're still seeing an association with physical activity here, steps per day. So I want to end by saying that I hope Steve is pleased with the work we've been doing in the Women's Health Initiative to better understand physical activity and health and aging in older women in the United States. His data on physical fitness and mortality over age is far more impressive than what I can offer you from the Women's Health Initiative, looking at light intensity physical activity and all-cause mortality within age groups. But I will say, and I hope Steve's got a smile on his face, we put the 90-year-old age group on the graph. Thank you, Steve, and thank you all for being here today.
Michael, thank you very much for that very informative presentation. As Russ has instructed me, he said, keep everything you say short. So I will keep my introduction to my good friend Greg Hand short. Greg is very special, like Mike is very special to me. Greg was one of my first undergraduate students. So I could tell you he is presently the Dean of the College of Health Professions at Wichita State University. And he serves several other kinds of national positions. But most importantly to me, Greg Hand is one of my undergraduate students who came to me his senior year and said, I want to get in our master's program. I talked with Russ Pate, and I said, I'm not really sure this is a good idea. Not because I didn't think he was very good, but I just thought he needed to go somewhere else. He went to 2 other places, spent some time in a postdoc, and we hired him in 1998 or 96, excuse me, and one of the best hires that Russ Pate made. And he has worked very closely with Steve Blair. Greg has left us, he's gone on, but you've done a great job in the things you've done. So I give you Greg Hand. I meant to say I've always looked up to him.
Thank you so much. It is truly an honor to be here. I want to thank Russ for inviting me, and certainly Jane, a very good friend. My wife and I can't tell you how many times we've eaten over at Steve and Jane's house, and I will tell you, I think you could give her a grape and some tree bark and she would make a gourmet meal out of it. She is actually quite amazing. So it's good to have you here, Jane. It's good to see you. In 2005, Russ Pate came to my office and said, we have the possibility of getting Steve Blair back to South Carolina. And I remember looking at Russ and saying, well, you know, I'm a stress physiologist working in HIV infection. So, you know, Steve's a big name. I'd met him for 5 minutes several years earlier. So it'd be great to get him back. I think it'd be good for the department and the college, but I don't think it's going to have much to do with me. And that was one of the dumbest things I ever said. Steve came in 2006, and shortly after he got here, he came into my office, and again, we didn't really know each other, and I'm sure Russ set this up, and Steve said, I want us to work together. And I said, what are we going to work on? And Steve said, if I can get this, okay, it's not you, Mike. I'm pushing the green button. There we go. Did I do that or did somebody else? You did it, okay. So this is what Steve said. We need to understand why people are gaining weight. And I'm going, you know, I'm a stress physiologist. I don't do this stuff. I said, so let me think about it. So I went away and a couple weeks later came back and met with Steve, and I told him there are a number of problems, first of which is we know why people gain weight. They consume too many calories compared to the calories they expend. And that was one of the other dumbest things I ever said, because it's not nearly that simple as we heard this morning. I also told him that we can't answer this question because we don't have technology that's precise enough to be able to deal with 25 to 40 calories a day, which explains the obesity epidemic. I mean, that's a couple of chiclets. We just simply can't measure that stuff. And Steve said, well, we're going to use what we have, and we're going to go try and do this. And I said, okay. I also showed him a study from Hobb et al. That really changed the way I thought about energy balance and energy expenditure and intake. This was a study that was done in the early 2000s where they were looking at calcium. They weren't even looking at weight. They were looking at calcium and its effect on bone mineral content. And what they did was they gave a calcium supplement to a group of people for 1 year. And they gave it to them in a fruit juice that was about 150 calories. And so for all practical purposes, they created a clinical study looking at an increase of caloric intake of 150 calories a day for a year. If you think of the old 3,500 calories per pound, they would have gained somewhere around 15 or 16 pounds. If you look at Kevin Hall's algorithm, where he was predicting weight change by calories, they would have gained 9 to 10 pounds. In fact, at the end of the year, they had not gained any weight. Not only had they not gained any weight, there wasn't any difference in fat mass or body fat or anything else for that matter. So this was, the equivalent of 54,000 calories over a year that had no effect on anything that Steve and I were interested in looking in. So, we struggled a lot with that. We thought a lot about it, and how are we going to measure something that is so small over a daily basis that we're going to try and do some kind of prediction in weight gain and try and understand why people are gaining weight. This was something that came out from the government in the UK, and this explains energy balance. That's the little red circle in the middle, and I took the liberty of adding self and environment just to emphasize what John was showing earlier this morning, which is this is really complicated, this is really hard. And the fact that there are a couple of guys at South Carolina who were arrogant enough to think we're going to solve the problem and understand how it works, I really had no idea what I was getting into. And this was a stretch for Steve because thermodynamics was not his thing, and he would tell you that. So we decided to start with a study that Steve had some money for that was called the Lean Study. Steve would always tell me when he was presenting our data, I want you to sit on the front row because when I get it wrong, you can tell me. So with Leanna and Robbins out there somewhere, I feel like you two should be sitting on the front row to help me out when I get it wrong. So if I reach out to you, please help me out. Anyway, this was a study that was done. We worked with Sarah Wilcox on this, as a matter of fact. And we did a weight loss study for a few months, and then we did a follow-up. They phased out the intervention, and we looked at them 9 months later. And we had 197 people, and we split them up into groups where we're looking at standard of care. So they got Steve's Healthy Living Everyday Workbook. We had an armband group. SWA is for a SenseWear armband, and they had a watch so they could see how many steps, how much energy expenditure they were doing every day. So that was an intervention. We had a group intervention that was cognitive behavioral therapy based, and then we did the armband and the group intervention together. And what you see is that the two together had a bigger effect in terms of weight and in terms of energy expenditure than any of the other ones. You can also see over on the right, we did an economic analysis. So for those interested in policy, as it relates to weight change and physical activity, the two together ended up costing about, we estimated $55 per kilogram. So losing weight isn't cheap. The interesting part about this for me was that when you actually looked per daily steps or you looked at energy expenditure and compared it to weight change, there was no correlation. So what were we missing? And Steve and I struggled over this for quite a while, and we said we're missing something. We need to do a bigger study, a more precise study, and so we started what was called the energy balance study. In the energy balance study, we had 300-ish people. We started off for a year. We ended up doing a 3-year study. And we were trying to measure things at baseline and quarterly as precisely as possible. So we had energy expenditure. We did that with the SenseWear armband. We did resting metabolic rate under a hood. We had energy stores through a DEXA scanner. We paid $200,000 for a DEXA machine, so we'd be able to do this. So we could look at lean and adipose tissue, and we were using Diana Thomas's model and Kevin Hall's model of body composition changes to estimate the energy stores and the change in energy stores. So lean weight has a certain energy value to it, fat weight does. So we were doing that. Energy intake turned out to be quite a challenge. We were doing the 24-hour recall, which was the gold standard at the time, and we were at least 700 calories a day off. The numbers did not make any sense. So we started back calculating. We took the energy storage changes over time. We knew what the energy value was in those energy stores. And then we took energy expenditure, which was semi-precise with an armband. We added those together, and we call that energy intake. When we did that, this was a weight change over the year for men and women. And you can see the mean and the standard deviation was really pretty small over a period of time. So again, it comes back to emphasize the fact we're trying to measure something that our equipment cannot measure precisely. So there's a lot of estimating in this, and there are a lot of assumptions that are being made with all of the studies that are being done on weight management. If you look at the energy gap, and that's the difference between our estimate of intake and our estimate of expenditure, this is what you see. For men, 29 calories a day. For women, about 10 calories a day. So again, this is well outside of the precision of anything we have, even today, and this was 10 years ago. This is well outside of the precision that we have with any measurement equipment today to measure this. This is the part that broke my heart. Well, if you look at this, we took the people at the end of the first year who were in positive energy balance. They had gained weight. The ones in negative energy balance who had lost weight, and the ones who maintained their weight. As you can see, the ones who lost weight also lost resting metabolic rate to the tune of about 182 calories a day. And that, if that doesn't break your heart, nothing will. It just, as you lose weight, it just gets harder and harder because your resting metabolic rate is getting lower and lower, and so you're trying to add activity on the top of that. So it gets really tough. And as John was talking about this morning, the complications of this are really impressive to try and understand. This is just the biology. You add the psychology, the environment on top of that, and it's really tough to do what we're trying to do. This I thought was really interesting, and Steve and I drank a lot of scotch looking at this data. If you look at the women and the men, what we did was we took the energy gap, which is the blue bar is our estimate of energy intake, the orange bars are expenditure, and so the difference between the two really is the caloric value of the change in energy stores. And we broke these into quintiles, and what you're looking at is the lowest quintile, quintile 1, which was weight loss, middle quintile, which was weight management, top quintile was weight gain. And as you can see, you can certainly explain the change of weight by that gap between intake and expenditure. Now, for the statisticians out there going, well, of course you can, because you used energy gap. That is the change in body weight. So you've set this up so that you're going to be able to explain that. And of course we did. What was interesting to me was that if you looked at the activity levels, which were objective in terms of and these are free living people, they were wearing this armband, I think on average, Robin's going to correct me, I'm sure, but it was over 16 hours a day. So we had trouble getting this published because our energy expenditure levels were so much higher than what you saw in the literature, because most people were looking at 8 to 10 hours of wear time a day. In any case, what became apparent very quickly was if you look at the women and the men, there isn't much difference in energy expenditure per day among the groups. So, my interpretation of that, being someone who was really more interested in stress physiology than weight management, was that the explanation for weight gain is energy intake. Because energy expenditure, the people losing weight and the ones gaining weight really isn't much different. Steve did not like that at all, as you can imagine. And he said the problem is that the orange bars are too low. That if we just raise the orange bars, more people would be losing weight, and the people on the right quintiles would be managing their weight, and there'd only be a small group of people increasing weight. And I, of course, said, well, you're making the assumption that when you change that, nothing else is going to change, that energy intake won't change, resting metabolic rate won't change. Those things won't happen. And so at that point, we sat down and decided, before we go farther, I wanted to say that this was a time when there was a lot of interest in behavioral compensation with physical activity. And so there were a number of people, David Allison being a huge promoter of that idea, that when you started increasing exercise activity, you would reduce other activities, light and moderate activity. This was a paper that showed that, I won't go into this too deeply, but if you look at the right two boxes, the ones under exercise, a 45-degree line would explain a change between weight change and energy expenditure. And you can see that in the exercise, there was a 55 to 64% less weight loss than would be expected by increasing energy expenditure that much. So again, Steve and I had met with David about this and talked about it a lot because we were very interested in the compensation piece because our data wasn't coming out, wasn't making sense the way we were looking at it. And I said, you know, what we need to do is control the increase in physical activity. We need to increase the energy expenditure, but we need to be able to control it and try and get people to maintain their weight, to consume the same number of calories they're expending based on how much exercise they're doing. And Steve said, that's a great idea. We need to call this guy named Bob Ross from Canada and get him down here to talk about it. And I went, oh God. So anyway, Bob came down. We ate a lot and had a good time. And Bob and I spent a lot of time together talking about how to do this. Because at that time, you know, Bob was looking at whether there was compensation or not. Bob was very interested, as he talked about this morning, in the precision of the methodologies that we use. So we put together what was called, if the slide changes, the energy flux study. We took about, I think there were about 90 people in the study, normal body weight, 20 to 35 BMI, 21 to age 45, and we randomly assigned them to three groups: an observation group, a moderate energy flux, which was moderate activity level, and then a high energy flux, or a high level. Both of the exercise groups were working at 70 to 75% of their max, of their heart rate max, and the moderate group was doing 17.5 kcals per kilogram per week, which was, you know, a pretty significant bit of exercise. It wasn't what I would call moderate exercise, but it was the moderate group for us. And then the high energy flux group, which was 35 kcals per kilogram per week. That's a lot of work. And these people were coming in 5, sometimes 6 times a day to get it in because they were working at that heart rate. So they had to go the amount of time. We did the measurements at baseline. We did it at 3 months. We did it again at 6 months. And our goal was the participants who were included in the analysis were those who had stayed within 3% of their body weight from baseline. And when we did that, this is what we found. If you look at the second group of bars, the exercise expenditure, you see no bar for the observation group because they weren't doing exercise. And this is exercise that was in the clinic where they were being monitored. So we knew what they were doing. And then you can see the moderate group, which is the hatch bar, and then the energy expenditure. And then you can see the black bar, which is the high energy flux group. The interesting thing about this data when you look at it is, first of all, they did maintain their weight. If you look at energy stores, it's over on the right. None of that increased or decreased significantly. If you look at the total daily energy expenditure, that's when it gets interesting. Because what you see is that even though they were significantly working harder in the high energy flux group, and they were working harder than the observation group, of course, and the moderate group, when you looked at total energy expenditure, the difference between the two exercise groups was not different. And then when you back calculate the total daily energy stores, the changes in energy stores, what you see is something that's very similar to the total daily energy expenditure, not the exercise energy expenditure. Steve and I, of course, drank a lot of scotch and sat around talking about this for a long time to try and figure out what we were going to do. So we decided one day we were going to look back and see what we thought would have happened and compare it to what it did happen. So when you're looking at this graph, what you see is the achieved exercise energy expenditure on the x-axis, and on the y-axis you see a change in total daily energy expenditure. The dotted line is the prediction of what you would see if the exercise energy expenditure was just added on top of their resting energy expenditure. What you actually see in terms of the actual numbers is the solid line. And so the relationship between the achieved exercise energy expenditure and total daily energy expenditure was not predictable, was not predicted by the exercise energy expenditure. Compensation, right? This is exactly what David Allison showed in his paper that was published in 2015, I showed just a minute ago. They had looked at 25 clinical studies, and David was absolutely confident that there is compensation going on. Steve hated the idea, and I was Switzerland on this, I was in between. But ultimately, when we looked at this, what we found was somewhere between about 150 kcals a day and 200 kcals a day of exercise energy expenditure. There seems to be a threshold where the exercise energy expenditure doesn't predict total daily energy expenditure anymore. All of this that was done, so these 3 studies that were done over this period of time were done by an amazing group of people, and I'm going to embarrass Robin and Leanna if I can make this work. There they are. Leanna's sitting right there. Robin's hiding in the back somewhere because he knew I was going to do this. But, you know, there were a number of people that were in these studies, and of course, there's the man right there. He took front and center. But, you know, this was a lot of work. It was a lot of time. Steve and I worked on this. We met almost every day when he was in town, and spent a lot of time over at Steve and Jane's house. My wife and I would have dinner with them, and then Steve and I would break out the scotch and start talking. And looking back on it, Jane and my wife Carol would sort of get up and meander away and go do something else, and then Steve and I would start arguing about data and talk about life and do those kinds of things. And it was some of the best times of my life, and I will always remember him for that. Thank you so much.
I think you'll agree with me that we had 2 wonderful presentations, and we have just a couple of minutes. So we'll have a question for Michael, and then we'll have a question for Greg. So who has a question for Michael? Get your hand up so we can get your microphone. Yeah. Right back here. There, microphone's off to your right.
Question for Mike. Thank you for the presentation to both of you. Mike, I saw you with the light intensity physical activity. They were structured into quartiles or divided. What did you got? And there was a lot of variables that were adjusted for. What was done with moderate and vigorous intensity activity? Was that controlled for, or what? How did you look at that from the accelerometry?
Yeah, that's a good question. So yes, we did analyses. We considered them to be more secondary, partly because I'm not sure if controlling moderate to vigorous when you're trying to study light or vice versa is the most sensible approach, and I'm not really sure what we're trying to understand when we do that. But it's common to do it. We did do that. The results attenuate somewhat, there's no doubt about that, but I think the general interpretation, particularly for the analysis on heart failure with preserved ejection fraction, was still, for the most part, the same.
Thank you.
So can we have a question for Greg? Question for Greg. Yes, Claude. Right up here up front. Coming in from behind, Claude.
I get a question from Claude.
How much time do we have?
1 minute.
So if some of the premises for the conclusions are based on the overfeeding study that you defined as the calcium experiment, I don't think you get a good picture of the effect of overfeeding, because there they were free living and they could have adjusted their diet easily. There are true experimental overfeeding, where you control them 24 hours a day, you feed the subjects, the amount of calories, et cetera, There are about a dozen of those studies, and George Bray and I have reviewed them in detail and published a thick, fat paper on this recently. And 80% of the calories are recovered in the weight. Only about 20% is unaccounted for and explained by some compensatory mechanisms. The body weight increases, so expenditure goes up. You have also the partitioning issue. Some people partition more to lean than to adipose tissue. It's a very complex biology, but the overfeeding, you said that 96% of the calories were not recovered in the...
In David's review, correct, yeah.
That's impossible, totally impossible. And the studies are solid because they are experimental, and most of them have used doubly labeled water and indirect calorimetry on all subjects, and about a dozen studies have kept the subjects in the metabolic ward for the whole duration of the experiment, 24 hours a day. So we know what they ate and what they did.
So, yeah, as far as the study that I showed that Hawk's group did, it was 150 calories. It was in fruit juice this much. There wasn't any change in body weight. There wasn't any change in body composition. So when you add those up over a year, I mean, you wouldn't think that'd be enough to really have them change their behavior during the day. They would show up in the morning, take this little swallow of fruit juice, and then they were gone. So that's one study. And again, this is free living people. You don't really know. You don't really have an answer. All you know is that it's not what you would predict to have happen. And that's what I found fascinating. As far as David's work goes, again, he looked at 25 studies across 25. Some of them were clinical, some of them were free living, some of them were not. You know, I can't defend the work other than, you know, I know David does fabulous work, and when he looked at that review, when he reviewed this, when he put these together, when he looked at the data, that's what he found within the data. So, you know, he's at Indiana. You can call him up if you disagree with the paper.
With that, I'd like to end this session. And while this was all going on, I got a text message from Trish Painter in Palo Alto. And our good friend Bill Haskell is listening to this presentation this afternoon. So let's wish a hello to Bill Haskell. Greg and Mike, thank you very much. Two wonderful presentations. Thank you.
Good afternoon, everyone. I'm Mark Sarzinski, an associate professor here. Like Russ said, I'll try to keep it short. The speakers' bios speak for themselves, but in the spirit of what we're talking about with Steve and being someone who shared with others and trained, these two gentlemen are definitely in that realm. I've had the pleasure of publishing with both of them, and I'll talk more when I get to Jim. So our first speaker is Chip Levy. He's an MD. He is the director of the cardiac rehab clinic, professor of medicine, director of the exercise laboratories at Ochsner in New Orleans. So I've had the pleasure of seeing him talk many times when I lived in Louisiana. As you saw in Jennifer's talk, he was on the early days with Steve of promoting, educating physical activity and fitness in med school. And if you look at his bio, he has thousands of publications. And I knew he was an editor, but this says you're an editor of 40 different journals. So I don't know how Chip sleeps either. So I welcome him and look forward to his talk. Thank you.
I was afraid after you spoke earlier that I was going to hear some jokes. So, but anyway, I want to also thank Ann and Jane Blair, Barbara Rager, certainly Russ, and Sean Arendt for everyone else who was involved with setting up this wonderful event. I'd like to also tag along something that Bob Ross said earlier about, you know, coming here yesterday and today and now no longer feeling totally special. I didn't think you were very special anyway, but I sure thought I was. But now I know I'm just one of a long chain in the proud Blair gang, and glad to be part of it. Well, this is a paper that was just out a couple of years ago, and actually Steve Blair introduced me to Jari Luukkonen in Finland. He's from Finland, and he introduced me when we were both speaking at an Ulrich Wisloff course in Trondheim, Norway. And so Jari wrote a meta-analysis. Many people have been quoting the Kodama analysis for many years from 1989, JAMA, and this was in Mayo Clinic Proceedings a couple of years ago, of 37 studies in 2.2 million participants, basically showing that for about every 1 MET change in fitness, and we heard from Claude Bouchard this morning about how many papers in the early 70s and 80s that Steve Blair did on cardiorespiratory fitness, but for every 1 MET change, it affected mortality by 11%. Those in the bottom tertile had a 45% higher mortality than those in the highest tertile. Now, when I was here this morning, I told Jari I was going to be using his first one of his first slides in the paper, and he wrote back. He goes, "I'm on the. He's in Finland right now. He was on the computer watching this by Zoom, you know. So I don't know if he still is because it's probably late in the night in Finland. But he was watching by Zoom, and he also said, going along with what Imin said, he said he and Steve, when they met at first in the year 2000 in Kuopio, Finland, they both were sharing pictures of their cats, you know. I was privileged to write the editorial on this paper, and in this editorial, I really concentrated on the fact that the African Americans had lower levels of fitness. Damon Swift, Steve Blair, and I and others published on this. They had lower fitness than the Caucasians and lower response to exercise training even, they showed in their Drew trial. And I actually commented that this could have been part of the reason why there was a paper in Mayo Clinic Proceedings the year before about the African Americans had lower fitness and higher mortality from COVID, and it could have been partly due to this exact mechanism. Now, another pretty famous guy, Peter Kokonos, is with the Veterans Trial. He published his paper in the JAC a couple of years ago. Steve and Peter have at least 4 papers together. Unlike most of us who joined his ACLS studies, Peter actually brought Steve along to his veterans data bank for studies. But in this paper in JAC, of almost 1 million U.S. veterans, he showed that fitness was an important predictor of mortality risk across spectra of age, race, and in both genders, and was probably more important than any of the other major cardiovascular risk factors, something that, again, Steve was showing in his JAMA papers in the 80s. And I was also fortunate to write the editorial for this paper, and again, concentrated on some of the same things with the African-American population that really I think we need to do better at improving their fitness. And I joined with Peter in this paper from the veterans, and it made me think about this, that Claude Bouchard showed his Steve Blair's 1995 paper on changes in fitness this morning, and how each 1 MET change produced a pretty significant change in mortality. Well, this is data from 2023 in changes in fitness in over 50,000 U.S. veterans, showing many of the same things that Steve showed many decades earlier, but showed that regardless of whether you started at a low or a high fitness, changes in fitness still predicted your prognosis. Obviously, the best was the people who were fit to begin with and stayed the same or even improved further. But even if you were fit, if you lost fitness over time, your mortality was higher. And obviously, the people who were low fit to start with and lost even more fitness, they had the highest mortality during follow-up. And again, I think this is a pretty important finding. Now, stress was something that actually, when I met Steve Blair, the first time we met, we were both being on Meet the Experts at the American College of Cardiology meeting. He was talking a 25-minute talk on his fitness, and I was talking to him a 25-minute talk on cardiac rehabilitation. And I presented in my talk a quick talk about stress and cardiovascular disease, and he came up to me after the presentation on our very first meeting, and he said, I didn't know about the data on depression, fitness, and mortality. You know, so I said, man, that's pretty nice that Steve Blair came up and said I taught him something that day. But stress does affect cardiovascular disease, and mental stress does. I know Jennifer was speaking on that as well today. And Cicero said centuries ago, it is exercise alone that supports the spirit and keeps the mind in vigor. And we published this data years ago, and I think I was sharing it with Steve in my presentation back years ago at the ACC, that, again, we have a lot of psychological stress in our coronary patients, particularly in the younger coronary patients, but both following a cardiac rehabilitation and exercise training program, there's tremendous reductions in anxiety, tremendous reductions in hostility or unexpressed anger. And the thing that probably we care most about, because there's the most data around the world, is on depression. And depression is high in our coronary patients, whether they're young or old. And both groups get tremendous reductions in depression following cardiac rehabilitation. But what was more important, we showed that the depressed patients in our cohort had 4 to 5 times higher mortality during the next 3 years, even after correcting for other factors. And the control depressed, which was the depressed patients who didn't attend cardiac rehab, had 3 times the mortality compared to the depressed who did a cardiac rehab program. Now, this is not randomized. This is, you know, obviously somebody could say that, well, maybe the control patients are different than the patients who did the cardiac rehab, but at least their baseline factors all seem to be the same. So it seemed like the cardiac rehab program made a difference. And of course, cardiac rehab is not just exercise. It's also tender loving care. It's a lot of, you know, social bonding, the way psychiatrists use team sessions. So we tried to separate that, and we found that those patients, we had cardiopulmonary stress tests on all the patients, and those patients who did not improve their cardio fitness, didn't improve their peak VO2 with the cardiac rehab program, they continued with a very high prevalence of depression and a high mortality rate. Whereas those who just got a little bit improvement in their fitness, or got a moderate amount, had significant reductions in depression and depression-related increased mortality. So we suggested then that you just needed a little bit improvement in fitness to get maximal benefits. And in our cardiac rehab program, this is a paper of over 1,100 patients followed for 6 years. We showed in this paper that, as Bob Ross was talking this morning, in his studies, 28% didn't improve their fitness. We actually showed 23% in cardiac rehab didn't improve their fitness. And we showed that those who improved their fitness the most had the best survival. Those who had intermediate improvement in fitness had intermediate survival. But what we also showed, though, this is just measuring the peak VO2. I don't have this in the slides, because I didn't know Bob was going to talk about this, but those who improved their estimated exercise capacity, estimated METs based on the speed and incline of the treadmill, the way most of us around the world estimate exercise capacity, and certainly that's how Steve did in all of his ACLS papers, they still got very significant improvement in survival. The best survival was those who improved both their peak VO2 and their estimated METs, but those who didn't get any improvement in their estimated METs had the worst survival, and those who had one of the two had intermediate survival during the next 6 to 7 years. And a paper in European Heart Journal also of about 850 patients followed for 7 years, we showed that the strongest thing that predicted survival was the end of cardiac rehab peak VO2. Now, when I became editor-in-chief of Progress in Cardiovascular Disease in 2014, my very first issue was on obesity. And I, of course, knew that Steve had done papers in JAMA on obesity and fit fat way back in the 80s. So I asked him to do a paper, and he got Von Barry to lead the paper with him. and they did a meta-analysis of 10 studies that were prospective and objectively measured fitness and BMI and jointly assessed their impact on all-cause mortality. And he showed in this paper that compared with the normal weight fit, the unfit, and he defined usually unfit as those not falling in the bottom 20 percentile or bottom 25 percentile, they had twice the all-cause mortality regardless of their BMI. Where the overweight fit and the obese fit had similar survival as did the normal weight fit. Then they suggested that fitness was more important than adiposity for long-term mortality. Now, I actually wrote a book on this topic, The Obesity Paradox in Patients with Coronary Heart Disease, that it's interesting that many studies and meta-analyses are showing that the overweight and obese with cardiovascular disease are having a little bit better survival than do the leaner patients. And we looked at this from his aerobic center longitudinal study, and I actually had the privilege of writing 97 papers with Steve Blair that are now published on PubMed. And he and I talked a few years ago about that when we got 100 paper together on PubMed, we were going to have some really good scotch together. I don't think that matters too much now because I think Steve is having good scotch almost all hours of the day at this time. But anyway, in this paper that we did with Paul McCauley and several other names that we know, Mace Way, D.C. Lee, who's here, Tim Church, who we've heard about today, 10,000 coronary patients followed for 15 years, and we measured the fitness on the treadmill, and we measured obesity by BMI, percent body fat, and waist circumference, and showed in this paper during follow-up that the fit, and we defined fit being those who didn't fall in the bottom tertile, so relatively fit. Those who were relatively fit had a good survival regardless of their BMI, regardless of their waist circumference, regardless of their percent body fat. Whereas the non-fit, those who fell in the bottom tertile, had much higher mortality, and there was a strong obesity paradox. Among the unfit, those who were a little bit heavier actually had a better prognosis. And this is for all-cause mortality, and we showed the same thing for cardiovascular disease mortality. Now, I'm thinking right now that thinking about a paper that May and I just published 2 days ago, that almost all the papers that we've been doing have been on cardiovascular and all-cause mortality. We have a paper 2 days ago from Aerobic Center longitudinal study data that Josh Sparks was first author, showed that cardiorespiratory fitness actually predicted non-CED and non-cancer mortality. So CRF is continuing to gain strength as time goes on. In another paper, I joined with Ross Arena, and this is in 2,500 heart failure patients with systolic heart failure. Mike was talking about heart failure with preserved ejection fraction. These are people with weakened hearts, and we measured their peak VO2 by VO2 on the cardiopulmonary stress testing, and we defined having fitness as having a peak VO2 over 14 cc's of oxygen per kilogram per minute. That's not a very high level of fitness for those of you who work with this, but that's what's been used for heart failure for many years since Donna Mancini introduced it many decades earlier. And we showed that those who had relatively good fitness, they had a good survival regardless of their BMI. Whereas those who had peak VO2s under 14 had a much higher mortality, and there again, there was a strong obesity paradox. We had already eliminated the underweight patients, and again, this is mostly a mild obesity study because we only had a few patients with BMIs over 35 and none with BMIs over 40 in this study. And Steve Blair also introduced me to Ulrich Wisloff and his team in Norway in the Hunt study, and we had a paper in American Journal of Medicine a few years ago showing that there was also an obesity paradox in 6,500 coronary patients in Norway, but the obesity paradox was only present in those who didn't meet their physical activity requirements. If you met your physical activity requirements, you had a good survival regardless of your BMI. And then the next year we studied changes in BMI, changes in physical activity over time in coronary patients and showed that physical activity was way more important than weight. And in fact, there was no group where weight loss was associated with better survival, whereas those who actually were in the thinnest weights, who gained weight, had a little bit better survival in this Norway Hunt data bank. Now, this is a very important study that came out a number of years ago from Wen and colleagues in Taiwan. 450,000 people followed for 7 years. And basically, when this came out in the New England Journal of Medicine, in the Lancet, there was headlines saying that all you had to do is 10 minutes of exercise to get mortality benefits. So people loved that. That was the thing that got all the publicity. But what it also showed is that the more and more exercise you did, if it was moderate, you got a little bit benefit up to about an hour a day. But if you're doing vigorous physical activity, you seem to maximize out after only 30 to 40 minutes. And this is along the same line as a paper that we did. D.C. Lee, first author. Russ is on this paper as well as May. 55,000 runners, published in JACC in 2014. 55,000 individuals, 13,000 runners and 42,000 non-runners, followed for about 15 years. We showed that the runners had 30% lower mortality, 45% lower cardiovascular mortality. That's not a big surprise, but what we were surprised at was when we divided the runners into quintiles, the lowest dose runners got the same benefit as those who were in the highest 4 quintiles. In fact, there appeared to be a loss in benefit in those who were in the 5th quintile. So we took the 5th quintile and did a research letter and divided that quintile into tertiles. So basically, we showed in this paper that the top 8% of the runners, those who are running 7 days a week, those who are running over 270 minutes per week, they appeared to lose the benefit. Not worse than non-runners, but worse than those running less times per week. Certainly suggesting that more was not better, but even raising the possibility that more could be worse. And along that line, this is, Iman showed this data before, so I won't go about how in 1964, this 10,000 steps per day was the magic number, and Stens and all had a meta-analysis in JACC just last year, and basically showed that you just need to do somewhere between 7,200 and 8,800 steps per day to get maximum benefits for cardiovascular and all-cause mortality, so well less than the 10,000 steps, and I was privileged to write the editorial on this. I must say, though, that I think I'm going to stick with what Iman said today. Steve Blair said he averaged 13,700 steps. I think that's going to be my magic number. Whatever Steve did, I want to do. And so, but if we could give every individual the right amount of nourishment and exercise, not too little, but also not too much, we would have found the safest way to health. So in conclusion, I don't think I need to emphasize this because others did all throughout the day, but certainly I think we can get benefits from exercise at much lower levels than what's in the national guidelines, and certainly our running data would support this. And I certainly think that all of us, what we haven't done a good enough job with, maybe Jennifer's starting to do this, but we haven't done a good enough job of educating the clinicians and promoting exercise. We also haven't done good enough job. We've done great with the science, but not good enough job at promoting exercise in the public and getting a much higher penetrance of our data. Thank you very much. And again, this is something that I hear every day. Give it to me straight, Doc. How long do I have to ignore your advice? I used to say, I used to have a number on this. I don't know what the number is now, how many minutes somebody has to do, but I do think what fits your busy schedule better, exercising so many minutes per day or being dead 24 hours a day is a pretty good answer. Thank you very much.
All right, we have plenty of time for questions for Chip, so please raise your hand and we'll get you a microphone.
Thank you, Chip. My question for you is about the obesity paradox. The ding on the obesity paradox has always been that the lower weight group included sick people, heavy smokers, all of that. I've never heard anybody present that with you an opportunity to respond to it. So I wanted to give you that opportunity today to respond to that.
So many of the studies have corrected for some of that. Certainly many of the studies correct for smoking, which certainly that is partly involved too. Certainly that the studies do show that many of the obese with cardiovascular disease show up a little bit younger. Usually that's about 3 years, so not 20 years, but three years younger. And you can correct for that in individual and meta-analyses. And still the findings are very strong. I do think part of the reason is what I've said today about the fitness, but also the fact that some of the very thin, or even in the normal BMI group, which is kind of thin for our current society, many are physically weak. So it probably has something to do with muscle strength and cachexia. So what DC Lee is going to be talking about this evening, I think, is very, very important.
Thank you. I'm a visitor here today, and I haven't done any of the types of research you folks have done. What part, or can you measure what hormones contribute to the improvement of the fitness?
So we have a very detailed paper in Nature's Reviews in Endocrinology recently talking about the exokines, but there's so many that have been studied that may play a role. I think clinically, really, I don't think we have anything, probably with the exception of C-reactive protein, which is inflammation. I think there's tremendous evidence that improving inflammation, which happens with physical activity and improving fitness, plays a significant role in cardiovascular disease and probably in cancers as well. But there's so many other things that could play a role, but I think clinically, that's probably the one that has the most weight.
Jim Skinner and I have been going at this for a little while, amicably. And this might be a question for Claude Bouchard as well. I have some concerns about generations of stressors. And so even if you try to make everybody the same, the stress that, for example, slaves experience based on people who were not slaves is definitely going to affect their genetics. And so I get really concerned when I see these slides, and you did go a little bit fast, so maybe I missed it, but that's me, not you. But I get really concerned that maybe we're not controlling for generations of stressors that have affect our genetics. And so no matter how controlled we try to make our studies, Black people and people of color are going to fare worse than other kinds of people.
You know, I mean, that's something I think that would be a very hard thing to study, because you can easily study African American, you can easily separate genders, but going back to some of the generational stresses that could affect long-term epigenetics, that's going to be a pretty hard thing to study, at least as far as I know right now.
So is it ever going to be a situation where we just have to accept we're going to be different and we can't go back and figure out why it is just going to be different?
You know, I mean, I think that is certainly acceptable, and then you have to try to maximize the benefits or maximize other things to make up for things that are different in a negative way that might affect cardiovascular disease or cancer or other types of mortality. But with regard to exercise and fitness, I think that right now we don't know that does it have to be different. You know, certainly there's a tremendous variation in people's fitness among every race, every gender, and so I'm not sure that and Damon Swift is doing a bunch of work, and I think Leon is working on some of the racial differences as well. But I don't believe that it has to be that the African American population has a lower fitness. That's been shown in many studies, and have a less even response to exercise training, as was shown in the Droop project.
Any more questions? All right, well, welcoming and thanking again Chip Levy. All right, so for our second speaker, it's definitely my pleasure to welcome Jim Skinner. He's a professor emeritus at Indiana University, former president of the American College of Sports Medicine, member of many councils that's promoted physical activity, exercise, physical education research. Near and dear to my heart, he is one of the original PIs of the Heritage Family Study, along with Claude Bouchard, which I am now the director of, and that is housed here at South Carolina. And I could be wrong, but our chair, Sean Arendt, was telling me that his first ever abstract in Arizona was the Heritage abstract. So it all comes full circle. He has many publications, but like we've been talking all day, he really is a proponent of helping others, collaborating with them. And I can say, you know, the papers we're involved in, we're cranking out dozens of Heritage papers and abstracts every year. Might have 10 to 20 authors. Jim's been emeritus for many, many years, so you'd expect to hear crickets from him. He's one of the only co-authors you can guarantee you're going to get a response and edits from. So he really is paying it forward like Steve would do. So please welcome welcoming Jim Skinner, sorry.
Thank you, Mark. I, like all the others, I want to thank Jane and Ann and Russ and the others for inviting me here to celebrate the life of a very good friend of mine and of yours. And I always had fun with Steve. That's the one thing we learned a lot from each other. Well, I learned a lot. I don't know how much he learned, but when we were together, it was never dull, and we enjoyed being with each other all the time. Now, when I got the invitation, and I would say with Steve, Blair, it's going to be epidemiology, and that's not really my area. But then I started thinking, in 1964, I was working with Sam Fox at the Public Health Service, and Sam and I had just published one of the first review articles on physical activity and cardiovascular health. And shortly after that, Sam got an invitation, but he sent me instead to the Delaware Medical Association for their annual meeting. So April of '64, which is 60 years ago this month, I was there, and there was another person giving a talk by the name of Ken Cooper. And Ken and I had breakfast together, and while we were talking, he was mentioning that there was the possibility he was going to go to Dallas, and these people had some money, and they were going to try to have him get something started. And I'd seen Ken many times over the years, and when Steve and I were working, writing up the Drew study, I would come and spend time with Jane and Steve, and he didn't give me so much scotch now that I think about it, but so some of the others are even more special than I thought I was, you know. But we would work on that, and one day I was in his office, and Ken Cooper walked in with someone else, and he introduced Steve, and then he said, and this is Jim Skinner. He's an exercise epidemiologist working with Steve, and then he left. And so I said, okay, for at least 30 seconds of my life, I was an epidemiologist, so I feel a little more comfortable today talking here. The other thing we did, though, you can imagine that right after that, Steve and I had a long conversation of whether I was promoted or demoted. And we never resolved that, but we agreed to disagree on that particular aspect. So that was one thing. And then Russ said, well, when I was invited, that you should also talk about research that you've been doing. And I said, well, I've been semi-retired for a number of years. And my wife says semi-retired means I still work, but I don't get paid as much. And so, but I started thinking about some things that had been bothering me. And I don't know who designed the body, but they did a pretty good job of it. And I always told my students, think things logically, because once you know what's going on, it makes sense. And so I started looking at some things over the last couple of decades, and there were things that bothered me. And once I got the invitation, I started thinking about all this, and saying, I'm going to try to put together some things that didn't make sense until I really got into it. And so now that I've still got a few neurons that fire occasionally, and I've got a captive audience, I would like to present to you some of the things that I've been thinking about exercise, physical activity, health, and all of that whole area. Now, obviously, a lot of you have already seen this graph. Bill Haskell put it on there, and I'm glad Bill's on the Zoom call right now. But you see there's that big drop in leveling off in terms of fitness and mortality, and also with some things with activity. And Bill did it another way in saying the dose response curve, that just going from doing nothing to doing something, there was this big improvement. Well, okay. And Steve also pointed this, I did it again and showing that. And you can see that at that time, this was in the 90s, we were always basically thinking of aerobic activity. And what I didn't see, or at that time, I said, well, we just don't have enough information, but what's really happening when you go from doing nothing to doing something? Why is this going on? And so all of those physical activity guidelines were based on aerobic exercise, because that's what we thought about. Strength was added a little bit later, but that was mainly from a health point of view, the muscle strength with the aging and all of these things. So I looked at it and I say, well, so what they're saying is anything's better than nothing. But you have to realize that what they were doing, the object was to get the masses off their asses. So it really didn't make much difference what they said. The idea is do something, okay? But for the public health aspect, it was fine. But for a person who wants to understand why, I was sitting there still saying, why is it that if I just start walking a little bit, something's going to happen? What else is going on? Well, so I looked at some more. What I felt was that I didn't have enough information to make any kind of sense out of that. And again, we were talking more about aerobic exercise, and so we need more details of what is and what is not adequate, and how much do I have to really do from doing nothing to doing something to start to get a benefit. Well, so what is the difference between being in the lowest quintile of activity or fitness and going to the second one? And so the guidelines they thought, as I said, they tended to think aerobically, and strength was added later on. And most of the information was moderate frequency, intensity, and duration. But an interesting thing happened a little bit after that. For example, we always thought about, for example, insulin sensitivity in type 2 diabetes, that aerobic exercise, and then we get these advantages. And then lo and behold, we get this study that shows that if you do resistance training, you get the similar effect. So all of a sudden, we're talking about why is it we were talking about? I understand the aerobic part of it, because you're stimulating the fiber, and the fiber adapts and that sort of thing. But these are mainly the slow fibers, the aerobic fibers. Strength exercise uses the fast twitch fibers. So what's going on there? So that's what I started going into. And you see the same thing. Whoops, I went too fast. You see the same thing in the glycosylated hemoglobin. Whether whether you do the aerobic exercise or you do resistance exercise, you'll get this change. Well, so as I said, when you start talking about the difference between aerobic and strength exercise, the duration is generally long, whereas in strength it's brief. If the intensity is moderate and the other is high. But the main thing that you're seeing is, as you know, when you start looking at the muscle fibers utilization, it's mainly slow fibers at the lower intensities, and as they gradually increase, you get the others. So what we're doing now with the strength exercise, we tend to use the fast fibers, which we weren't using with a lot of the aerobic exercise. So there must have been something that's in the that we're doing with the fast fibers that's also important. And so we know, as I say, we use mainly type 1 slow fibers during the aerobic exercise, but type 1 and 2 slow and fast in the strength exercise. And just as you all know this, but remember that a fiber, it's an all or none law. The fiber contracts or it doesn't. So if you're contracting a fast, if the stimulus, once it gets above a certain threshold, you're going to get that fiber is going to fire. And what we do is as you need more and more intensity, you get more and more fibers. And then they normally sort of switch off to maintain a constant tension. So even when we're doing any kind of exercise, most of the fibers will contract. Okay, that made sense to me. And then we started hearing things about high intensity interval training. All of a sudden, not just aerobic, but if you do high intensity interval training where you're doing near maximal activity, or you're doing sprint interval training where it's supramax, what are we finding? The high intensity exercise are using the fast fibers just like you are in strength. But we're getting changes that people are talking about. When you do high intensity interval training, you're getting changes in VO2 max. You're getting changes in all sorts of other things that we thought before were mainly aerobic kind of things, changes. So, but it's similar. It's because of the fiber utilization, it's similar to strength training. And many studies have shown improved cardiometabolic variables and also in a lot of health disease states like diabetes and emphysema and a few other things. There's some variations into why this works, but you're still seeing what we've always thought before was more related to aerobic exercise. Now we're getting it with high intensity work, and so the difference is the total number of fibers that you're using. Okay, so then you get the next thing that came up that started making sense, and sometimes not always, was we're getting into inactivity physiology, and this is the model that Mark Hamilton and his group used, and this and this uses where you suspend the tail so these back muscles here don't work and only the front ones work. And you see during that 12 hours of inactivity, the activity of the muscle that's not being used drops very quickly and it comes back up. So that if you're inactive for a long time, you got some problems. And you see this again in this rat model, that here you have the slow twitch red fibers, the fast twitch red, and the fast twitch white. And you see the normal standing, this is the lipoprotein lipase activity. And when they're limited because these muscles aren't being used, you see there's a big drop in all three fiber types. Now the diaphragm, there is no difference because you have to breathe no matter where you are. But that's just to show that and especially in the slow fibers, you'll get a much larger reduction, but also in the fast fibers, you'll get reductions. And why is this important? Well, we know that what you're doing when you're using the fast fibers and the lipoprotein lipase, fast fibers at rest can still use oxygen. During exercise, they use glycogen, but at rest, they also use fat. And so that's important. And so here's a study done by Ed Coyle from Austin, in which they took 2 days of low, limited, or normal steps per day, followed by running 1 hour. And what you see is that if you walk, in this case, it was about 2,700 steps per day or 4,000 steps per day or up around 8,000 steps per day, that if you're doing very little inactivity, whether you did the hour running or not, it didn't make any difference. But if you got up to 8,000, around 8,000 steps, you had two things would be happening, and that one is your postprandial plasma triglycerides are lower, and you're using fat more in the system. Now, that's important because we know that when, if you look just at triglycerides, it gives you some information, but postprandial lipemia gives you more information in terms of risk. Now, here's another study. So what he suggested, go back, I forgot about that. He suggested that if you're very inactive and then you become active, it may take a little while, but if there's a resistance to exercise. And that maybe what you need to do is be doing it more often. And you know, and we always, the information on, with diabetes, for example, and insulin sensitivity, we would say exercise at least every other day because there's a carryover. And he's probably showing the same thing here, that there's a carryover if you exercise enough. If you don't have that problem, you got to work on it. So then he also did another study. He's been doing it. He's got a bicycle that gives you 4 seconds of sprint at a super maximal level. You sprint for 4 seconds, and you do 5 of these interspersed by 45 seconds of rest. So you do this every hour for 8 hours a day. So you're doing a total of 160 seconds of exercise. All right? That's less than 3 minutes a day of exercise. And the following day, what he would do then is give them a high-fat meal, and he would draw blood at 2, 4, and 6 hours. So what do you see? You see that there's lower triglycerides in the group that did the sprint as opposed to the control group. No difference in glycogen utilization, but you've got a 43% increase in total body fat oxidation and 31% lower triglycerides. And that's important because this shows you, as I mentioned already, the association of triglycerides with future cardiovascular event. If you look just at fasting level, it gives you some information, but not a lot. But if you look at the non-fasting, it gives you, it's a much stronger predictor. And we don't live fasting for the most part. We're generally eating during the day. And if you can somehow reduce the amount of fat in the blood, that's going to be helpful. So I think this is how, since postprandial lipemia is a better predictor, it seems that maybe it's important to get these fast twitch fibers also active during the day. Okay, so as I said, type 2 fibers can oxidize fat at rest, and high-intensity interval training has been shown to increase mitochondrial activity and possibly fat oxidation in type 2 fibers. So we're not only just doing, if we do only aerobic work, we're using primarily we're training mainly the slow twitch fibers, not so much the other. So I think it's important to do both. So perhaps after high-intensity exercise, more muscle fibers are oxidating fat, and as a result, we're going to get lower postprandial lipemia, and that may be one of the reasons why you get a lower mortality in people who are also doing strength work and some of the high-intensity work. But see, when we were thinking back in the 90s, it was all aerobic. We talked about walking and walking a little faster, jogging, these things. But we didn't get too much into the strength work and then eventually into the high-intensity work. And here's a study that was done in Australia, and Ayman Lee is one of the authors on this, Stamatakis in that group there, and where they would do 15 to, just by exercising for a few seconds at a time, they found that if they did 15 to 20 minutes a week of just this high intensity but short duration exercise, you'll get a decrease in your mortality. And so you're seeing the same sort of thing going on and on and on, that this is a very short, another type of thing, a very short activity, but high intensity. And so you're seeing the same kinds of curves over and over again, and this is looking at the all-cause mortality and this was males and females. Now, we have this study, too, in which we looked at, with inactivity physiology, Peter Kaczmarczyk showed this part and said, okay, if you've got, wait a minute, I'm doing this, have the same problem some other people did, that if you're inactive during the day and you sit all the time, here's your death rate, and if you're sit almost none of the time, here it is. So you see there's about an 80% difference there. Well, what happens then if you're active, but you're active and you meet the guidelines, but you do your half hour of exercise or 45 minutes of exercise, and then you sit for 8 or 10 hours, you're better off than the people who are never active, but you're still 30 to 40% higher mortality rate. So your active couch potato is getting the benefit from the exercise side, but there's also an effect of inactivity on mortality. So being more active and being less inactive are the message from here. It's not just being inactive. If you have to be more active and less inactive. And here you see the estimated risk of all-cause mortality, looking at different kinds of activities. The people who are less active, you see there's a big change there. The people who are already active, you don't get much of an effect by adding some of these daily activities. So what does this all tell me? Contractions of type 2 fibers are associated with reduced risk, especially in inactive people. I think the active people are probably getting enough protection, but the inactive people are getting more protection because they're getting involved with doing some of these higher intensity, even brief activities throughout the day. So active people should continue being active to maintain their lower risk, but inactive people need to increase their activity levels to reduce their risk. So what we need is, I think the physical activity guidelines need to be revised. We've talked a little bit about putting in the number of steps and those things from the aerobic side. I think what we need, though, is this. The active people, you probably don't have to change the guidelines a great deal. Because if they're doing the activity what we're saying of 150 minutes a week, they're probably doing what they need to do. But they need to have more information on the risk of being inactive so that they can be active in following the guidelines, but if they sit in front of the television or the computer for 8 hours a day or 10 hours a day and they lose some of that benefit, they also need to be told that what they need to do is to decrease their inactivity. On the other hand, the inactive people need much more information and direction on what to do. I mean, especially regarding high-intensity exercise. You know, if you tell a lot of people, I want you to exercise 4, 5, 6 days a week and 150 minutes a week, a lot of people are going to say, there's no way I'm going to do that. It's a nice idea, but there's no way I got a half hour a day, or that I'm going to, maybe, once you've been fit, you understand this. If you've never been fit, this doesn't make sense to you. But when you're trying to tell someone to exercise for 150 minutes a week, they're going to say, I probably won't even start. But if you could somehow explain to them that by doing the moderate, the brief high-intensity exercise is less boring and take less time, then they can still have positive effects. I think we would get more people who are inactive to start doing some of the things they should be doing. And then maybe once they've got some of those, they might go into do aerobic as well as anaerobic high-intensity exercise. So what I learned from all of this and trying to put all this together, because things didn't make sense sometimes, is that you need to be more active and less inactive. Both are important, but those who are inactive need much more information about what to do to try to get them so they can reduce their risk as well. But I don't think the current guidelines is the best way to do that. So thank you very much for your attention and listening to my ramblings here. Thank you.
All right, thanks a lot, Jim, and thanks for staying on time. When you first said your talk was going to be about things you didn't understand, there was a chance we were going to be here all day, so thank you. I open the floor for questions and comments for Dr. Skinner. Nicole? I can bring you
So I have a comment, followed by another comment, followed by a question. And my first comment is, Jim, this is so important. Thank you for sharing this. You got to get to Gretchen Reynolds and whoever else will listen. I know that these data are published. Nobody's reading them. Nobody who needs to read them are reading them. And it is so important that that message gets out to the general population in any and every way possible. So important, and thank you for sharing this. My story about Jim has nothing to do with this talk, but just so that you know what a great guy he is, Jim speaks more languages than anybody I know. And I was at a president's reception, and there was this woman standing in the corner, and I asked her name. She's by herself. She didn't know anybody. She said her name was Mei Ling. I asked her where she was from. She told me, I don't remember. And I said, well, you're at the president's reception. Let's go meet some presidents. So I was taking her around, and I was introducing her to presidents, and I introduced her to Jim. And in her native language, she's from Asia, Jim asked her where she was from. She lit up. Then they started talking about her hometown. I had no idea what they were talking about. They were laughing. She felt happy. This is a wonderful man. And everyone needs to know what a loving, wonderful man he is. I want to thank you, Jim, because for my entire career, you've made me feel important. You've made me feel like I've mattered. You've listened to me. The most important thing you ever did was introduce me to Steve Blair. No, I'm kidding, but it is true. You did introduce me. If not for you, I would not have known Steve. You're an amazing person. And I said, comment, question. My question is, when are you going to start telling popular media this story? Because you're accomplished, you're a scientist, people will listen to you, and this is going to save lives. So when are you going to start?
I don't think I've ever stopped, but I'll go as long as I can. You know, as I said, I just try to understand what's going on myself, and this made sense to me, and it just turned out that as I tried to prepare for this, that there was information out there that didn't. We see all these little bits, but no one had put it together, so that's what I tried to do. And I will keep trying to do that. But I think it's important, like as you said, to let more people know that there are other ways to become fit. Just like this morning when John Jakichi said, you know, what do you do, what's the best program? The one you enjoy and that you'll do. But we ought to let them know that there are many ways of doing it, not just the one way that someone says, I like to run and therefore you should be running. So that's the point. There are all kinds of ways of getting fit or being more active and have better health.
It should be on every front page forever.
I hope this doesn't sound like too dumb of a question. This is a patient's question rather than a researcher's question. When you all talk about moderate and vigorous exercise and intense exercise, what do you mean?
In general, you know, the definitions are, if it's moderate, if you can walk and talk a full sentence with no problems. You know, and it's more vigorous when you start to, you're breathing a little bit more. Now, what that says in effect is your aerobic system is not quite as adequate, your intensity is high enough, you start using anaerobic glycolysis, you're breaking down, you're building lactic acid, and as a result, you have to breathe, and therefore you have trouble talking. And so when that's sort of the bridge between moderate and vigorous, then you have very vigorous, that sort of thing, you know.
Do those same rules apply to the other exercises other than running or walking?
Well, that's That's in terms of that. And when you start talking about strength exercises, basically you're talking about around 80% of what you can do one time, one RM maximum repetition. That's 80%. That's moderate to vigorous. That's sort of the point right there. You're back around 50%. That's moderate and it's easy to do. But when you get up to 75, 80%, that's more vigorous.
You know, some of what Jim was saying with just the short bouts of exercise, the running data that DC published in 2014, Jack, was along the same line with the dosing, is that just 5 to 10 minutes of running per week gave the maximal reductions in, at least associations with reductions in cardiovascular and all-cause mortality. And so doing more was not better, at least for cardiovascular and all-cause mortality.
Jim, I'll maybe make a comment or question. So if you follow this field of everyone going to what's the smallest amount we could do for benefit, I've seen some people call it, exercise snacks. So do you think our guidelines should just have a snack more?
Well, whether you call it a snack, because some people think of snacks that they're thinking, well, I'll do a little moderate activity, walk into the refrigerator, and that's not what you want them to be thinking about. But like I said, there's some evidence saying, if you run up the stairs and you do this 5 or 6 times a day, that kind of thing, there are some benefits to it. So how much is, we talked about, or IMEN this morning talked a little bit about what's the minimum number of steps. And so again, on the aerobic side, we've got a fair amount of information, but on the other side, where people can maybe do that and not be concerned about, when the high intensity interval training came out first, I was concerned because I knew there were studies, for example, showing that firemen who had all that, and they had to run and carry a hose and run up a stair, and they were getting ECG changes. But of course, they were under a lot more stress and carrying a lot more weight. But still, I had this in the back of my mind that, we can't control the high intensity exercise, but they do it for such a short time that it's really not that much of a problem. So.
Thank you. All right, that concludes this session. Thanks, everyone. Thank you again to our speakers.
Okay, I guess we should probably go ahead, get started. Good afternoon. Hi, my name is Mei Sui. I will serve as the chair for today's last session. Thank you for hanging on there. This is the last session. You will hear 3 presentations from Steve's mentees. So they're all here. Myself, I'm also Steve's mentee. People often ask me, how you know Steve? Well, long story short, so after I graduated from University of Alabama at Birmingham, I got my first job at the Cooper Institute in 2004. That's, when and where, I met Steve and also Jean. So then, back in 2006, right, Steve, moved back to Columbia, South Carolina. He basically took me with him. That's why I'm here. This is really how I met Steve, how I entered the field of physical activity and exercise. There is a Chinese word, it's called, I don't know, James, if you might know, you know a lot of Chinese, 生命中的贵人. So translating to English means someone in your life significantly influenced your life. So I really consider Steve is such a person in my life. I still remember, back 6 years ago,
when my husband suddenly passed away, Steve gave me a huge hug. That hug makes me feel so loved, makes me feel so special. Bob, Chip, I still feel special. You know, maybe you guys need that hug, right? To feel special. So I really want to thank you, Steve. If you could hear me, see me, thank you so much. Okay, okay, this last session, we have 3 speakers. They all Steve's, I guess, most recent mentees. So they each will speak about 15 minutes, following with 5 minutes question and answer. So our first speaker is Dr. Lee, or maybe DC Lee. Steve's postdoc, currently a full professor at the Iowa State University, where DC and I, we kind of joined the exercise department around the same time, back in 2007. So we became colleagues and friends since then. So I really consider DC a rising star in my mind. He is a physical activity epidemiologist, trained by Steve as his postdoc. And he has really a great record of peer-reviewed publications resulting from both cohort studies and his randomized control trials. So today, he's going to talk about the title of his presentation is What Type of Exercise is Best for Health? Please help me welcome to the podium, DC Lee.
Yeah, it's also my. I will jumpstart my topic. So HLS is well known for CRF, but also HLS has a very unique data about muscular strength, and which is my one of the biggest interest. And I'm going to talk about half of my talk is about weightlifting and muscular strength, another half aerobic exercise and cardiorespiratory fitness. So this photo, Steve brought his Olympic torch, 2012 London Olympic torch that he carried. Then he was carrying the torch on the hallway, and then, of course, came by my office. And he was very proud, of course, and he was very, very happy. And as you all know, he's very direct and honest, sharing and expressing his thoughts, brilliant thoughts. But he's also very direct and honest, sharing his emotion. And that's what I'm trying to be, like Steve, not going around, but be direct to my students. So, yeah. And then this is the photo of my family. 2 of my kids were born in Ames, Iowa. And that photo, would not exist if Steve's not accepted me. And this is the format that I presented some years ago at the HSM Symposium. And Steve really liked it. He came to me and great job, son, and he shook his hands. And so I want to use the same format. So Hulk is a strong man, as you know, and he probably enjoys weightlifting, resistance exercise, and Flash, as you know, super fast and fit, and probably enjoy aerobic exercise. So I have two representatives in my talk. I just forgot to say one other thing. My dear friend Francisco Ortega at University of Granada in Spain, he just sent me two photos that he asked me to include, but I couldn't add it. But there are armies of students in University of Granada, as well as University of Almeria, University of Cadiz, that Steve mentored, the last 10 years when he was here. And they are my best friends. And yeah, so there are not only here people today, but there are, again, many, many people around the world are watching it. And that's another big things that I got from Steve, all those connections. Okay, so before we compare, I want to show you two slides about the benefits of being strong and doing weightlifting. So this is a meta-analysis, and we found that strong men and women on the top, roughly 30%, had about 30% reduced risk of all-cause mortality compared to the weak person at the bottom, roughly 30%. And then this is data from the HLS. And then as you can see here, even less than 1 hour of resistance exercise is good enough to reduce the risk of all-cause mortality as well as total CVD events, CVD morbidity and mortality. So I'm going to show you many bar graphs, but you can forget all those things and just follow the image. So I put the Hulk here. Lower bar, the better. I know this is the last session, so I will try to make it simple and easier for you to understand. And then let's look at the benefits of fitness and aerobic exercise that you all know very well. So I just have two slides. So this one shows the changes in cardiovascular fitness. And the message that I want to focus on is the middle group. So even though you maintain your cardiovascular fitness, you can reduce 30% of the all-cause mortality. But I put the Flash over there, so you get the biggest benefits if you can improve your fitness over time. And this is the running paper. The original idea was from Russell Pate. Steve came by my office and, hey, DC, I have an idea for you to work on. And then that was the running study, originally from Russell Pate. So as you can see here, runners had about 30% and 45% reduced the risk of all-cause and cardiovascular disease mortality. Okay, let's now let the competition begins between Hulk and Flash. Who lives longer and who are healthier? So this is the one of the study. I think it's very important because we included a man with hypertension. But as you can guess, the cardiologists, some of them might be afraid prescribing weightlifting for their patients with hypertension because their blood pressure increases significantly when they do, high-intensity weightlifting. However, what we found here was, you can see here 3 groups, lower, weaker, moderate, and strong. And then by also fitness, low fitness and high fitness. So I put the Flash here because the Flash has a high fit but a lower strength. And then you can see the Hulk in the middle because there are 3 groups and there are 2 groups by CRF. So I put in the middle. So as you can guess, the benefit is quite similar in men with hypertension in terms of all-cause mortality. However, this group who is fit and strong, you can see the gets the biggest benefits. And then when we look at the arterial stiffness, this is the cohort that I established at Iowa State University. You can see, Flash probably gets a little more benefits, although it was not statistically significantly different. but you can also see, the biggest benefits occurs those people who are strong and fit. Those were strength and fitness, and let's compare the behaviors, resistance exercise versus aerobic exercise. So this is in this study, the outcome was incident metabolic syndrome, and you can see the 4 groups. This is the ideal group, who's meeting both aerobic as well as muscle strengthening guidelines. And this is you can see Herc here, meeting only resistance exercise guideline, and Flash here, meeting only aerobic exercise guideline. And what we found is the people who are meeting both was the only group showing the significantly reduced risk of developing metabolic syndrome. And also when we look at the hypercholesterolemia, it was very, very similar. This is also from the ACLS data. And again, meeting both was the best, rather than Flash and Herc. Then this is the review paper done by Angie Burlington, my colleague, and she's sitting over there. We conducted really wonderful study that I'm going to present later. But one point that I want to point out here is these are different health outcomes, and then you see 4 groups in each outcome, meeting no guideline at all, meeting only resistance, meeting only aerobic, and meeting both. So regardless of the outcome, one thing is very clear, meeting both guidelines, you can see here gets the biggest benefits. Okay, so those data are all from observational studies, and there are many benefits in observational studies, but there are also significant limitations that people over-report their exercise and physical activity. There's a reverse causation and confounding. So clinical trial is needed in almost all topics I think in our field. So we conducted a clinical trial called Cardio Race. So we had 4 groups, no exercise at all, aerobic exercise only, resistance exercise only, half and half. So all 3 exercise groups did 1 hour, 3 times per week, so it was time matched. And then we had about 100 participants, and this was a 1-year-long exercise clinical trial. Then the primary outcome was, as you can see here, the composite score of well-established 4 CVD risk factors, including systolic blood pressure, LDL cholesterol, fasting glucose, and percent body fat. And then again, you can see those 4 different groups. And here's the outcome. So we look at each CVD risk factors, but this is the primary outcome. So as you can see here, those 2 groups, aerobic only and half, those were the 2 groups showing the significant improvement in CVD composite score. And so there are simply 2 messages. If you're concerned about heart attack or stroke, CVD health, I think you want to include the type of exercise that Steve enjoyed, running, walking, those aerobic exercise. However, the other, the message that I want to focus is the combination group. They did half aerobic, and half of the aerobic was replaced with the resistance exercise. And then that group is the only group that also improved muscular strength and lean mass that the aerobic group did not improve. So the message is if you are only runner, you can maybe run half and replace half, then you get a same benefits on CVD risk factors, but you get additional benefits on muscular strength, for example. So that's, I think, one of the kind of novel message from this clinical trial. And then the big question is, why not? Why there's no benefits in resistance exercise? Was the intervention studied well, delivered well? So we had 94%, sorry. Okay. So you see here, we had only 6% dropout over 1 year, and then 82% exercise adherence rate. The other data that I want to show is here, we also measured 1RM bench press and leg press, And as you can see here, resistance group showed the biggest improvement, baseline 6 months and 12 months. So resistance exercise was delivered as planned. And if you look at the CRF, aerobic group improved the best. However, the combination group improved both strength as well as fitness. So that was not the kind of the explanation why resistance exercise did not show significant benefits. However, this meta-analysis recently published, 2022, and this one shows the J-shaped graph. So let me explain. So this is the minutes per week of resistance exercise or muscle strengthening activities, and this is the relative risk on cardiovascular disease, morbidity, and mortality. So what they found is 60 minutes per week showed the best benefits on CVD. However, people who were doing 130 minutes or more, they started to lose the benefits. So those U-shape, river J-shape, that exist also in resistance exercise and CVD. Then probably many of you think, why? What are the potential explanations? So we look at the published papers, and then we found two potential explanations. One is if you do lots of weightlifting, ultra stiffness, increased ultra stiffness was one of the potential explanation. The second is a chronic inflammation. However, the limitation of the data is there's no dose response data from resistance exercise. So we, and this is the amount in cardio race. So they were doing again 1 hour, 3 times per week. So maybe the resistance exercise in the cardio race trial was maybe too much, maybe not. And then we proposed a new study to test whether that J-shape is true from clinical trials. So the original idea was Aimin emailed me maybe 2-3 years ago, hey, DC, I have a great idea. Let's have a Zoom meeting. And then we wrote it and it's funded. So we will test whether that 60-minute provides the best benefits on CVD risk factors. The primary outcome is the same as a cardio race. And also we will test if that J-shape is true, then this group should not improve composite scores. So we will test it. This is a 1-year long intervention, and we will have 240 participants. So I'm very, very excited about this study. We will start to launch the study this coming fall. Okay, let's go back to the original question. So between Hulk and Flash, who is healthier and live longer? Then the answer is Superman, who is strong as well as super fast, right? You guys know how fast he can fly the Earth, right, in those movies. Then the million-dollar question is, how can he make people Superman, right? That is not my expertise, but I had one study, I did one study, and this is the result. Very simple, and probably most people on Earth, they know it. Buy a gym membership and go to the gym. One thing is, aerobic exercise, you can go out and run. You don't have to have equipment. But in terms of resistance exercise, you need weight, right? You need to add a resistance. So the gym is the perfect place, and it's not for everyone, but we wanted to know. So gym members and non-members, the members should meet, the percentage of meeting the guideline must be higher. So that was not a surprise. So as you can see here, compared to non-members, members, less than 2 years, 2 to 6 years, 6 years or more, you can see 11 times, even though they had a membership less than 2 years. So you can, clearly the answer, the finding is not a big surprise that going to the gym, buying a gym membership will increase the percentage of meeting the guideline. However, the magnitude was surprised. I was surprised that's 11 times higher odds of prevalence of meeting the guideline. So, But there are, of course, many questions, how to stay in the gym for a long time. Again, that's not my area of research, but simple message is, you want to improve both strength as well as fitness, and one simple answer is bio membership. Stay there and go there and stay there for a long time, because you can see here the prevalence is much higher. Thank you.
Yeah, I guess we are a little bit over time, but probably take a couple questions if there is any questions for DC. Okay.
Hi, I love your analogies. They're wonderful. In the gym membership trial, did you guys correct for confounding variables like income, for example, to be able to purchase the gym membership and accessibility to the gyms in the area, things like that? Did you guys control for those variables in your study?
No, and then that was not a trial. It was a simple,
sorry, not a trial.
Yeah, sorry, I couldn't clarify those at the beginning. It was a simple cross-sectional study. So we did a survey, whether they have a gym membership or not, and then we asked their physical activity, as well as we measured blood pressure, grip strength, and resting heart rate, some other outcomes, also waist circumference. One other surprise was the gym members had about 1 inch less, smaller waist circumference. But again, that was a cross-sectional study. So, it's the one potential problem is active people are more likely to go to the gym, buy a gym membership. So we need that's why we do clinical trials, right? We recruit people and then provide a different type or intensity amount of exercise, and then we measure the outcome baseline and at the end. But we adjusted gender, smoking and other common confounders, but not the variables that you just mentioned.
Right, because I'm also thinking too with waist circumference, for example, people who have the money to purchase a gym membership are also going to be more able to access nutritious foods, and so totally. But I'm glad to know that gender and things like that were accounted for.
Yeah.
Hey, DC, real quick, right here. DeMarcus Heller, former student of Dr. Stephen Blair and Larry Durstein, the legend himself. I just want to ask a question regarding the cross-sectional study that you had presented. Did you guys look at nutrition at all? Was that
in the gym membership study?
Yeah, in the gym membership.
I don't think we did. However, one other surprise was one research question that I had. Maybe the gym members, have a lower activity level outside of the gym. And then we found no difference at all. Members and non-members, their activities outside the gym was equal, because we asked their activities in the gym and then their lifestyle activities. But I don't think we measured diet. It was a $10,000 internal grant that I got in my second year of assistant professor. So. But that's a very important factor.
Gotcha. Cool. Thank you.
Thank you. Okay, our next speaker is Dr. Leanna Ross. She was Steve's last doctoral student and now an assistant professor at the Duke University. So Leanna and I both worked on the energy balance study, where she is studying here. So her research focused on precision exercise intervention to prevent and also manage chronic disease. So the title of her presentation is, exercise training for long-term resilience. So again, please help me welcome to the podium, Leanna Ross.
Good afternoon, everybody. I am truly honored to have been asked to participate in this session following all of these incredible scientists and family members that have been connected to Dr. Blair. I still can't call him Steve. He will forever be Dr. Blair to me. And similar to what others have said, it's really cool to hear all of these amazing connections and relationships that have been built. And I started to feel a little bit like you said, you know, maybe I'm a little less special. But then as May said, I realized I have that one thing. I'm so fortunate and blessed to have been his last doctoral student. And he was more than a mentor and a teacher and an educator. He really seemed like a father-like figure to me. Being 13 hours away from home, I knew that I was well taken care of by someone who really cared about me, including Drs. Durstein and Sardzinski here, as well as Dr. Swee. So, as his daughter Anne knows, this is one of our favorite pictures. So, for those that have not met me, I am currently probably standing at about 6'3", as I probably was in that picture. I wear heels on top of being almost 6 feet tall, barefooted. And anytime we would take a picture together, Dr. Blair, who is, how tall would you say? 5'4", 5'3", 5'4" on a good day. Every time he would go up on his big old tiptoes and I would scrunch down. So that's why in this photo it appears that we are much closer in height when in reality there's probably about a foot of difference in us in this picture here. I am so fortunate to have been mentored by him. In undergraduate, I had some experience in the lab as a researcher, but that experience was limited to microbiology. And in the year and a half I was in that lab, I appreciated it, I learned a lot, but I thought, okay, being under a hood, working with Petri dishes and Staphylococcus aureus samples, it just really doesn't seem like that area of science and research is gonna be my thing. And then I came down here and started my master's degree in the Department of Exercise Science and started to work with Dr. Blair. And even during my master's, I thought I would never get a PhD. That's just not for me. And Dr. Blair was the one that said, I will write your letters of recommendation for physician assistant school, but he's like, I really think you have potential to be a leader in this field one day. And he said, if you stick around and do your PhD, I will take care of you. Where I am today, and all of these incredible people that I have interacted with, and the opportunities that I've had, and the mentors since him, they're all dedicated to Dr. Blair, and because of those doors that he opened for me and seeing that potential in me to become a researcher. So during my time at South Carolina, I started to develop interest in a couple of areas of exercise science, one of which was the dose-response effects of exercise, and the second of which was inspired, actually, by the original Dr. Ross sitting over here, and the individual variability of these responses to different doses of exercise. I saw a presentation at the very first ACSM annual meeting that was presented by the OG Dr. Ross, and he introduced this concept to me of individual variability. And after ACSM, I returned back to campus, and Dr. Blair was always like, you need to start thinking about your dissertation. I mean, this is like one semester into my PhD. Gotta start thinking about your dissertation. I said, I've got an idea. I saw this talk by Bob Ross, and this is what I want to study. And I'm very fortunate that those opportunities and interests led me to Duke University and the Molecular Physiology Institute to a postdoctoral fellowship with Dr. Bill Krause, where I now continue on as a faculty member, where I've been able to combine those interests and passions that were started in the lab with Dr. Blair, and individual variability of responsiveness and dose-response effects of exercise, and the physical activity epidemiology work that I started to learn under Dr. Blair. And now I conduct longitudinal follow-up studies, observational studies of former structured exercise intervention participants, looking at the long-term dose-response effects of exercise and how that might differ between individuals. And so before I tell you about the long-term effects of exercise, I need to at least give you a little bit of a substrate of, or an understanding of the substrate that I do this work on. So the STRIDE studies, led by PI Dr. Krause, were a series of 3 NIH-funded randomized controlled trials. This is a super brief overview. In short, the first STRIDE study, which randomized previously sedentary adults with overweight or obesity, recruited to have mild to moderate dyslipidemia, compared the differential effects of aerobic amount and intensities of exercise compared to an inactive control group. The second STRIDE study, similar to what Dr. Lee was just talking about, took a very similar study population and instead compared what are the effects of aerobic exercise to resistance exercise compared to what the combination of the two might be. And the third STRIDE cohort was called STRIDE Prediabetes, and this cohort was similar, but they were actually a little bit further along the disease spectrum into developing chronic disease as they were recruited to have prediabetes. These all were 6 to 8 month exercise interventions, and I'm going to go over a brief highlight of the first STRIDE study's design. So the first group was an inactive control group. The second group was what we call our low amount, moderate intensity group. These participants were participating in about 14 kcals of energy expenditure per kilogram per week of exercise energy expenditure, which was roughly equivalent to them doing a brisk walk, so a moderate intensity as was explained a few minutes ago, about 13 miles a week. Next, the third group there listed, they did the same amount of exercise, but they did a higher intensity activity. And then finally in group 4, this was also vigorous intensity exercise, but the amount of exercise was increased to about 23 kKWs, or 22 miles per week, roughly. So if you look at groups 2 and 3 in the middle there, here we have held the amount of activity constant between the two groups, and we have differed the intensity of the activity. So we're able to discern what is the intensity effect while holding amount constant. On the flip side, if you look at groups 3 and 4, here we have the intensity of the exercise held constant, but the amount is what we are testing here. And so a quick overview of what was found in STRIDE 1. Here I have examples of 2 more metabolic-related outcomes, looking at changes in triglycerides and changes in the insulin sensitivity index. Here, one of the very neat and surprising at the time findings was that actually for some metabolic outcomes, doing moderate intensity exercise, that group that was doing more of the brisk walk versus the jog and run, they actually had more beneficial effects on these metabolic outcomes of changes in triglycerides and insulin sensitivity. And this kind of challenged like conventional thinking at the time where it was like, more and harder exercise is better. Well, not necessarily for everything that you're looking at. And in fact, if you look at the bottom panel there for change in insulin sensitivity, if you compare the second bar of the low amount moderate group to the high amount moderate group, in order to get that same benefit that the low mod group got, the vigorous intensity groups needed to do double the amount in order to get that same metabolic benefit that just the low amount of brisk walking group received. On the other hand, change in percentage of peak VO2 follows our more typical knowledge of a straightforward dose-response relationship where the inactive control group doesn't see any beneficial change in their percentage VO2 peak. The low amount moderate group significantly improved their fitness level. The low amount vigorous groups, you increase the intensity, you get more of an effect. And finally, if you increase the amount on top of that increased intensity, you get, on average, the largest effect. So I want you to keep those dose-response effects in the short-term response to training in mind, as now I transition to talk to you about the legacy effects from the STRIDE 1 trial. So I thought it was very fitting today that I would talk to you about the legacy health effects of exercise, as we're here to honor the legacy of the one and only Dr. Blair. So this topic of the presentation seemed like a no-brainer to me, and I'm so excited to share this information with you all today. So what is a legacy effect? What we were wondering is now we are pretty sure, outside of the individual variability that we see, we're pretty sure on average we can tell what dose, mode type, amount of exercise is going to be most beneficial on average for a certain health outcome. So we're wondering, okay, those short-term benefits, do they potentially persist over time? And if so, are any of those health benefits actually specific to the original amount and intensity of exercise that participants were engaged in? And so enter the STRIDE 1 reunion study. So in medicine, in the medical literature, back in 2008, it was the first time that the concept of a legacy health effect was mentioned in the literature. And some studies that were looking at long-term follow-up of pharmacological interventions where the drug trial had ceased and the treatment had ceased, participants were no longer taking certain medications, whether that was in a statin trial or a glucose lowering trial. And years, up to 10 years after cessation of the trial and the medication, those that were on those intensive therapies actually still saw persistent benefits in things like heart outcomes like mortality, disease development, et cetera. And similarly, a couple of diabetes prevention program-like studies saw that intensive lifestyle interventions were seeing these similar long-lasting legacy health effects. And so we wanted to know, well, what about just a strict exercise-only structured intervention? What potential long-lasting health effects are there? And so what our group did was we invited former Stride 1 participants back, participants that had originally graduated the original trial, back for an observational follow-up study, approximately 10 years after their study completion. We had 104 participants return for the reunion study, and we assessed things like their VO2 peak, fasted blood samples were collected, we measured waist circumference, blood pressure, and they completed medical history and physical activity recall questionnaires. Importantly, we wanted to note that we saw a really high enthusiasm of our Stride 1 reunion participants to come back for follow-up testing. So what did we find? So first, I'm going to orient you to how this graph as well as the other panels are going to show. So on the far left, that bar represents the inactive control group. Next to that is the low amount moderate intensity group, followed by the low amount vigorous intensity group and the high amount vigorous intensity group. Here, all of the bar graphs that I'm showing are representing the 10-year reunion time point value of that outcome minus their baseline value. So this actually, the change score encompasses that actual intervention time as well as the ensuing 10 years afterwards. So the first legacy effect that we found was related to the intensity of exercise and change in peak fitness level over time. And so the left two bars are the inactive and low amount moderate intensity group bars. And over that 10.5-year period, we saw an expected about 10% decline in fitness over time. However, if you completed one of the two vigorous intensity exercise programs, they saw only half that decrement over time, where they only lost 5% of their fitness compared to baseline. The second things that we saw were actually related to the low amount moderate intensity group instead of the vigorous intensity groups. So changes in mean arterial blood pressure as well as fasting insulin continued to persist as sustained benefits over time, especially for the low amount moderate group. And then the final legacy effect that we saw was looking at changes in minimal waist circumference, where the inactive control group continued to gain in their waist circumference over the follow-up period. However, participation in any of those three exercise groups actually mitigated that change in waist circumference over time. And next I want to illustrate another way that we looked at the change in fitness over time, where here, instead of analyzing the participants based on their randomization group, here these were participants that were in one of the three exercise groups, and they were categorized based on tertiles of change to the short-term intervention period. So this is the 8 to 9 month exercise intervention that they did, what was their magnitude of change there, and then based on those tertiles, how did those three categories fare over time with their fitness levels. And so what was really neat here that we saw was that if you were in the highest tertile of that short-term response, so the green line there that's on top, they saw a really large increase in their relative fitness level. And then over time, they saw essentially the same rate of decline over time if you look at the slope here compared to the slope of the other two groups. However, because they had that really nice improvement in their fitness in the short term, we termed that they were almost resetting their baseline, so that even though they saw the same rate of decline over time, they ended up no different than they were before they even started the intervention. And this is something that's really fascinating to us, and one that we are starting to continue to investigate in the other STRIDE cohorts. So I will preface my continuing the legacy portion here as these are data that are from an ongoing reunion study of the third STRIDE cohort. The study is not complete, so these are unpublished data, but I couldn't resist the chance to present some new data hot off the press, not even at the press yet, in honor of Dr. Blair's legacy. Because as any former student will know, whenever he was up at the board teaching, he would say, "Show me the data. I want you to argue with me if you disagree with me, but whatever you do, show me the data." So this is new data in honor of Dr. Blair. So far we have consented 83 participants that were former STRIDE PD participants. The data that I'm going to show today are preliminary findings from 74 participants that have completed our reunion follow-up study. The average follow-up time is a little bit longer than STRIDE 1. Participants are on average about 12 to 13 years out. And with this iteration of the study, one, we were extremely fortunate to receive funding from the National Institute of Aging to perform this work. And we were able to add in some additional assessments. So for example, this time around, we're including BOD-POD to have a more objective assessment of body composition changes. We've added accelerometers, additional health-related questionnaires. And so what I've done here is I have copied the figures that I've showed you from a few slides ago with STRIDE 1 shown in the green bars on the left, compared to the magnitudes of response that so far we are seeing by groups in the STRIDE PD reunion study. So what we're seeing in changes in minimal waist circumference on the left, the STRIDE 1 reunion cohort, everyone, as I mentioned, kind of mitigated that gain over time, and that inactive control group was the one that significantly increased their waist circumference over time. If you look on the right, in our STRIDE PD groups, nobody is going up in the positive direction. These participants are all showing trends to where they are lessening their waist circumference compared to when the baseline of the original study. And in fact, the high amount vigorous group, which is the second bar, and the low amount moderate group here are actually significantly less in their waist circumference compared to baseline. Next, I wanted to take a quick peek at what was happening with change in their relative peak VO2. This is percentage change, so it's set up just like the STRIDE 1 reunion. And here, I was a little bit surprised. So on the far left of the STRIDE PD panel, our high amount of moderate intensity group actually saw a pretty significant decline so far on average, where they're averaging about a 16% decrement over time. And then if I draw your attention next to the next group, that's our high amount vigorous intensity group. And they're actually seeing in STRIDE PD about a 10% decline in fitness. And this is basically the exact same prescription. Oops, sorry, I've joined the crew and hitting the wrong button every time. This high amount vigorous group here in STRIDE 1, that's basically the same prescription that was done in this group over here. And they're seeing over half the amount of decrement over time compared to STRIDE 1. And again, I know these are preliminary findings, but as I mentioned, I'm interested in individual variability, so I wanted to do a quick peek and look at something that was easy to see if there's something going on individual variability-wise by doing a quick check of some potential sex differences that are happening. And I'll keep your attention drawn to that high amount vigorous intensity group, because so far that's the most surprising finding to me. And lo and behold, the men are seeing almost an 18% decrement in peak VO2 over time in that group, compared to the women, where they're not much different from baseline, and they're seeing about a 5 to 6% decrease over time. So the next question we have is, well, maybe that's potentially related to some changes in body composition, since now we have BOD-POD data available. And so a preliminary look here is looking at, broke out by women and men. Women on the top half, men on the bottom half. Fat mass is in the green bars. Lean mass is represented by the purple. And total body mass change is shown in the blue. And I'm going to keep your attention drawn on my fascination with the high amount vigorous intensity group here. And if you look at the women in the top there, they are significantly losing fat mass and total body mass and have preservation in lean mass compared to baseline. If you look at the bottom graph for men, men seem to actually be increasing in fat mass, potentially losing a little bit in their lean mass, and no change in their total body mass. And so the relationship between body composition and peak VO2 is something that I can't wait to explore more as a potential mechanism for why we're seeing the differential sex responses to vigorous intensity exercise in this group. So for future directions, I can't wait to dig in when all of the data is finally collected, and we've done reunion studies actually across all 3 STRIDE cohorts, so we'll have data on about 250 participants. I can't wait to dig in and use some new bioinformatic approaches with some of our colleagues at the University of Minnesota to do a more precision medicine framework and analytic approach to try to identify patient phenotypes that are gonna be more likely to have a beneficial response in a certain health outcome, not only in the short term, but also potentially translating that to a sustained benefit over time. And finally, I'm really excited that in a couple of months through a career development award, I'm going to be able to, what I'm calling retrain some former STRIDE PD participants in a legacy cohort where we are undertaking prescribing them to their same original exercise prescription in relative terms to what they did when they were in the study 12 to 15 years ago, and compare their individual magnitudes of response to the original intervention study, and what does their magnitude of response look like now that they've aged another 12 to 15 years. So stay tuned. I'm so fortunate to be able to do this work. Again, all of these ideas, were seeds that were planted under my days of learning with Dr. Blair. So thank you so much for your time and attention, and thank you to Dr. Blair, his family, and all of my USC family members here. It's been a wonderful, wonderful ride so far, and I can't wait to see what's to come.
Well, I think, again, we are, Mike, not hear me? Oh, okay. Sorry. Again, I think we are really behind our schedule. I probably need to borrow, I don't know, maybe 10 minutes from Tom. But anyway, probably a couple questions for Liana, if you have.
You didn't have to do it. Go back up there.
I can go. Thank you.
You're welcome. You didn't have to jump. That was a lovely talk, Leanna. My
Thank you.
question may be just more of a clarification. So the amount, as it was defined in STRIDE, if I saw correctly, it was 13 miles per week.
That's a rough estimate. They were actually prescribed based on kcals of energy expenditure per kilogram per week.
Okay,
so it was actually consistent among individuals based on 14 versus 23 kKWs for the amount effects in STRIDE 1.
I think you've answered my question, which was if the 2 groups defining low amount are doing 13 miles a week or so, what your slide said, if one does it at moderate intensity, the other does it at vigorous, they're going to have a different total energy expenditure.
Yes, absolutely. Yeah, I should have clarified that. That's just depending on the different audiences that we're talking to. Some people might look at me like I have two heads if I'm speaking in KKW prescription terms. So that's just kind of a rough estimate. It's a little bit more translatable. Yeah.
Hi, Leanna. I just want to make a comment. Seeing you from the very beginning to now, I'm just so proud of your growth, and thank you for giving your talk. I'm sure I'll hear lots and lots about this, so I guess I'll keep it easy. But the PD people obviously are pre-diabetic, so much different. So I'm sure you and Bill have thought about this for hours and hours. What are your just anecdotal thoughts of maybe that's why they're worse or not,
Yeah, it potentially is. So that's why I cannot wait for this study to be completed to look at all the data. Because one of the things I am really excited to look about is actually disease progression, because we're collecting 10-year medical history as well as current medications and looking at are there any differential responses even in disease development, potentially to type 2 diabetes or cardiovascular diseases, whether that differs by their original prescription group, and then as well being able to parse out potential outcomes and how that's related to disease activity or not.
And in PD, have you looked at them irrespective of group and more of the high response, low?
Not yet.
I don't want to use responder.
Not yet. Thank you, everyone.
Thank you. Okay, our last, but I guess not least speaker, Dr. Rabin Shuk. He was a doctoral student and also a postdoc fellow of Steve's. Rabin also worked, Rabin now is an associate professor at the University of Missouri. So Robin also worked on the energy balance where he was here in the USC. I mean, I guess now you heard a lot about energy balance. Robin is, his research is really focusing on energy balance and the lifestyle approach for healthy behaviors. So the title of his presentation is Physical Activity, Appetite, and Energy Balance. So again, please help me welcome to the podium, Robin Shook.
All right, last presentation of the day. You can stand up if you want. You need to stretch, wake up a little bit before we wrap things up today. It's totally okay. We're at the end. I'm going to try to go through this really fast just because we're short on time. But when I was at some point during my doctoral work, Steve and Greg shared with me some studies from Jean Mayer in the 1950s. He published 3 or 4 in a series that were looking at the associations between energy intake, physical activity, and body weight. The slides you're seeing here, the figures you're seeing here, are from one of those studies that involved adult males in India who worked at a rope factory. They made rope. And just like any factory, different employees have different jobs that they do within the factory. Some of those jobs are more sedentary. So in this case, supervisors, clerks, things like that. Other people have jobs that are more physically demanding. So they might be welding, they might be weaving the rope, some might be blacksmiths, and some might be carrying these big 220-pound bales of rope around. And what Mayer noticed is that above a certain level of physical activity, energy intake was closely correlated with the amount of physical work that they were doing, or their occupational energy expenditure. Below a certain threshold, energy intake became uncoupled with physical activity and energy expenditure. And the result is intake in the most sedentary group that is above all of the other job classifications, which, if you look at the top panel, ultimately ends up in higher levels of body weight. So Mayer called this the everything above that threshold, the normal activity range. John Blundell at the University of Leeds, who many of us in the room know, he calls it the regulated zone. And everything below that threshold, Mayer called the sedentary zone or the non-responsive zone. Blundell called this the non-regulated zone. And of course, there's some limitations to this research, but I think the overall implications are quite interesting, that physical activity acts on energy balance, not just through its role on energy expenditure, but also on the role of energy intake. And so, as you heard many times today, around this time, we were doing the energy balance study. And we thought that maybe we could reanalyze similar data using a more contemporary approach. So that's what we attempted to do with the energy balance cohort. 430 people. We did rigorous assessments of energy balance at baseline, and then we also followed them up every 3 months for a year. You've seen the one picture from the energy balance study, but you haven't seen the original study team members. So in our super cool gray shirts, you see the whole team there. There's Jennifer Trilk, there's Amanda Paluch, there's May, let's see, there's Vaughn Berry, there's John Sieverdes, Megan Bruce in there, Ed Archer's in there, so we got the whole original crew in this picture. Here's the updated picture that Greg showed earlier. Okay, I'll quickly go through this. So instead of classifying people by their occupational work status, we used their quintile of physical activity. So we had 5 groups. Group number 1 was our least active group, getting about 6,000 steps per day. Our most active group was getting about 10,000 steps per day. Then I attempted to just recreate the figures that I showed you at the beginning from my air. And what you'll see is pretty similar using a contemporary approach. It looks like there does seem to be some threshold above which energy intake seems to match the amount of work that is being performed through moderate to vigorous physical activity. Below that threshold, we see not decreasing levels of energy intake with lower levels of physical activity, but actually increasing levels of energy intake. So then the question becomes, well, what is exactly going on? What might some potential mechanisms be? And that's what I've spent most of my time since I left South Carolina trying to understand. I'm only going to show you one little bit of that data. That's from a study that we just finished about 4 months ago from the study called Activity, Adiposity, and Appetite in Adolescents, study number 2. So this is, we actually received funding from NIDDK to do 2 studies. The second study is an exercise RCT that's still ongoing. Not going to talk about, or I'm not going to show any results from that study here, but I will show you the data that we've just received from study 1, which is a cross-sectional study in teenagers. So first thing I'll show is who we tried to recruit. We wanted to get a mix of active and inactive kids and across a range of BMIs. So we recruited a quarter of our sample who were normal weight and inactive. A quarter of our population was normal weight and active. A quarter is overweight, obese, inactive, and a quarter is overweight, obese, and active. We measured a lot of different things in this study. I'm only going to talk about 2 here today, and that involves our assessments of appetite. So we had these kids, these teenagers, come in for a morning visit following an overnight fast, and we gave them a breakfast meal that is equivalent to 40% of their resting energy expenditure. And then we had them rank their hunger for the next 3 hours using visual analog scales. So we gave them it's on an iPad, but we asked them the question, how hungry are you right now? And there was a line. On one end, it was, I'm not hungry at all. On the other end, it said, I've never been so hungry in my life. And they would draw a line where their hunger fell on that line. The other measurement that I'll talk about today is we measured insulin sensitivity using the hyperinsulinemic euglycemic clamp procedure. I'm just going to quickly go through this, but here is our study population. We ended up with 46 kids in our study, and you can see the group breakdown there. Average age was 16. This slide just confirms that our normal weight kids were normal weight and our overweight kids were overweight or obese. So our normal weight kids, which you see in these 2 columns, had a BMI percentile of about 50, where our overweight obese kids had BMI percentiles of about 92, 93. Next slide is showing that we also properly recruited our kids based on activity status. So steps per day for our active kids were about 9,000 and 8,500 steps per day, and our inactive kids got about 5,000 and 6,000 steps per day. Oops. The data that you're seeing here is data from the insulin clamp. So what we're looking at here is insulin sensitivity as defined by glucose infusion rate. Lower levels of glucose infusion indicate insulin resistance. Higher levels of glucose infusion represent insulin sensitivity. And you can see this is the essentially minute-by-minute data from the clamp organized by group. Here is the steady state data organized by group as well, so just the last 30 minutes of each clamp. So as you can see, the normal weight active group had higher levels of glucose infusion compared to all the other groups, meaning they're more insulin sensitive than the other groups. You'll note none of this is significant at 0.05. This is likely due to our sample being underpowered, and we're taking note of this for the subsequent study. But just because our 4 groups, we kind of anticipated that we would be on the threshold for power for this 4 groups. So we also planned on just grouping, collapsing the 4 groups into 2 groups. So in this slide, or in these 2 figures, I'm showing just the individuals organized by active and inactive kids. And so this is their glucose infusion rate, and here you can see that, oh, sorry, I just blinded Leanna there, sorry. The active kids had higher levels of glucose infusion than the inactive kids. This is statistically significant after adjusting for sex. When we grouped them the other way by body weight status, we actually didn't see any difference in glucose infusion between the normal weight and the overweight obese kids. The last thing I wanted to show was how glucose infusion rate is associated with hunger. So along our y-axis, we're seeing glucose infusion rate. Along the x-axis, we're looking at hunger area under the curve. So this is the 3 hours of hunger responses that we have. We calculated the area under the curve. Higher levels of hunger, AUC, represents higher levels of hunger following the breakfast meal. And the dots are organized by our inactive and active kids. So what you'll see here is that our active kids have a positive correlation, a positive association between glucose infusion and hunger area under the curve, and we saw nothing among our inactive kids. So you may be saying, this seems kind of counterintuitive. Looks like maybe the active kids are hungrier than the inactive kids, but I think the proper way to interpret this is that the hunger responses in our active kids are proportional to the metabolic demands within the active kids, which hopefully, theoretically, means that they are more likely to have a balance between their intake and their expenditure. I just wanted to close out by giving my reflections on Steve, especially those reflections as a student of his. The first thing he told me when he agreed to be my mentor was, "I'm the worst advisor ever." And not so sure that that's true, but I want to go through one explicit example. So early in the stage of my dissertation, I emailed him a copy of my specific aims. He was traveling, of course, internationally at the time. I sent him the email on Tuesday, January 22nd. His response was 5 days later. And no one today, we've heard a lot of great stories about Steve. We haven't heard any email stories about Steve. So I'm going to show you an actual email that Steve sent. Dear Robin, I am really embarrassed at how long it has taken me to review your aims and get comments back to you. Please feel free to nag me in the future if I'm taking too long. I think you are on a good track with these, and I only have a few minor comments for you to consider. So anyone who has received an email from Steve recognizes some classic Steve Blair hallmarks here. So let's go through them. Dear Robin, every email was always addressed, Dear so-and-so. Rarely did you get an email that just said, Robin, DC, Jennifer, or no salutation at all. Steve always addressed people with Dear. He said that he was embarrassed about how long it took to respond. It took 5 days. That's pretty dang good, I would say. And he was the first of my committee members to send back comments. In fact, Greg, I think I'm still waiting on your comments. Then he says, please feel free to nag me in the future. And I can't remember where he was when he was traveling on this particular occasion, but it was right around the time he was having beers with Bill Clinton in the oldest pub in the UK, or when he was having lunch with the Nobel Prize Committee. It was right about one of those times. So yes, Steve, you should stop what you're doing to review my dissertation aims on resting metabolic rate. And then the final thing was he always said some comments to consider. Remember, I was a lowly PhD student at this time. He could have easily said, Robin, make these changes. And in fact, he, at the time, had an H index of 90, and mine was 3. But still, he just wanted me to consider whether I should accept his comments or not. And I could go on. I do want to call out a couple other things. A few months before this email exchange, he paid for, again, I think we were second-year doctoral students, he paid for Amanda Paluch and myself to go to a conference in Australia, in Sydney, Australia, as a reward for our work on the energy balance study. Not only that, out of his own pocket, he paid for our partners to go with us on this trip. Shortly after this, he received the Lifetime Achievement Award from the Obesity Society. I helped make like a couple slides for him. And as you've ever saw a Steve Blair presentation, he would always call out colleagues who had given him slides. This slide I received from Claude Bouchard. This slide I received from Bob Ross. He did the exact same thing to me in his TOS Lifetime Achievement Award talk, just for helping to make a couple slides. These things seem really minor, but as a doctoral student just starting out, they're very important. Steve and Jane have been so kind to me and my family since I first met them in 2004, way back in 2004, believe it or not. It has continued since I've moved on from my doctoral work. He's given me countless opportunities to give lectures, to travel internationally, to China, to Israel, to write book chapters. He grossly overpaid me for watching Fifi, his cat, when I was a doctoral student. And even most recently, when he has passed through Kansas City, where I live now, he and Jane have joined me and my wife for lovely meals. And these things, as we've all talked about today, just mean so much to all of us. So I decided to let Steve believe he was the worst advisor in the country, but in fact, we all know that's not true. There's no one that I wouldn't want to work with. I've tried to model myself after Steve, not only professionally, but personally, and I know Amanda feels the same way, and DC, Leanna, and John, and Vaughn, and Sarah also feel the same way, that we are grateful for all the opportunities that he gave us, the respect that he gave us, and the kindness that he offered us. So thank you very much. Thank you, Russ, Jane, May, for inviting me to talk. So thank you.
I think, Russ, we are really over time, right? Do we want to take a couple questions or not? Probably. Maybe one question for Robin, if there is an. Sure.
You all seem so close, and it's really cool. And being in a PhD program is hard, and lots of people end up never speaking to one another again. Can you say what it was about Steve Blair that held you together like glue?
I think we might all have individual responses, but the common themes I think are the themes that you've heard from everyone today, is that he treated you with respect, he treated you with kindness, he challenged you intellectually, and probably most importantly of all, he made you feel special. And when you're in a room full of really smart people and really smart other students, feeling special sometimes really helps you get through the challenges of a PhD program, the challenges of a study, the challenges of life.
So I was fortunate to be kind of mentored by Robin as he was a doctoral student and then as a postdoc, and then he went on. But one thing that I think is really common amongst us, and that you see in great people like Dr. Blair, is that when they're that special of a person, they surround themselves typically with other people that are like them. And that extends to students and postdocs and junior faculty that he worked with. So for example, like when Dr. Sarzinski came, like he knew this is going to be a great junior faculty member for me to pair with. So I think, just knowing that like he surrounded himself with the best of the best, not just scientifically, but personality-wise. And that's, I think, partly what makes us stick together is we all get along so well and respect each other and love each other.
I have two things. One is research. That's the connection between me and Steve and me and everyone else. The second is person. So if I see two things and I'm go crazy, working hard, whatever the topic is. So I think that's the two things that I think my answer to your question.
So what I've learned is you don't have to treat your doctoral students, postdocs, early career faculty like less than human. The more human you treat them, the better off they're going to be in their career. And I think that's an important lesson for all of us, no longer early career faculty, to learn, and I hope everybody heard that. Thank you.
Absolutely. Yep.
Thank you. Let me just conclude this last session before we have our final comments from our Dean, Tom, and our Chair, Sean. So again, as Steve's mentee, we all are, whether doctoral students or postdoc, I think we all really cherish those memories, those great memories that we have with him. I think it is those memories that we share with him that make us feel special, because he's a very special person. In this world, there is only one, Dr. Stephen Blair. He makes us feel special. So I feel special too. Thank you.
For those of you that don't know me, I'm Sean Arndt. I'm the chair of exercise science. And I take particular pride in the fact that even though technically Steve was retired when I got here, I still consider myself his last chair. And I found out from Ann that he did as well. So I appreciate that fact. I also think he'd appreciate the fact, given how much fitness meant to Steve. I think he would be incredibly impressed by the endurance you all have shown today to make it through the whole day. So well done. I don't know what the equivalent in steps would be, but it's got to be impressive. Before I say some things in closing, one of the things that I want to note is the tremendous amount of respect that I had for Steve Blair, even before I knew him, but certainly more when I knew him. I want to introduce somebody that I have that kind of respect for as well. And I am very fortunate to have called my dean for the last 5 years and consider a friend, and somebody who I think has been another exemplary role model for those of us in the Arnold School. Dr. Tom Chandler.
Thanks, everybody. It's wonderful to be here to see some alums, some former faculty, some retired faculty, and see how well everybody's doing. Thank you, Sean, for the nice introduction.
I'm short, so
Oh, there you go. Okay. You're not that short. I can't say enough about what Steve meant to me. I've been deaning for 17 years, and Steve was with me the whole time. The whole time. And he was somebody that I could always count on for advice, for support. We met in 2007. It was shortly after I signed on what I thought was going to be a very short term as interim dean. And Steve came into my office. He wanted to make sure that I understood the history and the importance of exercise science to the University of South Carolina, because Steve was one of the founding faculty in that program way back in the days, I guess in the 60s, right, Larry? Yeah, in the 60s. And he especially wanted me to understand his particular role in building that history of the department. Not in a boastful way, mind you, but he did manage to work in a bit about his career accomplishments, which I did appreciate, and that I found mostly pretty interesting. So I used that early discussion as an opportunity to tell Steve a little bit about my own much less impactful career as a marine ecotoxicologist. And when Steve heard the word toxicologist, he perked up. He perked up and he said, "Hey, my little brother Aaron is a toxicologist. You must know him." Sadly, I didn't, but I did know his name. And I looked at him and I said, "Wow, Aaron Blair is your brother?" And he looked at me puzzled. He said, "Well, yeah." I said, "Steve, I don't know your brother personally, but I had in fact just relied on Aaron or one of Aaron's studies for a grant that I'd submitted the previous year to the EPA that got funded. And Aaron, that was your study on 2,4-D and chlorpyrifos, looking at health care, or not health care, but looking at the health of workers exposed to those pesticides." So I poked at Steve a little bit of fun, and I said, "Well, it looks to me like your little brother became the real scientist in the family, given he worked for the National Cancer Institute and the NIH, and he does field work." And Steve kind of laughed, but clearly he was proud of his little brother, Aaron, and he frequently mentioned you to me, and I'm so glad you're here today. And I met you once before, but this is only the second time we've been able to meet. So there's certainly some very good academic genes in that Blair family tree, including Jane and Ann, of course, and of course Aaron. And Steve, I can tell you, spoke about you all often to me, and he was so proud of his family on many different levels. But what I like best about Steve, and you've heard this from many others today, was how generous he was with his time. He was very productive, but he always made time for people. And I always knew if I stumbled, he'd be there to help me out. And I stumbled a lot in those early days as dean. He always offered sage advice on leadership, how to win over difficult personalities. Imagine that, difficult personalities in the academy. And how to be an effective leader and an effective fundraiser. That was very helpful to me. He was tireless in his devotion to helping his graduate students. You've heard about that today. His postdocs, and especially early career faculty. Up until the end, he was engaged with their early career faculty, helping them succeed and build strong academic lives and careers. And as you can see from so many of his mentees that are here today, he was very effective. We all mentor, but we are not always effective. And as Claude Bouchard said earlier, Steve was truly ein Mensch auf Menschen, a man among men, a human among human beings. And that is such an apt description of Steve. And I want to finish with a funny story, and I'll never forget it. As you know, Steve raised a lot of money when he was director of the Cooper Institute. So as a new dean, I needed some help in that department. And I spent a lot of time going around talking to Rotary clubs, garden clubs, just about any civic club that would give me an audience. And I would talk about public health and give a PowerPoint presentation and various aspects of our School of Public Health. And mostly I just bored the shit out of those folks. And they rarely gave me much money. But then I had an aha moment. I said, wait a minute. Steve raised a lot of money. And Steve was always stopping by my office on the 4th floor, although he was down on the 1st floor, to use the dean's restroom. He was convinced my restroom got cleaned more often than the other restrooms. Wasn't true. I paid the custodians. I knew it wasn't true, but he was convinced that was true. And then he spread that rumor through the graduate student population. And now I can't even get in my restroom. And 2 of them are sitting and standing at the back, Eric and Scott in the back. Thank you, boys. But Steve would drop by my office, and he would say things like, well, he's always preaching the fat but fit mantra. Fat but fit. How he hated BMI as being too simplistic and overrated, and how just 50 minutes 3 times a week of moderate cardio, Tommy, was sufficient for you to live to be 100 years old. And I should try to get 10,000 steps a day. And then he'd ask, Tommy, how many steps have you got today? I've got 7,538 steps. And usually I was far, far below that. And then on his way out, he'd grab a handful of candy out of my candy dish, and he'd go back, and I'd see him a few days later, and I loved those visits. I really loved those visits with Steve. Anyway, back to the aha moment. I asked Steve if he'd join me on one of the fundraising trips to speak to a civic club over in Camden to talk about the merits of fat but fit. He agreed and even seemed quite excited. A road trip with the dean. What fun. So I did my usual spiel about how $3 spent on public health measures turned out to be $7 or $8 in economic return to society. Snore, snore, snore. And then I brought the Steve machine up to the podium. And I have to show you what Steve did. Steve swaggered up to the podium. Comes up. Got his jacket all buttoned up. Comes up. Looks at everyone. He says, where's the handheld? Is that it? Hello? Anyway, he came up to the podium. He said, I'm going to give you all a talk about the benefits of vigorous cardiovascular exercise and eating right and not enjoying life very much. And then you're going to want to get up and get out of here because you don't want somebody telling you what to do, correct? And of course, the audience is like, oh, yeah, another egghead professor. And then Steve would say, but what I'm really going to share with you is look at me. And then he'd unbutton his jacket, and he'd throw out his belly, and he'd say, I'm going to talk to you about what it's like to be fat but fit, and you all can do it. And then he would give the most remarkable, wonderful seminar to the group about the things that you all have talked about today, and they would listen. And they gave money. They gave money. It was great. And he did that with me a couple of other times. Rotary Club here in Columbia and another benefit up toward Blythewood. But I so appreciated that kind of interaction with Steve. He was great. And of course, best of all, what I would call all these moments is what I call moments with Steve, and I'll always remember them. They gave me a chance to get to know him very well early on in my deanship. I grew to know and love the man. I knew he loved me, and all of you in the Blair family, you need to know that I so respected Steve, and I appreciate so much that you, Jane, and you, Ann, and you, Max, wherever you are, that you shared him with all of us sitting here today. And I know I speak for everyone in this room. I miss him very, very much, and I think about him often. And thank you for allowing us to do this wonderful tribute to this great man. So thank you.
You know, it was funny when I came here to South Carolina. I was at Rutgers for 17 years before this, and just the thought of coming into a department, a school, with the legacy that this one had, that had been built on people like Steve Blair and Russ Pate and Larry Durstein and Mark Davis and Greg Hand and all of them. It was an amazing opportunity. And the thing I quickly realized, and Steve, so second day on the job, I'm sitting in my office trying to figure out what the hell I'm doing. Because if anybody's ever moved into a department chair position, you realize that first, I don't know, 6 months, it's like drinking out of a fire hose. But Steve stops by randomly, just, how are you doing? Checking in. Honestly, just kind of shooting the shit with me. We talked about the history of South Carolina, some historical facts about the university. Somehow it devolved into talking about different types of scotch and his enjoyment for those. And then he left. And I looked at my watch and I was like, I just had a 45-minute conversation about nothing but everything with Steve Blair. How freaking cool is this? And I realized that, you know, I don't think there's any doubt Steve was a prolific scientist, but he was a legendary human being. And I think that's the lesson I take from all of this. It's interesting because if you think about the number of people that know of Steve Blair, it's remarkable. It's millions. We saw his citations earlier, but I'll tell you what, those of us who got to know Steve Blair were the ones who were truly blessed. And it leaves us with something, whether he's still here or not, he's still with us. And I think getting to know Steve Blair as a person was one of the best parts of this job. And he always had this way of stopping by and sort of saying the right thing at the right time. And he was always so kind about it. You know, and so there were so many things I loved about Steve. Number one, he made me feel tall. And that normally only happens if I'm hanging out with like 10-year-olds, right? So I loved when he'd stop by because I would stand up. I wouldn't just sit at my desk. I had to go stand next to Steve like for a moment. I'm like, this is pretty good. I like this. Thanks, Steve. But you know, it was one of those things where he would talk about anything. And it was funny. Susan Jurgen made a comment earlier about how Steve found a way to connect with her about her hydration work. And it was funny because here I come into this department in a school of public health, and my background's human performance. I'm a sports scientist. And I'll tell you what, Steve was every bit as glad to talk to me about the testing he started with football and sports and athletics as he was about just physical activity. Every bit, and he was well-versed in it. And we can have those conversations. Now, I'll never forget, there was one day, I'm sitting in my office, and there were times where I felt it was a bit of a struggle for people to grasp that human performance in military and athletes is still a part of public health. And so it was just kind of happened one of those days, and Steve stops by, and he looks at me, he's like, what's wrong? And I told him, I'm like, I don't know how the fit is. I don't know if everybody appreciates this. And he just pauses for a second. He goes, do you know what one of the first grants we had was in this department? And I looked at him, I'm thinking, you know, American Heart Association, NIH, and he looks at me and goes, just like this, Gatorade, you'll be fine. And he walks away. And I'm like, you're amazing, right? So it was one of those where he always just had a way of doing this. He was always so humble, where it was always, the number of times that he would say to me, and it was funny, Robin, when you were showing the email and the whole, I'm embarrassed it took me this long, he would cop in, talk to me, and then be like, you know, I'm sorry for bothering you, and he would walk away, and my response to him was always the same, Steve, it is never a bother. I enjoy those moments. Much like Tom said, I miss him. I miss him just popping in. I miss, after a faculty meeting, him stopping in just to go, thank you for your leadership. That was a great meeting. He didn't even have to mean it. I didn't care. Steve Blair said it, right? It was good enough for me. And so it really starts, I miss him wheeling his suitcase down the hall with his stuff in it. Like, it's those things. But it's funny because there's certain moments that I'll always remember. But I think one of them will always stand out to me. So my wife, Michelle, and I had gone over to Jane and Steve's for dinner. And I think to set the stage for this and sort of everything that goes on to this, it wound up being one of those very surreal moments where two universes collided. The Steve Blair I knew of, and now the Steve Blair I got to know. And it was awesome. And I'll just never forget, we're sitting there, and so he treated libations much like a 7-course meal where they kept changing. So I'll never forget, at one point, we're at dinner, and Jane, amazing cook, and we look over, and Elvis the cat is eating out of a high chair, as he does. And I'm like, and I'm just hanging out with Steve Blair. Okay. And then somehow, by the way, for those of you that have been to Steve's house, he doesn't have a liquor cabinet, he has a liquor closet. And he kept disappearing into it and coming out with something new. And I'm like, wow, okay. So the fact that I can even still tell this story and I remember anything is actually pretty good. But I think one of my favorite parts, too, is after dinner, we go in and Steve shows us the horse collar and we've got all that. But anyway, he starts telling stories. But the best part about this is pretty much every story, Jane would correct. She's like, not quite, right? And so it made it great. And I just remember thinking to myself, God, these are two awesome people, right? This is an amazing experience to see. And it's one of those things that any of us that knew Steve realize what kind of person he was, right? And one phrase, and I said this last night at the dinner with the speakers, but I want to reiterate this because it's a phrase that always comes to mind when I think of Steve. It's nice to be important. It's more important to be nice. And that's what I will always remember about him. And what he's done for the field, that'll last. But what he's done for us is something that each one of us has a unique advantage over others to have experienced. So, Jane, Ann, to reiterate what Tom said, thank you for sharing him with us. It was a highlight of my career, but more importantly of my life, to get to know the man and to see the love that he has for you. And like I said last night, Ann, at the risk of making you cry again, though we've kind of gotten this out of the way, it's like delayed onset muscle soreness, you're good. It's like just previous exposure. I think the reality with him is he leaves an incredible legacy behind, but you're the legacy he's most proud of. And we know that. And so thank you all for doing this. And I do want to make one announcement that I think is very cool. So we saved it for this. We are starting the Stephen N. Blair Horse Collar Endowed Scholarship Fund in his honor. This fellowship has been established through the vision and generosity of Dr. Jane Blair and Dr. Ann Blair Kennedy. It will honor Steve Blair's legacy by supporting doctoral students across the Department of Exercise Science and the Department of Epidemiology and Biostatistics who have, and this is the important part, the curiosity and work ethic to address important questions in the sphere of public health as well as demonstrated financial need. There's a history behind the name for this, right? And we got a little exposure to it earlier in some slides, but Steve was named the Honorary Order of the Horse Collar Knights at the Blair Symposium. This order was established many years ago by the faculty of the Department of Exercise Science of the University of Kuopio, Finland. By the way, for anybody in Finland that I'm murdering this, I know it's really late there, so you're probably already off this, so I'm good. The honorary order has been bestowed upon some of the world's most distinguished exercise scientists. The Horse Collar Knights were so named because a horse collar allows the horse to pull the plow through the field. Thus, the Stephen N. Blair Horse Collar Endowed Fellowship Fund is being established to help a deserving individual do the all-important work in the field of public health. If you're interested in learning more about how to support this fund, there is a QR code on the back of your program today with a direct link. Information can also be found on the Arnold School's webpage, or you can reach out to our Director of Development, Lauren Johnson. And I do also want to acknowledge the efforts that Russ Pate and May Swee, Barbara Rieger, my assistant, who has put tremendous efforts into this, all those within the department around all of the amazing speakers. You all crushed it. Steve is looking down and he is smiling and he's probably thinking of some things that he's correcting in his mind right now that we said wrong, okay? I also want to acknowledge all the grad students. Thank you all. Much love to you guys. You know how I feel about you. You guys were a big help today, and I am always proud of you. So thank you very much. One last order of business. Ann and Jane, you guys mind coming up for a second?
Thank you.
So we have a little something for both of them. It's an engraved plaque of this symposium to honor Steve. And I know that this is what he wanted. And Jane, from day one, you were very clear on what you wanted the vision for this to be. And I sincerely hope, on behalf of the Department of Exercise Science, on behalf of the Arnold School of Public Health, that we pulled it off and you think Steve would be proud of what we did here today. Would you like to say anything to anybody?
I just would like to say thank you to all who participated in making this happen. Steve wanted Claude to give the speech that he gave, and he did a wonderful job. And he wanted a scientific symposium that emphasized the science, and that's what it's been. And May and Russ and Larry and just everyone that has participated in this, thank you all so very much for making what Steve wanted come true.
So let's do one last thing to close this out. One more round of applause, but I want it loud enough that Steve can hear it. So welcome. Thank you all for coming. We love you. We appreciate you, and you will always be part of this family. Thank you.